Sir, can we start now, sir? Because 30 are there.
Sure, madam.
We will let the others join us. In the...
Sure.
Jane?
Good morning, everyone. Thank you all for joining in today for the second day of our CARE-PARE event. Hope you had an inspiring first day. Today's first session will be Rajendran sir. It is my pleasure to welcome you back, sir. Sir delivered an insightful presentation yesterday, and I hope all of you are excited for sir's second session today. Over to you, sir.
Then make me as a co-host, Jane. I'm not able to share.
Sorry, sir. I'll make you co-host, sir.
Sure. Super. Can you hear me well? Can you see the slides?
Yes,
Yes,
sir.
we can hear you. Your slides are quite visible.
Sure. Good morning, everyone.
Thanks,
Thank you
sir.
for coming for the day 2. And this is the slide I showed yesterday. Just to recap, the pancreatic tumors are mainly divided into primary and secondary. In the primary tumors, it's exocrine and endocrine. In the exocrine, we are in the new WHO, they deal only with epithelium. The stromal tumors, they put separately. So we are talking only epithelial tumors that can be divided into benign, pre-malignant, malignant. Benign is acinar cystic transformation, where a lot of cystic spaces lined by both acinar and ductal cells. That is very, very important to understand. Previously, it is called as acinar adenoma, cystic adenoma, but now they are telling it is not a not a neoplasm. It's a non-neoplastic condition. That's why they changed the name into acinar cystic transformation. Second one is serous cystadenoma. Radiologically and grossly, it has a characteristic picture like a sponge, and microscopically, it is lined by clear cells that are loaded with the glycogen and a VHL gene and VHL syndrome associated with that. So the VHL protein will be positive in immunohistochemistry. Coming to pre-malignant, we talked about PANN, IPMN, IOPN, ITPN, and MCN. Other than MCN, all the 4 are connected with the duct, and the PANN is non-palpable, less than 0.5 centimeter. Again, we have to divide them into low grade and high grade. I went through the features or criteria for low and high grade. Then IPMN, it's a visible more than 1 centimeter lesion, mainly arising in the major ducts or can arise in the minor ducts also. And it has 3 morphological types. Histologically, it can show gastric foveolar epithelium, intestinal epithelium, and pancreaticobiliary epithelium. IOPN is intraductal oncocytic pancreatic neoplasm that shows intraductal oncocytic proliferation. And the fourth member in that group is ITPN, intraductal tubulopapillary neoplasm, and that will have more solid intraductal growth with a lot of tubule formation with focal papillary formation. And madam, yesterday you asked me the prognosis. I told bad, but I checked. ITPN is having relatively better prognosis than IPM.
Thank you, sir.
And molecularly, IPMN is associated with the GNAS, whereas ITPN won't show GNAS. And the last member of the pre-malignant is mucinous cystic neoplasm. Please remember, it happens only in females. It's similar to ovarian stroma we can see just beneath the lining epithelium. Again, it can be low grade and high grade. Malignant, we covered the ductal carcinomas and all the patterns of ductal carcinomas. And from today, we will see acinar cell carcinoma, solid pseudopapillary, pancreaticoblastoma, and then all the endocrine tumors. Acinar cell carcinoma, this you can see a very nice picture of fleshy growth and with lobulations and septae. It's in the tail of the pancreas, so it is invading into the spleen. Microscopically, it shows a very well circumscribed tumor made up of pink cells with indistinct cell border and round to oval nuclei with the prominent nucleoli. And you can see the prominent nucleoli in them. You may confuse it with oncocytoma, but oncocytes won't show this prominent nucleoli, and chymotrypsin will be positive in acinar cell tumor. Again, it can be classically solid, cystic, and it can be mixed with a neuroendocrine tumor and ductal carcinoma. In well-differentiated tumors, we can see the nice acinar formation with more uniform cells. That you have to keep it in mind. In addition to trypsin, chymotrypsin, this will also be BCL10 positive. And since madam asked, I checked the literature, they are telling glypican also is positive in acinar cell carcinoma. Pancreaticoblastoma, it happens in young age group. It's like a Wilms tumor, so it will have epithelial and stromal component. The epithelial component can be primitive, can be ductal, can be acinar, can be neuroendocrine, and squamoid eddies are very, very characteristically seen in pancreaticoblastoma. The stroma can be homogeneous or heterogeneous. Here you can see primitive cells from the pancreatic tumor, and you can see the nice squamous nest here, and you can see the squamous nest and more primitive cells in the background trying to form a acinar pattern. And these cells are classically beta-catenin positive and can be also trypsin positive. Remember, I told you these are multi-lineage tumors. It can be ductal, it can be acinar, it can be neuroendocrine, it can be embryonal. So trypsin will be positive, and beta-catenin, normally they are seen in the membrane. Whereas when you want to call beta-catenin positive, it has to be seen in the cytoplasm and nucleus. I will show you a normal picture when we talk about solid pseudopapillary tumor, which is the next. The other name is Gruber-Franz tumor, because in the quiz they may ask you what is Gruber-Franz tumor. So it is nothing but a solid pseudopapillary tumor. And you can see solid areas and papillary areas. These are not real papillae. All the cells in between these papillae are disc cohesive and they shed. That's why it looks like papillary. Really, it is not papillary. That's why it is called pseudopapillary. And high power, it is characteristic having coffee bean nuclei. See the nice coffee bean nuclei. And another interesting features is the hyaline globules. They produce intracellular and extracellular hyaline globules. This is what I am telling. This is the normal pancreas adjacent to solid pseudopapillary tumor, and normal beta-catenin will be membranous positive. So you cannot call it beta-catenin positive. This is normal pattern. Whereas here it is both in the cytoplasm and in the nucleus. So this is beta-catenin abnormal expression. This is normal expression. This is abnormal expression. In addition to pancreaticoblastoma, the solid pseudopapillary tumor also shows beta-catenin positivity, and it has characteristic progesterone receptor positivity and the CD10 positivity. Now we are entering into the exciting area of neuroendocrine neoplasms. Whatever I am talking about neuroendocrine neoplasm in pancreas more or less suits all the other organs. It's mainly divided into well-differentiated and poorly differentiated. Well-differentiated neuroendocrine neoplasm is called as neuroendocrine tumors, and they are graded into 3 grades, grade 1, 2, 3. Whereas poorly differentiated neuroendocrine neoplasm is known as neuroendocrine carcinoma, and there is no need to grade them because they are always grade 3. In addition to this neuroendocrine per se, they can be seen with mixed non-neuroendocrine neoplasm. So it is called MINN, mixed neuroendocrine, non-neuroendocrine neoplasms. Okay, and these numbers we will see it in the next slide. This is the pyramid you have to remember. The mitotic rate and Ki67 index is very, very important in neuroendocrine tumors. When you want to call neuroendocrine tumor, the mitosis should be less than 2 and the Ki67 index is less than 3. To call it grade 2, the mitosis should be 2 to 20 and the Ki67 3 to 20. and G3 more than 20 mitosis and more than 20% Ki67 positive. And I always tell my postgraduates, remember the middle one. Grade 2 up to 2 to 20 mitosis and 3 to 20 percent Ki67. If it is less than that, it is grade 1. If it is more than that, it is grade 3. Always remember the middle. And when you talk about grade 3, you may be thinking how to differentiate it from pancreatic neuroendocrine carcinoma, because that is also grade 3, even though there is no need to grade. We have to do P53 and retinoblastoma IHC. They are negative in pancreatic neuroendocrine tumor, but they are abnormal in pancreatic neuroendocrine carcinoma. In addition to that, DAX and ATRAX are positive in neuroendocrine tumor in addition to MEN1 protein, whereas KRAS and SMAT4 also positive in neuroendocrine carcinoma in addition to TP53 and retinoblastoma gene. This understanding is very, very important. So, and it captures in a nutshell the whole classification of neuroendocrine tumor. Well differentiated, poorly differentiated. Well differentiated is known as neuroendocrine tumor. It is graded into 1, 2, 3. Poorly differentiated is known as neuroendocrine carcinoma. This distinction of grade 3 neuroendocrine tumor and pancreatic neuroendocrine carcinoma is very, very important, because the pancreatic neuroendocrine carcinoma has a very bad prognosis. So when you are starting the mitotic count, you have to go to the most active area and you have to calculate 50 high power field, but now they are telling in millimeter square. And when you count for 50 high power field, then you make them divided by 5 and make it into 10 high power field. Ki67, you have to count in 500 cells. What they do is they manually print out the tumor, and then what are all the Ki67 positive, they will just calculate and calculate the negative cells in the background, and thus they come up with the percentage. It is very cumbersome to do it manually, and artificial intelligence is going to help you wherever you are counting. For example, Hartunium scoring, ERPR scoring, Ki67 scoring. In a couple of years, artificial intelligence will be of great help. It's already the Western countries, they already started doing it. Probably in 5-6 years time in India, we will be doing artificial intelligence in all the quantitative pathology. Just want to show you the picture of people who are all behind this hard work about neuroendocrine tumors. David Punstra from Memorial Sloan Kettering is leading with all the other doctors. I don't want to pronounce their name. Probably I may kill by pronouncing them wrongly. The main difference between well-differentiated neuroendocrine tumor and neuroendocrine carcinoma, hormone expression, hormonal syndromes, and hereditary syndromes are seen in neuroendocrine tumor. They are not seen in neuroendocrine carcinoma. This is one of the nice grass picture. Because of that, I took this slide, and it shows pancreatic neuroendocrine tumor here and a nice intravenous emboli, and this is ATRAX mutant, and see how nicely the histological sections are showing that neuroendocrine tumor emboli in the vein. So this is just for example how to grade them. G1 1%, G2 10%, G3 32, more than 70%. Just keep this in your front of the microscope, and when you are doing, you just see where this belongs to. And remember, Ki67 should be 2 to 20. If it is less than 2, it is grade 1. If it is more than 20, it is grade 3. The interesting terminology, Minan, you have to have a very crystal clear idea. Before going into Minan, when you see two tumors separately, they are known as collision tumor. When you see two tumors mixed with each other, they are known as mixed tumors. And mixed tumors, either component can be prominent. Here, neuroendocrine component, the red one is the neuroendocrine component. It can be neuroendocrine component predominant in this end, whereas non-neuroendocrine component predominant in this end. But when you see a cell that has both endocrine and non-neuroendocrine features, like a goblet cell carcinoma, it is known as amphicrine tumor. So you must know the definition of collision tumor, mixed tumor, and amphicrine tumor. When you come to mixed tumor, remember this person, 30. To call it mixed tumor, each component should be more than 30%, but less than 70%. Okay, so it should be more than 30%. The understanding of the terminologies are very, 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 very important, and it is the same for all the organs. So this is a neuroendocrine tumor, nice neuroendocrine tumor in the body of the pancreas, and it may show some cystic changes also. Here there are multiple tumors. It is associated with MEN1 syndrome. And this is the morphological picture. It can be seen as nests or it can be seen as ribbons. And the microscopically high power picture is very, very important. See, the cells are more or less uniform and they have the characteristic salt and pepper chromatin pattern. And some of the cells may look plasmacytoid. So the salt and pepper chromatin pattern and plasmacytoid cells are a classic of neuroendocrine tumors. And it may produce serotonin and that create a lot of sclerosis, or it can produce some proteins that are arranged in beta pleated appearance and gives rise to amyloidosis. For example, insulinoma can create a lot of insulin that gets malformed and form amyloid. So this is a grade 1 neuroendocrine tumor. Remember, we divide them into functional and non-functional. Functional, it can be glucagon, it can be insulin, it can be somatostatin. Morphologically, we cannot differentiate except somatostatinoma. In somatostatinoma, you see a lot of somoma-like calcifications. So in any neuroendocrine tumor in the pancreas, if you see a lot of somoma bodies, it is a diagnostic of somatostatinoma. Neuroendocrine carcinoma, grade 3, it can be divided into small cell and large cell. Small cell is similar to small cell carcinoma of the lung. Crush artifact, a lot of apoptosis and mitosis, but because of the hyperchromatic nuclei, you may not be able to see the mitosis. And this is a large cell neuroendocrine tumor with a minor component of small cells. As I told you, the markers are very important to differentiate neuroendocrine tumor grade 3 and neuroendocrine carcinoma. P53 is abnormal in neuroendocrine carcinoma. The lower one is neuroendocrine carcinoma. So it is abnormal in neuroendocrine carcinoma. Retinoblastoma gene is abnormal. It is lost in neuroendocrine carcinoma. And SSTR2A is positive in neuroendocrine tumor. So let us see the pictures. This is neuroendocrine tumor grade 3. This is neuroendocrine carcinoma. K67, even though both are having more than 20%, the neuroendocrine carcinoma will have 70 to 80 to 100%. Okay, very highly mitotically active. TP53 is abnormal in neuroendocrine carcinoma. And this picture shows a neuroendocrine tumor grade 3 that is positive for SSTR2A, 3+ positivity. Whereas the SSTR2A positivity become less in neuroendocrine carcinoma. That you have to remember. So how to use MINAN? The summary slide, identify the two components by morphology, confirm it by immunohistochemistry, classify the two components by morphology and immunohistochemistry, for example, Ki67 to grade the neuroendocrine tumor. Then quantify the components. You have to have more than 30% of the components to call it mixed neuroendocrine, non-neuroendocrine carcinoma. This is the best example. You can all identify the serous cystadenoma, and here it is neuroendocrine tumor grade 2, which is positive for neuroendocrine marker synaptophysis. This is a duct formation and neuroendocrine. So it is adenocarcinoma, neuroendocrine carcinoma. Grade 2. This is a classic nice picture. This is more like acinar cell carcinoma, whereas here it is neuroendocrine carcinoma. So synaptophysin should be positive here and trypsin should be positive here. And this is trypsin positive in acinar component, and this is synaptophysin positive in the neuroendocrine tumor component. So we have 5 more conditions in addition to the tumors: acute pancreatitis, chronic pancreatitis, autoimmune pancreatitis, pseudocyst, and nesidioblastosis. Acute pancreatitis, nobody excises it or nobody biopsy it. Most of the time we see it in the autopsies. These pancreas are from autopsies. It shows extensive necrosis, and microscopically you see the saponification. The pancreatic enzymes, they come out and they auto-digest the adjacent structures and produces soap formation with the calcification with the extensive necrosis and neutrophilic infiltration. Chronic pancreatitis is very, very important because the chronic pancreatitis, sometimes it may look like tumor, and microscopically also it may look like tumor. We have to be careful. This lobular pattern in the low power is very, 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 very important to diagnose chronic pancreatitis. If you go individual cells, they may look malignant, but this lobular pattern is very, very important. What happens in chronic atrophic pancreatitis? A lot of the acini and the duct system undergo atrophy, whereas the endocrine component may be present as nests or individual cells in a sclerotic stroma. That's where it looks like malignancy. Here you see, even here it is seen around the neural bundle. So we may think this is carcinoma. But when you do the neuroendocrine marker synaptophysin, all these cells are positive for neuroendocrine tumor. So chronic pancreatitis is a greatest mimicker of carcinoma grossly as well as microscopically. So you have to be very, very careful. Autoimmune pancreatitis, there are 2 types, type 1 and type 2. Type 1 is known as IgG4 disease, where serum IgG4 elevated, and you see 3 characteristic features: lymphoplasmacytic infiltration, storiform fibrosis or lamellar fibrosis, and obliterative phlebitis. These 3 triad is very, very important for type 1 acute pancreatitis, whereas type 2 acute pancreatitis, we call it gel, granulocytic epithelial lesion. I will show you the picture. Both are responsible to steroid, okay, 100% responsibility. And this type 1 autoimmune disease can involve other organs, and type 2 autoimmune disease usually associated with inflammatory bowel disease. So grossly, it may look like a tumor, but microscopically, it's a lymphoplasmacytic infiltrate, storiform sclerosis, and phlebitis. This is the triad you have to remember. See here, it can be ductocentric and lobulocentric. And microscopically, you see around the ducts, lot of plasma cells and lymphocytes, and see a major artery. And in here, there's a vein that shows inflammation and obliteration. So this is a phlebitis. And microscopically, you can see the lamellar fibrosis. And see, this is the artery. Sometimes in the H&E, it's difficult to identify the phlebitis. So elastic tissue stain may highlight the phlebitis component. And when you do IgG4, it will be more than 50%. Type 2 autoimmune disease, it's again ductocentric, and it shows a lot of neutrophils that are going into the epithelium. That's why it is known as granulocytic epithelial lesion, gel. Remember any gel you use, okay? Gel is type 2. Coming to pseudocyst, again, nobody biopsies or excise the pancreas. Most of them are autopsy findings. This is a cystic space with extensive necrosis, and it won't show any definitive lining epithelium. Again, it will look like acute pancreatitis, fat necrosis, and saponification. Nesidioblastosis is a condition where there is a ductocentric neuroendocrine cell proliferation. Here in this hyperwire, you can see very nicely a duct, and the neuroendocrine cells are proliferating around the duct. This usually happens in infants of the diabetic mothers. The insulin from the mother stimulates, the lack of insulin stimulates the neuroendocrine cells in the babies. Nesidioblastosis. When you do synaptophasing, you can identify the increased number of neuroendocrine cells. Now we are coming to immunohistochemistry in pancreas. These are the 7 conditions where immunohistochemistry will be helpful. I told chronic pancreatitis and ductal carcinoma can be very, very difficult to identify. And in those cases, VHL, MASPIN, S100P, and IMP3 will be very, very helpful. For pancreatic neuroendocrine tumors, chromogranin, synaptophasin, PGR, and PAX8. But insulinoma-associated protein, INSM1, I think Kundavai's thesis is on that. That is the new marker that is excellently positive in neuroendocrine tumor of any organ. So that's one of the new markers you have to get. And it is a nuclear positivity. So it's very, very easy to interpret. Acinar cell carcinoma, trypsin, glypican 3, and BCL10. To differentiate IPMN from mucinous cystic neoplasm, stromal estrogen and progesterone receptors. To differentiate solid pseudopapillary tumor from others, we have to do CD10, beta-catenin, nuclear and cytoplasmic positivity, and PGR. For plasmablastoma, trypsin, beta-catenin, and synaptophasin. For serous adenoma versus others, I remember I told you serous adenoma associated with von Hippel-Lindau. So PVHL and MUC6 will be positive, and inhibin A will be positive. For completion's sake, I am putting this table, various types of mucin stains, but to me, they are not very, very useful. But in the exams, they may ask you. The only important thing I see here is in ITPN, the MUC5AC, MUC5 is negative, whereas it is positive in all the other types. That's the only significant thing I understand. This is a very, very important, practically useful slide. You have to keep it in your working area. So you'll see some pictures. VHL gene is present in the normal pancreas, whereas absent in the pancreatic carcinoma. The opposite is good for MASPIN and S100P. This is different S100 when compared to the melanoma marker or neural marker we do. They are positive in the malignant ductal cells. Neuroendocrine tumor, progesterone receptor, PAX8, chromogranin, synaptophasin, and see the new marker, INSM1, crispy nuclear marker. For adenoid cystic carcinoma, it is trypsin, BCL10, and glypican 3. For IPMN versus MCN, ovarian type of stroma that are positive for ER and PR. For SPN, we already saw this picture, beta-catenin, normal membranous expression, abnormal cytoplasmic and nuclear expression, positive for progesterone receptor and CD10 in solid pseudopapillary tumor. For pancreatoblastoma, it's a multilineage. All the markers will be positive. Cytokeratin, trypsin, chromogranin, alpha-fetoprotein. And the squamous nests are very characteristic. You have to remember in pancreaticoblastoma. For serous cystadenoma, it is a VHL gene, and the MUC6 can also be positive. Coming to frozen section in pancreas, only 4 things they want to know. Is there a lesion in the pancreas or in the tissue submitted for us? Is it benign or malignant? If it is a resection, is the tumor present in the margin? And if it is a lymph node, is there any metastasis? These are all the answers they want from us. And you can freely communicate with the clinicians. What do they want to know? For example, margins, in addition to tumor, they are interested in low-grade dysplasia. For example, it can be a carcinoma associated with PANIN or IPMN. And that IPMN at the resection margin may show low-grade dysplasia or high-grade dysplasia. But when you say it is high-grade dysplasia or carcinoma at the margin, they will go for further resection. And you have to remember the major and minor criteria for pancreatic carcinoma to apply strictly in frozen section. Nuclear size variation, incomplete glandular lumen, disorganized duct distribution, no lobular pattern, very, very important. That's a major criteria. Minor criteria are huge irregular epithelial nucleoli, necrosis, glandular mitosis, glands unaccompanied by stroma in the smooth muscle fascicles, and perineural invasion. Coming to grossing of pathology, it can be a Whipple's resection or it can be tail of the pancreas with the spleen. And this is the easiest specimen. Just take one resection margin from the cut surgical end. And many people ask me, what is resection margin? Wherever knife has been placed to cut from the body, it is the resection margin. So this is the only resection margin here. Whereas these are known as radial margins. They are floating in the retroperitoneum. Surgeon never uses knife to separate the upper and lower portions of pancreas. Once they cut the pancreas and free the spleen, it comes out as the specimen. So this is the only resection margin. And you may ask me, what happens if the tumor is there in the radial margin? You just tell in the report, tumor is present in the radial margin. The possibility of going into retroperitoneum and peritoneal cavity is high when it is in the radial margin. But when it is in the resection margin, definitely tumor is there in the patient. Coming to Whipple resection, many people think it's difficult, but it is very, very easy. It has a C-shaped intestinal portion that can be proximally pylorus of the stomach or the duodenum. So this will be the proximal margin, and this will be the distal duodenum or early portions of jejunum. So proximal margin, distal margin. Then you have to identify the common bile duct. This common bile duct is another resection margin. And then you trace the common bile duct into the pancreas, and most of the tumors are around the common bile duct. And this is the resection margin of the main pancreatic mass, and this is for the Asner process, because big blood vessels, they come in this area. Okay, so the surgeons has to use the blade to release it from the bigger blood vessel. So this is one of the margins. So there are proximal margin number 1, distal margin number 2, common bile duct number 3, primary pancreatic body number 4, and uncinate process number 5. There are 5 resection margins. And then you describe the tumor, take the tumor along with the duodenum, along with the ampulla, and along with the adjacent pancreas, and look for lymph nodes. And when you see lymph nodes, you group them. For example, this is a superior pancreatic, this is inferior pancreatic. Like that, you have to classify the lymph nodes. Cytology of pancreatic lesion, it's a very big topic, but the terminologies used are non-diagnostic, negative, atypical, suspicious, positive, and then neoplastic. These are all the terminologies used. And what are the criteria? Again, major criteria: overlapping nuclei, irregular nuclear contour, chromatin clearing or clumping. You have to see either 2 or more major, or 1 major and 3 minor criteria. And the minor criteria are single epithelial cells, necrosis, mitosis, and nuclear enlargement. Please remember this for cytology. What are all the things you have to mention in the final report? You always follow the CAP protocol. CAP has 2 protocols, one for exocrine pancreas and the other one for the endocrine pancreas. In a nutshell, you have to mention tumor site and size, histological type and grade, microscopic tumor extension, margins, lymphovascular space invasion, perineural invasion, and PTNM staging. If there are any additional findings, you have to mention. If you have done any ancillary studies, you have to mention. Many patients may undergo neoadjuvant chemotherapy before surgery. In those cases, you have to mention the post-treatment effect. Coming to the last part of our talk, molecular events, it's very, very important to understand the molecular events in pancreas. So we have to divide them into solid tumors and cystic tumors. KRAS mutation, CDKN2P16 inactivation, TP53, and SMAT4 inactivation. These are all the 4 major changes that are seen in the predominantly in the solid pancreatic carcinomas. And they have both diagnostic, prognostic, and theranostic, where, for example, KRAS mutation can have potential therapeutic target. So these molecule changes are very, very important for targeted therapy or tailored therapy. And these are all just for completion, not very characteristically seen in all tumors. Take a picture of this. Coming to the cystic tumors, IPM1, I told you KRAS and GNAS. GNAS is very, very important. Mucinous tumors, KRAS and RNF43. Serous cystic neoplasm, as I told you, von Hippel-Lindau. Solitary pseudopapillary neoplasm, beta-catenin. So these are all the classic molecular changes. Again, they dictate the prognosis, theranosis, and sometimes they may help in the diagnosis also. For example, pancreatic cystic fluid, if it is GNAS positive, it is diagnostic of IPM. So that brings the end of our discussion. The key points you have to remember: the histology of solid neoplasms and cystic neoplasms, pancreatic neuroendocrine tumor, salt and pepper chromatin pattern, the solid pseudopapillary tumor, coffee bean grooving and hyaline globules, Hussener cell carcinoma, prominent nucleoli, pancreaticoblastoma, very early age group, multilineage and squamoidness. Coming to the key features in cystic neoplasms: pseudocyst, no lining epithelium; mucinous cystic neoplasm, mucinous lining epithelium with ovarian stroma; IPM1 connected with the duct, and it's again mucinous with gastric, intestinal, or pancreaticobiliary type. And this is the only cystic neoplasm connected with the duct. Serous cystadenoma, clear cells and complexes and VHLG. And grossly, you have the characteristic picture. Once you see the serous cystadenoma, you don't need any ancillary studies. So these are my references. See, most of the pictures are by Atul Singh. He is now in University of Pittsburgh, but previously he was in John Hopkins. I think he played a major role in the app. John Hopkins has 10 apps, including pancreas. So you have to get all of them. Unfortunately, they are available only for the iPad, okay, not for the Android users. So please get, I think each one of them cost you 100 rupees. So they have beautiful pictures. So you have to get all the 10 apps in the iPad from the John Hopkins. Just go to App Store, put John Hopkins Pathology, and you can locate these 10 apps. Manual of Surgical Pathology by Susan Lester. This is the Bible for you for grossing and how to do reporting and how to solve issues in anatomic pathology. And WHO Blue Book, CAP protocol, and very importantly, pathologyoutlines.com. So these are all my references. And more importantly, I want to talk about another very, very important thing, perplexity. That is the artificial intelligence. What is the time, madam? Can I just spend 5 minutes, madam, on this perplexity?
Sure, sir. Even 10 minutes is there. No problem.
Yeah. Yeah. Perplexity is where I will show you the magic of perplexity. So just go to internet, type in perplexity.ai, and whatever you want, you can type. You may think it is very similar to
Research.
okay, but I will ask one of you. Madam, you ask one of you to tell something to search. I will type it in. Let us just have a, because if I type something, you may think I already worked on this. So I want to.
Okay, postgraduate, one of you volunteer to tell something for sir to type.
Anything. What are all the movies released in Diwali 2024 in Hindi, Tamil, pathology of pancreatic neoplasm, whatever you want. Madam, if you ask anybody, nobody will ask.
Okay.
You ask a name.
So somebody has already sent, sir, SMRCB1 deficient tumors.
Yes, some more.
CB1.
CD1.
B. SMRCB. B for Bombay.
B. SMRCB1.
Deficient tumors.
Okay, just click it. See, this is how it will tell you the answer. See, the Google just tells all the journals, articles, web pages where it is present. But this Perplexity, not only Perplexity, but this is the best site which I use. But any AI search engine, it will go through all the literature, and it will pull up and it will give you the answers. For example, here, who is the person who asked Madam, ask them to read this.
I think it was Swati.
Swati, can you see what is here? You read, ma.
Dr.
Madam,
Swati.
mute her mic, madam. Probably you might have
We
muted.
can mute ourselves, sir. Dr. Swati. I think she is not able to.
I've asked her to unmute, ma'am.
Because I can read, but then it is will be very monotonous. I want the person who asked the question to read.
Swati, can you please unmute yourself?
Yeah. Malignant rhabdoid tumors, atypical transitional
From the
rhabdoid
answer.
tumor.
Swati,
Start from answer.
Okay. SMARCB1 deficient tumors are a group of rare cancers characterized by the loss of function of SMARCB1 gene, which is an important tumor suppressor. Hence, an overview of these tumors. Tumors of SMARCB1 deficient cancers are SMARCB1 deficient cancers can occur in various locations and affect both children and adults. Mainly malignant rhabdoid tumors, atypical tetroid rhabdoid tumor, renal medullary carcinoma, epithelioid carcinoma, pediatric poorly differentiated chondroma.
Swati, read
Ah.
properly. Check your eyes. It is epithelioid carcinoma. It is not epithelioid carcinoma. I will kill you if you read wrongly.
Yeah, sorry, sir. Epithelioid sarcoma, pediatric poorly differentiated chondroma, synovial sarcoma,
Chondroma.
chondroma, sorry.
Cardoma, not chondroma.
Chondroma. Synovial sarcoma, myoepithelial carcinoma, sinonasal carcinomas, schwannomatosis, and cribriform neuroepithelial tumor. Some of these tumors like MRT and ATRT are more common in children, while others can occur in adults. Molecular characteristics. The key features of SMARCB1 deficient tumors is biallelic loss of function in both SMARCB1 alleles. This typically occurs through deletion, mutation, epigenetic alterations. The SMARCB1 gene is located on chromosome 22q11.2 and is a critical component of the BAF chromatin remodeling complex. Clinical significance. SMARCB1 deficient tumors are generally associated with poor prognosis, particularly in pediatric cases. They are characterized by aggressive behavior, rapid growth, limited treatment options, high mortality rates. However, some SMARCB1 altered conditions like schwannomatosis have better outcomes. Diagnostic challenges. Diagnosing SMARCB1 deficient tumors can be challenging due to rarity of these tumors, histological variability, potentials for misclassification and immunochemistry in INI1, SMARCB1 protein expression, and molecular testing are crucial for accurate diagnosis. Therapeutic implications. Understanding the molecular mechanisms of SMARCB1 deficient tumors has led to potential therapeutic strategies like targeting aberrant enhancers and promoter regulation, exploring MYC inhibition as SMARCB1 loss can lead to increased MYC activity. And the third point is investigating epigenetic therapies, considering autophagy inhibitors or proteasome inhibitors in clinical trials. Research directions. Current research focuses on developing more effective targeted therapies, understanding the epigenetic mechanisms involved in tumorigenesis, exploring the role of SMARCB1 in a different cellular contexts, improving diagnostic accuracy and classification of these tumors. In conclusion, SMARCB1 deficient tumors represent a diverse group of rare cancers with significant clinical challenges. Ongoing research aims to improve diagnosis, classification, and treatment options for patients affected by these aggressive malignancies.
Are you happy, Swati, with this
Yeah.
answer?
Yes, sir. Yes, sir.
How long will it take for you to get all this information from Google? You have to go through individual papers and you have to write your own summary. See how artificial intelligence has done it very nicely. And more importantly, you see the numbers, these are the references, and they give the references here. Okay. If you are not happy with this answer, you can ask it to rewrite. Okay. So it will rewrite it again. And you can share this link, you can copy and paste somewhere, and you can edit the query. Okay. So do you love this, Swati?
Yeah, yes, it is quite good.
Hereafter, it is not quite good. It is soundly good. Okay.
Yes, sir. Yes, sir.
So I think people should stop using Google. They should start using.
Sir, actually, the younger generation has started using they're using only Perplexity now. In my house, my kids are using only Perplexity. I am the only one who is still doing Google search.
Yes, madam. But our pathology PGs, they are not using. That is the problem.
Exactly.
And I want to show you one more thing. I have one Telegram group. I don't know how many of you are members. I'm
We're
pretty
all
sure.
members, sir.
Yeah, you are all members, but how many of you see
Books,
it
sir.
every day?
Books are there. Telegram books, sir.
No. In Telegram, I have my phone. Kundavai may be knowing it. She is the member, but she is not using it. That's a reason. So I have a group and we have 1744 members. I publish one case every day, interesting cases. See, I shared this conference also in that site. And for example, 24th October, 57-year-old female, acute abdominal pain. So this is a gallbladder. All the veins are stuffed with the tumors. The tumor is having hepatocellular component or hepatocellular morphology. So this is a poorly differentiated carcinoma, hepatocellular carcinoma with metastatic HCC. The main reason I put this, there is a new marker called serum PIVK2. I don't know about this, so I asked Perplexity, and this is the answer I got. You also remember, all the participants, please remember this serum marker. This is very, very characteristically positive in HCC, especially when alpha fetoprotein is negative. So like that, I share interesting cases every day. And if you want the link, you can get it from Kundavai. Kundavai, share it with all the people, ma.
Thank you, sir.
All of them become members and not using it every day. Okay, Kundavai? And when I talk to people, I ask them, are you seeing it daily? They say yes. And then I ask them, what is the case I published today? So don't lie to me. I will check on you because I can see who all seeing every day and who is seeing occasionally. So happy Diwali to 2024. And I always have this request for you. 2000 ரூபாய்க்கு துணி எடுத்தா அட்லீஸ்ட் ஒரு 100 ரூபாய்க்காவது கோஆப்டெக்ஸில் 2 கைத்தறி வாங்குங்க. ஸோ தட் ஒரு ஏழை வீவரை யூஸ் பண்ணலாம். ஃபார் பீப்புள் ஹூ டோன்ட் அண்டர்ஸ்டாண்ட் தமிழ், let 5% of our dress purchase for Diwali be from weavers to support them.
Yes, sir.
Thank you
Very
so
true.
much. And
Thank
that and if you have questions, please ask me.
I have two important statements to make, sir. Today I learned most important things about frozen section, the major and the minor criteria, because that is always a problem for us to give a diagnosis. At least tell them whether it is malignant or benign when we get a frozen section from pancreatic tumors. That was a great learning point for me. I have boldly written it down and I have taken a picture. I've also already typed in my notes and kept in my laptop itself, because
Super, ma'am.
that is one definite area of deficiency for me when I do frozen section. Thank you so much for that, sir.
And
And
you use
cytology,
perplexity, madam. Wherever you have questions, you use perplexity. For example, we will check. I have not checked it. Criteria for pancreatic malignancy in frozen sections. See, if you are not getting the right answer in perplexity, it means you are not asking the right question. Okay. So you have to keep on asking until you get the right question. You have to keep on changing your question. Criteria for pancreatic malignancy in frozen section. Let us see what perplexity says. Dun, ta-da. Do you like it, madam? All the correct.
yes, sir. Yeah. Thanks, sir.
So, madam, whatever question you have, please ask perplexity.
Sure,
Okay.
sure.
Example, I will ask new movies, new Tamil movies, Diwali. Sorry for taking your time. This is just to show you the power of the Amaran, brother, bloody beggar. Okay, since I put Tamil movie, many people may be telling me, the Lucky Bhaskar is not there, but I typed Tamil movie. Okay, so Lucky Bhaskar is a pan-Indian movie. I don't know how many of you saw the trailer of that. My thing is, you must enjoy life. You must see a lot of movies. If you don't know interest in movie, you cannot do pathology very well. It's my personal opinion. Thank you, madam. Yes, madam.
So second point, sir, I have
Hmm.
between high grade NET and NEC, that is again another major issue for me. So we have only P53 and we can do CARE-PARE. I don't have SMAD and I don't have RB. So is these two are enough for me to differentiate between these two markers?
Madam, nowadays, madam, instead of doing only one ISC, just send it for panel of molecular, because
Okay.
that is getting more cheaper.
Okay.
So please don't try to do molecular in your hospital. We cannot make money. Because
Yes.
the amount of pancreatic tumors we are getting every day, in Ramchandra, I may get 1 or 2 per month. How can I run molecular lab? That's why all the molecular labs started in institutes have failed, whereas commercial entities are thriving very well because they get from many hospitals. And the minute you ask open in one hospital, other people won't send it to you. For example, if you open a molecular lab and ask Ramchandra Pathology to send it to you, the management might, you know, the politics there. Okay? So, because many people ask me, sir, why can't I start a molecular lab? Not in the college or hospital. If you
Yeah.
want to do it outside the campus as a individual company, not as a.
Yes,
So
sir.
instead of doing only one IHC marker, madam, now you send it for panel of molecular.
Okay. Sure, sir. Thank you, sir. Thank you so much.
Any other questions, madam? Anything in the chat box?
There's not a question, sir. Dr. Subhashri has said you are a great teacher and you can never keep anything good to yourself, sir. Perplexity was new to me. The session was really good.
But I think Subhashri is my student from Pondicherry. Is it that Subhashri or different Subhashri? I don't know. Subhashri, is it the same Subhashri?
Yes, sir.
Super, ma. Thank you, ma.
Okay,
I
sir.
learned many things from you.
Okay,
You
thank
are all
you.
my teachers. All my students are teachers. I learn from you all. Thank you.
Thank you, sir.
Thank you, sir.
Thanks a lot for all your effort and time. And without hesitation, the moment I send a request in WhatsApp, you're there to accept it. And that's, I mean, I consider it as a great privilege and pleasure to myself. Thank you so much, sir. And I won't stop with this. I'll keep disturbing you every year.
Sure, madam. The why I am coming for these conferences without hesitation, it keeps me reading. I learn a lot when I am preparing.
Exactly,
So
sir.
I love to talk, and Subhashri knows that. Once I start talking, I won't stop. But
I
now
think the
I'm
entire India and globally, they know, sir, that you love to talk. You're a great teacher.
yeah. Thank you, madam. Have a great day.
Thank you so much, sir. Happy Diwali to you, sir.
Welcome, madam. You
Thank you, sir.
eat some extra jangri. I love jangri, but I cannot make it here in US. So
We will
you,
pass.
all of
Swiggy,
you,
sir.
Swiggy US வராது. All of you eat one piece of extra jangri on behalf of me. And don't
Sure, sir.
forget to get the cotton waved cloths from
Yes.
Cooptex.
Yes, sir.
And buy many crackers and enjoy. Don't worry about the environment. They are having
Yes,
war
sir.
in Russia and Ukraine. They are having war in Israel. They are not worried about that. But they are worried about crackers in Diwali. It's utter bullshit. Okay.
One corner of the world, that too.
Yeah. So let people who produce crackers in Sivakasi enjoy life.
Yes, sir. Sure. Thank you, sir. Thank you so much.
Bye. Have a great day.
Yes.
Thank you.
Thank you, sir.
Thank you all.
Thank you, sir, for being so gracious. Now we'll go on to our next speaker. Pradeep, sir, was here yesterday. Sir, thank you for accepting our invitation. Over to you, sir.
Good morning. Am I audible?
Yes, sir.
Yeah, I think my voice has become slightly better today.
Good morning, Dr. Pradeep. Thank you
Yeah, good
again.
morning.
Good
Good
morning.
morning. Good morning, ma'am. So is my presentation visible?
Yes, sir.
Visible.
Yeah. So thanks for this topic, and thanks for having me here. And this is quite a bit of comfortable topic for me because this is what we practice day in and day out. So let's try keeping it interactive again, and I think I have 45 minutes, so let's try finishing it. But if at all, if I'm going slow, we'll be skipping a few cases. But for that, the participants have to be interactive. So let's get ahead. I don't know, it's not moving. Yeah, so my sincere gratitude to you all and people way back here at Anand. So we have this MCQ right now. What is it doing? You can unmute or you can type it in the chat box and you can tell me the responses. I won't be able to see the chat box, I think so. How many of you are for option one is trying to speak to a teammate? Or how many for two, option three and option four?
Option 3.
Option three. Okay. So anyone else? You can just type it in the chat box, whatever you feel. It's a MCQ, so you need not type in the entire sentence. Okay, I think there's some. Okay, most of them are saying 3. Okay, so we'll come back to that as usual. So this is about the cell counter. So I actually thought we'll modify things a bit about the topic was a peripheral smear being a window, but I think we will start with how cell counter can be a window when we are looking at the peripheral smear, and this how accidentally a cell counter was discovered. And you can just Google again, just say Coulter principle and Velash Coulter, and how the Coulter principle came in, and he was working with something and he accidentally found out that the blood also can be examined, and that's how a cell counter came up. So initially we had these 3-part analyzers where we had lympho, mono, and grants to be there. And then we got into a 5 or 6-part analyzer where you have rest all the grants which were split into your baso. And if at all it gives a immature granulocytes, that will become a 6-part. And this is the Beckman-Coulter where the scatter is slightly different. All you have to know is how the axis is, and whatever histogram you see, you have to know what's the axis is. Here it's the volume and here it's the number. So I'll just take you through what exactly the cell counter does. So, but this will be just a brief one because we have to speak more about the peripheral smear. The reason why I'm telling you this is how a cell counter information can help you look at what exact cell you want in a peripheral smear. So you know that it's the impedance principle which is there. So what that means, so when a cell passes through, you have a pulse which is coming because of the electrical impedance, and we measure the height of it, and we measure the multiple events that go through. And finally, when you have the multiple events, you have these things which are uh, formed following the passing of the cell through that in between the electrodes, basically. So once this data is there, using the software, they just smoothen the histogram and get the histogram what we are looking for. And then this is the normal platelet histogram which is there, and usually it's all peaked here in this first quadrant itself, and later you have some larger platelets which are there, and that's where this particular graph comes in. This is just to show how impedance can give you a false low count whenever there is giant platelets. You will also have a thing here. So it would not start from the baseline whenever there are giant platelets or platelet clumps or NRBCs or even hemoparasites. So that is for the users of Beckman or any 3-part users. If you're looking at WBC histogram, just see whether it's starting from the baseline or not. If not from the baseline, you have those possibilities which I just mentioned. So whenever you have issues with the impedance technology, you can always go for alternate technologies like fluorescence. So whenever you have these kind of straight lines in a histogram, that means we are dealing with the abnormal platelet histogram. And usually these indicate either a platelet clump or a difficult phlebotomy. So more with a pre-analytical cause for a low platelet count in that particular sample. So just remember that. So the same thing here because of the clumps, it's not starting from the baseline. And this just to highlight how actually you should be aware of what sits in what axis. So whenever a neutrophil passes through, we have fluorescence here and side scatter here. In another instrument, we'll have side scatter on the y-axis and forward scatter in the x-axis. So neutrophil has passed through. Since it has high side scatter, it has to sit anywhere here or here. But we are also taking into account the fluorescence part. So they are less fluorescent. So they sit here. They are slightly smaller cells when you compare it to the other ones. So they sit here. Whenever you have a lymphocyte which is there, they don't have fluorescence or the side scatter, and they are smaller. So they have to sit here. And whenever the monocyte passes through, they are definitely less granular than neutrophil, but definitely slightly higher granular than lymphocytes, but they are slightly high fluorescent than lymphocytes. And here they're slightly larger than or almost the size of a neutrophil. So this sit here, okay? And then eos, they have so much of granules, so they take the extreme part on your side scatter. So if you just replicate the same, you have lymphocyte, monocyte, neutrophil, eosinophil. This is in a Sysmex instrument. If your users are FRCPath, this will be a lymphocyte, this will be a neutrophil, this will be a monocyte, this will be your eosinophil. So whichever analyzer you're working with, you have to be aware of what axis it is and what cell sits where. The same with the histogram in a Beckman, where a neutrophil passes through, and since the nucleus is so much of segmentation, the volume is higher, so they sit at the extreme. So here it's not about the size, but it's the volume of the nucleus, so they sit at the extreme. The lymphocyte, it's very simple. So the volume of nucleus is just at the beginning. It's the least amongst all others. And then you have a monocyte, which is again slightly larger than the lymphocyte, so they sit here. And eos, again, they are at least bilobed or slightly segmented, so the volume of nucleus will be higher than a monocyte. It's not about the size, so they sit here. So whenever you have anything like a CLPD where your mature lymphocytes are more, this entire histogram goes up and you hardly have anything here. So it's always about the highest number of cells that would give you this particular peak. And where there should be a valley like this whenever you see between the population. And if not, then we are looking at something abnormal. Okay. So that's just the comparison of how a normal histogram looks in a Beckman Coulter. And this is from McKinsey, where they say about the different regions. If it's not starting from the baseline, these are the things which we mentioned. And then if there is no valley, what are the things? So you can just go through it. But make sure you start looking at this cell counter data before we start interpreting peripheral smear. So we've been doing this a lot, where we just look at the cell counter values only and we are not looking at the pictures most of the time. So but I think with this particular class we will start at least try looking at the data other than the numerical. So that's what Master Shifu in Kung Fu Panda says. So if you only do what you can do, you'll never be more than what you are now. So let's try getting more data. So this is what we spoke yesterday also. So a cell counter gives a numerical data and a graphical data also. And you have a morphological data. So if it's just like a funnel basically. So initially when you look at a cell counter slip or the printout, whatever you have, or in a cell counter, you just look at the numerical first, whether it's leukocytosis, is it anemia, or is it thrombocytosis. But then that has a lot of differentials when you look at leukocytosis. But with the graphical data, let's say there are basophils which are more, there is a left shift, then you think more in terms of MPN. But then when you look at morphology, let's say you just want to see it's just a left shift which is there and basophils again which are there, and those are supporting and blasts are less than 9%, you know that you are looking at CML chronic phase. So things like that. So it's more of what we can learn from each step. So we were looking at this part, but let's start, and we were jumping to this, but this is the main key where we can utilize and make the diagnosis more easier. So let's have answers for this. We've been showing a lot of gross images, but this is different. What do you think the diagnosis is? The right hand side is a normal one. The left hand side is of the patient. So anyone who can answer? You can type in the chat box, or you can unmute yourself and say what this is. The left hand side slide. What do you think the pathology is? Can anyone type in? Sorry?
Cellular aggregation.
Agglutination.
Yes, correct. It's auto-agglutination. This is a case of AHA. So before even we put the smear into the microscope, let's start practicing this just to have a look at if there is anything with the smear. So this is the same case I think I put yesterday. So we'll start with the cases. I think I have 8 cases. We should be able to finish in next half an hour. So again, we are looking at a microcytic hypochromic anemia. The reason why we put this case is whenever there is erythrocytosis in a reproductive age group, it is fine to overdiagnose, meaning we can say that there is possibility of a thalassemia minor and we can screen across. So here we had asked what exactly it was, and this the same thing whatever I put yesterday, so I'm just rushing through. It's just to warm you up so that you are with a case which is very familiar. So the graph has shifted, that means we are looking at microcytic RBCs. So this is the entire picture. Your WBCs and platelets are normal. So the next test that was asked yesterday, most of you just told that we'll calculate the Menser index and we look for electrophoresis, and that's what here it is. So it is beta thal minor. Coming to case 2. So this is, I think I have put a, yeah. Okay, so this one. So this is case 2, 45-year female, leukocytosis with thrombocytosis, WBC at 14,000 and platelet is at 5,68,000. And if you look at the indices, MCV is low, MCH is low, hemoglobin is normal, RBC is at 6.9. So I'll just give you one thing. This from the Sysmex, since I work a lot with this, I've just put this, but don't completely go by what instrument I'm using, but it's about how we can approach this. And this is for the basophils. I just get you few things now. Now, before going, what do you think the diagnosis might be in this particular case? We have just finished a thal minor. And if you look at this particular case, you have MCV low, MCH low, hemoglobin normal, RBC is on the higher side. What do you think the diagnosis can be with this? Would you need smear for this? How many of you say you need a smear for this? Or you say it's the counts are fairly fine and we can proceed? What may be the broad diagnosis now, just looking at this? Yes?
Postgraduates, please make an attempt to answer.
Unless you answer, I would not go ahead, and if we don't go ahead, we'll miss out on the cases which we have put. So
Agatha, Soumya, Usha, Sidhu.
and it's fine to do mistakes. I have learned by mistakes. So
Look at the,
sorry?
why polycythemia?
Why do you think? Hi, that can happen in a thal minor also. No? That's what we were discussing right now. Erythrocytosis, MCV low, MCH low. So that's Menser index. If you take in this particular case, it's absolutely towards a thal minor. And we are speaking about a female patient in this particular case.
Well, see, the RDW is also very high.
22. Okay, I'll just move it and I'll give you the morphology. So you have a lot of these neutrophils which are there, but basophils are also being there. Now, this is what I want you to focus on. So how are the platelets? Do you think all are the same, or do you think there is anisocytosis in platelet? Is there anisocytosis in platelets?
Yes, sir.
Yes. Other than anisocytosis, is there anything else which you are able to see? Anisocytosis is there. There is size variation. Is there anything else with respect to platelets? Anyone can answer? Sorry? Anything else? Giant platelets is fine. But then, see, if you see, okay, just mute that person. Hello? Yeah. So if you look at the staining intensity of these platelets, you have a low anisogranularity is what we would say for this particular case. So you have a dark staining platelets and a light staining platelets, very similar. And whenever you look at these particular staining characteristics in platelets, you should always think of a myeloproliferative neoplasm. So, but then now, can anyone answer? You can just type in the chat box. You have option 1, which is minor hemoglobinopathy, option 2, which is probable minor hemoglobinopathy with iron deficiency, option 3, which is infectious cause, option 4, which is MPL. You can just type in and let's move slightly faster. Yeah, someone has answered. So 4, yeah. Okay, 3, someone said 4. Okay, so with this particular thing, so that's what we just mentioned. Because there is anisocytosis and anisogranularity in platelets, this can't be anything other than myeloproliferative neoplasm. So this was myeloproliferative neoplasm, and someone actually got it right because this turned out to be a JAK2 positive polycythemia vera. So this is how your sign out report can be saying it's leukocytosis with thrombocytosis and you're thinking of myeloproliferative neoplasm, and they have to do molecular workup including JAK2 and other mutations. So just remember, whenever you have thrombocytosis, just look at the platelet size and the staining intensity. If that is different, it is nothing other than myeloproliferative neoplasm. Okay, next question. So you have on the left-hand side normal, the right-hand side the case. What do you think the diagnosis is? Quick.
Anemia.
Sorry?
Anemia, sir.
Hemolysis.
Yeah, hemolysis. So this was hemolysis, but that's what I think I had taught you earlier. This was a case of polycythemia. So if you just look at the smear before putting it under microscope, this is how it looks because it's studded with so much of RBCs and it will be polycythemia. So Dr. Viksha has actually answered and it is polycythemia. So the case we just covered, and this is how it looks if you see it. Okay, so let's move on to the next case. So case 3. So we have 2 cases. So we are looking at 2 particular female patients, 17-year-old, hemoglobin of 7.3, RBC of 4.1, 64, MCV 17, 27, almost similar things. Any other data would you want right now so that we can differentiate, or do you think it's the same diagnosis, both of them? I'll just get you the another thing. Okay, so RDW, yes. So I've given the RDW. So 18.6 in one and 26 in another. So let's say we are just looking at these values and we say it is microcytic hypochromic anemia, but let's look at the smear. So this of case A, where the RBC count is still on the lower side and it will be slightly there. Anyone who can describe this? How is the anisocytosis or the degree of poikilocytosis and anisocytosis? Do you think it is mild or it's moderate or severe? Okay, marked is what you say. Okay, I'll just put the other one. Okay, now, how do you think this is? Elliptocytosis is what to say. So we'll just put this back to back. So I have the case A and case B. How do you think the anisocytosis is much severe in which particular case? I think everyone would accept that it is B. Okay, case B is marked, yes. And then you have case A, which is just mild, probably moderate, but here it's so severe that you can actually see every particular shape of RBC which is there. So what extra history would help in this case to get to a diagnosis? So we know that we are looking at 2 different pathologies as such.
History of transfusion.
Transfusion, no, because we're not able to see anything which is transfuse basically in this particular case. Probably if I would have, I thought I put the histogram, but maybe I missed it. I think I've put it further, but let's see. So any particular history anyone wants to look for? Sorry, I didn't hear.
Splenomegaly, sir.
Splenomegaly, that's great. So I just go to, yeah. So this person had splenomegaly and this person did not have. We just proceeded with electrophoresis, and you had a fast moving hemoglobin which is separating or eluting right at zone 15. And whenever you have zone 15, just do a supravital stain. And case A didn't have anything. This did not have a band either. The electrophoresis was normal in this, but this particular case had a normal band in 15. So if you see, how does it look like? So this is a golf ball inclusion. So all in all, whenever you're looking at microcytic hypochromic anemia, you just look at the poikilocytosis. If it's mild or if it is severe, then you ask what's the organomegaly or splenomegaly status. If that is not there, it's a simple iron deficiency. If it's there, you're looking at a thalassemia intermedia. In this particular case, it was HBH. So case A was iron deficiency and case B was HBH. I probably had shown the histogram last year when I had conducted, this time I missed it. My apologies for that. So basically, when you're looking at microcytic hypochromic anemia, always be aware of the degree of poikilocytosis, because the management is completely different and the diagnosis is a key in these particular patients. Okay, so we move on to case 4, where you have, I think this was leukocytosis with lymphocytosis. In the Sysmex, you have all these which are reactive lymphocytes, and here you have the normal monocytes, but you have some monocytoid lymphocytes sitting here. And in this particular case, the LFT is showing elevated SGOT and SGPT. Any particular diagnosis with lymphocytosis in adolescent or a young adult with a deranged LFT? What do you think the diagnosis may be, with fever being there?
Dengue.
Dengue, but lymphadenopathy is there. Okay, Agatha has actually answered that. It may be IM.
EBV, sir.
ABV, yes. So this is a particular morphology if you look at, and it's the skirting of lymphocyte, which is very classical in this case. And if you just open this particular book, they say liver function is abnormal and serum levels of aminotransferase and alkaline phosphatase are mildly elevated. Which book do you think is this from? If anyone says, I think I'll get you a chocolate next time whenever I'm in Chennai. Or I can. Okay, Harrison's correct. So Kamal, you can mark this name and we'll get you a chocolate next time. So this is from Harrison. So this is a lymphocytosis because of an infective etiology. So whenever you have fever, you just look at how the lymphocytes are, just have a look at how the LFT is, and you'll always have the diagnosis. So this was EBV. Now a 4-year-old boy, again, we are looking at lymphadenopathy and pallor. So total count is fairly fine, 15,000, but hemoglobin has dropped a lot, 40,000 amongst the platelets. Lymphocyte predominant. We just look at the scatter. I would probably would go to the morphology directly in this case. So any difference between the first 5 columns on the left hand side and the next 5 columns on the right hand side? Are both the cells same or different? That's the first question. Are they different or are they same? Atypical lymphocytes, okay. Are they same or different? That's the first question.
Different, sir.
Different, okay. So if it's different, what do you think, which is abnormal, the left hand side or the right hand side? Which one is abnormal? Someone who typed atypical lymphocyte, which one is the atypical one?
Left
Okay.
side, sir.
Okay, so the left side ones are actually abnormal, and if you actually see them, you hardly have any cytoplasm across all these cells basically. And if you look at the chromatin, it's almost like how a paint can be on a rough wall surface. It's not as smooth as how it looks in these cells. So these are mature lymphocytes. But in this, if you see, it's such a disturbance in the chromatin and they hardly have any cytoplasm. So we are looking at atypical cells, yes, but we have to commit to what it is. So with this particular scanned cytoplasm and that particular chromatin pattern, this is always neoplastic. So this case turned out to be a BAL. The reason why we put this across is they almost look the same at the initial part. If you just look at lymphocytosis and say it's a severe anemia, we might even miss it, but just having that particular uh, attention to the chromatin, that will help in this particular case. So this is another next case. So we have a 44-year female incidentally detected thrombocytosis and it was 20 lakh. This was her first visit basically. And if you see, these are a lot of basophils which are there. So these are the basophils again, and you have neutrophils being there. Anything in the platelets? So with this, do we think it's a reactive thrombocytosis or something towards myeloproliferative neoplasm again? So you have a case of thrombocytosis and you're looking at platelets, and platelets again are varying in size and they have different staining intensity. You have a dark stain and a light stained. Yeah, so hypogranular. And so you have a dark stained platelet, you have a large light stained platelet. So we are again looking at MPN. So smear findings, there is basophilia and platelet anisocytosis and anisogranularity. What do you think we have to do next? What do you think the impression is? So let's say it's MPN, yes, but what next test you want to do in this particular case? Just give you, this is what they give for essential thrombocytosis. So BCR, ABL, and you have all other things, JAK2, CALR, MPL. But this particular case, if at all we would have gone only by isolated thrombocytosis, and we actually did this panel first and everything came negative. But then going back to this made us think maybe we should check this first and then should have gone to this. And this lady turned out to be a BCR ABL positive. So that means she was labeled as chronic myeloid leukemia, but with that high platelet count, she was started on a second generation TKI immediately. So just a note that the reason why they give these criteria is we have to rule out these first before even getting to the next particular set of things. So isolated thrombocytosis, most often it is ET, but if BCR-ABL comes positive, they are still CML chronic phase in this particular case. Okay, so how much time do we have?
10
I
more
think-
minutes, sir.
10
Thanks,
minutes, okay. I think we have two more cases. So we are looking at a normocytic normochromic anemia with associated thrombocytopenia, but there is leukocytosis. Again, you just look at the histogram, not much of a clue in this. What do you think the cells are showing, the neutrophils? What do you think these are?
Hypersegmentation.
Yeah, otherwise, what's in the cytoplasm? You have these particular things. See these vacuolations. So
Activated
that's,
cytoplasm.
yeah, so vacuolations indicate there is infective pathology that's happening, or more often the sepsis kind of thing. So these are toxic changes. So, and then anything which is stand out here, fragmented abyss, but anything in that you want to categorize those as particular entity for that. If you look at cells like this,
Cystocytes.
schistocytes, exactly. So whenever you have anemia which is there and the dropping platelet count, you always look for schistocytes. So schistocytes were there, and it was coming to, yes, 2% of the total RBCs. Even 1% is actually significant if you go through that paper from ICSH, and this was microangiopathic hemolytic anemia. And just go through this particular paper. It's extensively written and it's a review article, and they explain about what all pathologies can cause your MAHA. And in this particular case, it was sepsis, which was causing the DIC, and microangiopathic hemolytic anemia. So if anyone just want to just take this particular ID, just type it in Google and you will have this article. Go through it. It's very well written, and you will know like what all pathologies can cause MHA. Okay, we come to the next set of gross image. This is normal, left-hand side. Right-hand side is the pathology. I want you to tell what pathology it can be.
Plasma proteins increased.
Yes, great. So this is myeloma. But if at all, this particular case, let's say it looked very granular in this particular head end, what do you think the pathology may be? This one didn't have much cells, so it's fine. But if you find this, I couldn't get the image of that. It was on my desk, but I couldn't go yesterday. So I couldn't get the image. If at all this turns out to be granular, your head end is more granular. If it's something like sand, but bluish, what do you think the diagnosis may be? So next time, just look at those. It will be those cases with high WBC count, usually the CMLs which present with 4 lakh, 6 lakh count. If you have the surface which is too granular, you have a diagnosis right there. So just move on. I think it's the last case, I think. I hope so. So we're looking at macrocytic anemia in an elderly female with platelet normal. So this is just the scatter of it. So we know that there is some abnormality. So I have to look at the lymphocyte population for this. Nothing much with the histogram, but yes, it's slightly asymmetrical. Maybe there are some polychromatophils. We'll just see. So this is the RBC picture. Anything striking in this? It's not a very good case, but I would still want you to pick a few things which are there in this particular case. We are looking at a macrocytic anemia. Okay. NRBC, no.
Microspirocytes.
Microspirocytes, rather than I would say they're just spirocytes, but they are varying sizes. They are interspersed, but you have few awkward cells like this. You have these spirocytes which are there, and they vary in size basically. So whenever there is spirocytes of varying size, what's the only diagnosis or the likely diagnosis, if at all? What test would you want to do next? In a case where you're seeing spirocytes of varying sizes, okay, what do you think is the pathology whenever we have that? Anyone? Sorry? It's okay. Make mistakes. It's fine. Okay, someone else.
Hemolysis.
Yeah, AHA. Great. So we probably are looking at AHA. Just before that, we did a retic count for this, which was 6.6. RP of 5.4 is high. So did a DCT with suspicion, but why autoimmune hemolytic anemia in elderly? What's the first thing you want to look at? Again, we are speaking of a 70-year-old woman who has AHA. What's the first thing you want to look at? I'll give you the morphology. So there are few normal looking lymphocytes, but there are these few which have kind of these particular cells. You have some projections and all that. See here, some villous projections which are there. So what do you think this can be? AHA, elderly, lymphocytosis. So lymphoma. Yeah. So just did a marrow for that. We had the same looking lymphocytes in those, and this was from that particular case. So this was in Trephine, and there was this cluster which was there, and this was splenic marginal zone lymphoma. So whenever you have anemia in elderly, just be aware that look for these spherocytes of varying sizes, just get a retic done, and you will have the diagnosis of AHA. And once you have to follow them up to see what's the causes, and most of them will have underlying lymphoma. So all in all, it's your numerical data which is there. Get information from the histogram and the scatter plot you see, and then you look at the morphology and you have the diagnosis. So this was a question which we asked in the beginning of it, and most of you told 3, and there were a couple of them who told 4. I don't know if they were part of this presentation before. So the answer is 4. So because he was not wearing the helmet, I think that's where I tried to confuse you all. So my sincere gratitude again to the organizing team. I hope I finished on time, and this our team there in Anand. So thank you.
Thank you, Dr. Pradeep. It was such a, I mean, I should say it was very, very good session, even for us sitting here. It was nice to kind of revise ourselves with all the day-to-day entities, what you showed. And of course, some of them, the lymphomas were very good actually, because PGs don't get to see, I mean, kind of understand the lymphoma spillover in the blood. And sometimes when we tell them these are atypical lymphocytes, yes, that is when they also look at it. And it was really good, very, very good. Thank you so much. And how are you feeling today? Are you okay?
Yeah, I think I'm better today. So I think I can get to work today.
That's nice.
Oh, yeah, but
Yeah.
it's good.
Postgraduates, you have
any questions? Any doubts? Or was I too fast? I think I rushed a bit because of the cases.
No, it was quite clear. It was quite slow and deliberate and very clear actually. And hematology, any day, every day, you can still listen to cases, because the everyday problem we have, we think we know something, but then still when you go and report, there are a few cases every day which gives a kind of a...
Yeah. So anything, any inputs on how we can do better from anyone?
This is the best way you have done, because discussing cases is what is more interesting and makes us learn as well, application point of view. Along with a little bit of theory, because you need to understand the, the hematology analyzer, and the information we get from these automated analyzers are more important when you want to really crack a case.
I think I couldn't actually put a lot of comparison with the normal this thing. I think that would have slightly helped a bit more. But the thing was, at least to, if we are looking at that particular number and that particular graph, what are the clues which we have already before looking at the morphology? So that was the thing. And the platelet one has been explained even in Barbara Bain, if you just look at the literature. But very recently we started observing it. And no matter which MPN it is, you'll always have that variation in platelet size and staining intensity. So
actually, I don't much of apply PDW and MPV in my routine. I mean, I don't incorporate when I'm trying to report something which is abnormal in the platelets. But is it really useful to look at MPV and PDW on a day-to-day basis?
Yeah, so I think that's an exercise which I have started to do right now. I still don't have an answer to it. So I think more cases we just compare. So for now, the only thing, like the thing has been morphology, but also to see if the indices actually give any clue. So I think we all can actually do that homework. So if at all the platelets look uniform in smear, yes, we are more likely looking at reactive. But I think if we have few clues on the indices, I think nothing better than that. Because that becomes very objective, because morphology sometimes can be subjective. So that's where indices can help. Yeah.
Thank you, Dr. Pradeep.
Yeah,
Thanks
I think
a lot.
there is one question. If we observe variation in platelet, how to word out the report Yeah, so let's say there is variation in platelets. So again, this is in the context of what else you're seeing. So let's say it's isolated thrombocytosis. You cannot give those in cases of thrombocytopenia and all those. It's just the thrombocytosis which is there. Or let's say there is leukocytosis or elevated hemoglobin which is there. So we see what exactly it is. So let's say it's thrombocytosis, and you can say suggestive of myeloproliferative neoplasm in view of platelet morphology. So morphology would have described. So you can say there is thrombocytosis, but because of the platelet morphology, it is suggestive of NPN, and ask them up to work further. And most of them invariably will have at least one thrombotic event if we go on the hindsight. It may be just like they would say they have some pain in the calf region, or we have had two cases where it was just a chronic headache and nothing else. So the thrombotic event can be so subtle, or they would have had just one pain abdomen kind of thing that's also there. So it's always in the context of what we are looking at the background, because if you look at ITPs, there is thrombocytopenia and you will have quite a good amount of anisocytosis, but not anisogranularity. So it's always in the context. So, and two things in MPN, it's always anisocytosis and granularity. In ITP, whenever you're looking at thrombocytopenia, you would not actually get anisogranularity, but you will definitely observe anisocytosis. So it's all a combined thing. So once you are looking at numerical, that should lead to your morphology, basically. Okay.
So, thank you, sir.
Yeah. Thank you.
Thank you, sir.
Thank you. Thank you. Yeah.
So thank you for making this an interactive session and pulling in the PGs to answer as well, sir.
Hope they answered at least the
Some
general
of
ones.
the
So thank you. Thank you. Thank you.
initiatives.
Yeah. Yeah.
Now we will go on to our next speaker of the day. I request Dr. Sanjay to introduce our next speaker.
Good morning, everyone. It's an honor and pleasure to introduce Dr. Shruti Mishra ma'am as our speaker today. She has done her MBBS and internship in Bankura Samilani Medical Institute and Hospital in the year 2005. And she completed a MD Pathology in Medical College and Hospital of Kolkata from 2013 to 2016. And she has done her senior residency in AIIMS Bhubaneswar and is currently working as an assistant professor in Institute of Medical Science, BHU. Her achievements, some of her achievements include getting the gold medal in preventive and social medicine in her MBBS days. In 2017, she has won Young Innovators Award in Indo-British Health Initiative Oncology Summit, and she has over 20 publications in index journals with 11 international publications. She has delivered talks in multiple CMEs. She is a reviewer for Blood and International Journal of Lab Hematology, and she has also helped establish flow cytometry services in AIIMS, BBSR, and BMTSRC, IMS, BHU. And her specialized expertise is in the field of lab hematology, including transplant pathology. And she has extensive experience in coagulation and hemostasis lab with training under Professor Sukesh Nandan Nair in CMC Vellore. We are honored to have you as a speaker, and I will waiting to learn the knowledge shared by you.
Welcome, Dr. Mishra.
Thank you so much, ma'am. Shall I share my screen now?
Yeah, sure.
Is my screen visible?
Yes, ma'am.
Yes.
And I am audible clearly, right?
Yes,
You're
Dr.
Yeah. So thank you, ma'am, for having me over here. It's a great pleasure for me to be a part of this venture of yours. And of course, it takes a lot of efforts to arrange all this webinars and all. And I'm really happy to be a part of it. Okay. One sec, ma'am. Let me just get a hold of my... I'm just stopping my video as of now.
Okay.
I can see my slides clearly. Okay. Okay, sure. So let's start. I have been given the topic to talk about morphology to flow with role of flow cytometry in bone marrow evaluation. So This will be an interactive session, and I would urge the postgraduates to please answer the questions whenever we are discussing the cases. Okay. So where do we do flow exactly? Means where do we do actually morphology? Means when do we order bone marrow examinations in patients? So whenever our patient is presenting to us with any sort of cytopenia, which is unexplained, say for example, the patient is having a persistent leukopenia for some months and it's not responding to any therapy or something, then you have to do a bone marrow examination. If the patient is having pancytopenia and there is no explanation as to why is it there, means we don't have any sure thing like there is a hypersplenism of anything, so obviously we will go for a bone marrow examination. Definitely in cases of hematological malignancies like leukemias or lymphomas, we will be ordering bone marrow examination. And also we do it in cases where there are suspicions of infections induced marrow suppressions, or we have to get the sample for culture, or we have to rule out macrophage activated syndrome or HLH. There also we will be doing bone marrow studies. So in all this, where is flow standing? No, flow helps supplements morphology, or definitely when we are dealing with malignant cases, like in leukemia and lymphoma analysis, we need flow. It helps us in diagnosing MDS. Now, as per the recent guidelines, MDS is now called as myelodysplastic neoplasm, even though the abbreviation remains MDS till date. Apart from that, it helps us in MRD detection. Previously, MRD was minimal residual disease. As per the latest guidelines, the nomenclature goes as measurable residual disease. And also it helps in DNA ploiding and proliferation. So these are the uses of flow where it is supplementing morphology, but that doesn't limit the use of flow cytometry in a hematological setup. Other than this, we also use flow in doing CD34 assay, in doing HLA typing for the patients, in analyzing the diagnosing platelet disorders, like it helps us in diagnosing Glanzmann's thrombasthenia and Bernard-Soulier syndrome, in PNH clone detection. So there are multiple other uses of flow in hemat, but I will be restricting my talk today only where it is supplementing the morphology. Okay. Now, what exactly is flow cytometry? So as the name suggests, flow is when the cells are in flow. Cyto means cell and metry means measurement. So this is basically we are trying to measure the different features of the cell when they are in motion. Okay. So this is different from what we do while we are doing morphology. In morphology, we have already fixed the cell on the slide and they are in the same, we are just going to analyze their features visually. Okay, now this is just a short video which I'll be sharing with you to tell you the different aspects of flow cytometer. Now inside the box, there are three parts. The first part is the fluidics part, which helps us transporting the sample towards the towards the optical part. And the last one is the electrical part, which will translate the data that is generated into the electrical impulses and give you the visual display. Now, first what we do is we prepare the sample and we let the machine aspirate the sample. Once the sample is aspirated, it is put into a fluidic suspension and it passes in front of the laser one by one. Now, this methodology is called hydrodynamic focusing, where there are two fluids flowing simultaneously parallelly in the same direction with the cells in the center and the sheath fluid in the outside. Now, once the cells are flowing in a single linear motion, now they are coming in front of the laser. What happens if a cell comes in front of the laser? Obviously, it will give out some shadows and reflect some light. Now, the thing is, there are certain detectors. The detector which is exactly in front of the laser is what it is detecting the forward scatter. Now, forward scatter is determined by the size of the cell and the voltage varies according to the size. And this is how you get the display of a histogram of the forward scatter and the cell count. Apart from forward scatter, there will also be side scatter where the detectors are present at 90-degree angle. And this will depend upon the complexity of the cell. That means the granularity and the nuclear lobularity, etc. So just like the voltage that is generated during the forward scatter, similarly, there are voltage changes for the side scatter, and it will vary according to the size of the cell. So these are the histograms which are being generated in the forward and side. And when we combine them together, we can delineate each individual entity that is present in the blood sample. So one with the maximum forward and side scatter will be our neutrophils, and the one with the least will be our lymphocytes, because they hardly have any cytoplasm and they are the smallest cells in size. Okay, now what makes flow cytometer even more interesting is that apart from this forward and side scatter, if you add fluorophores, you can detect different antigens that are expressed within the same cell. Now, what does this fluorophores do? They will produce light of different wavelengths. And this light, when emitted out, will be filtered by different filters, and they will be targeted towards their specific detectors. And these detectors will then convert these photons or this optical energy into the electrical output, which we can see as a display. So flow cytometer helps us in detecting antigens, various kinds of antigens within the same cell, as well as quantify this antigen. Okay, now till the hydrodynamic focusing part, it's the same principle which we see in an automated hematological analyzer as well as a flow cytometer. Now, how is flow cytometer different than an automated analyzer? It's that we can change the flow rate in our flow cytometer. If we want, we can increase the speed, and we can increase the number of cells that is being transported. Now, this flow is dependent on the pressure difference between the inner layer and the outer sheet fluid. Okay, so if the pressure difference is low, your number of cells that is going to be transported is single cell. If you increase the pressure difference, you can, the inner diameter will increase, so more number of cells can pass through. So high flow rate is something which will give you a lesser resolved output, but a higher sensitivity. And it is what is used for immunophenotyping of the samples. And we prefer the low flow rate, which is giving us a higher resolution, but a lesser sensitivity for DNA ploidy analysis. Okay, so this is something which we cannot do in an automated hematological analyzer. We cannot change the flow rate. Okay, now, as I have already said, the forward scatter depends upon the size of the cell, and the side scatter depends upon the complexity. That means the lobularity of the nucleus, the size of the nucleus, as well as the granularity. So as we can all understand from this, the highest cells with the highest forward scatter and the side scatter will be the eosinophils, followed by the neutrophils. The lymphocytes will have the least forward scatter and the side scatter, and monocytes will be somewhere in between because they are larger in size, but their granularity is less and their nucleus is not lobulated. Okay, now another important feature of flow cytometer, which differentiates it from the automated hematological analyzer, is the adding of antibodies. Now, these antibodies are associated or linked with fluorophores, which works on the principle of fluorescence. Now, what is fluorescence? It is the principle where the cells or the molecule is excited by a light of a single wavelength, and when it comes back to its relaxed state, this molecule will then go to an excited state, and while coming back into its relaxed form again, it will let out those energy in the form of heat and an emission of a light of a different wavelength than what has excited it. Now, this emitted light is what we are detecting in our flow cytometer to detect whether those antigens are present in our cell or not. Now, this is the electromagnetic spectrum, and we are using different dyes or fluorophores or fluorochromes for different wavelengths. Okay, so this is a simplified version. You put the fluorophores or fluorochromes in front of the laser. The cell molecules will go to an excited state, and when they come back to the ground state, they will release some heat and emit out the light in another wavelength from that which has excited it. Now, this is an example of few dyes which everyone uses in flow, like T, Texas Red, FITC. All these things are usually commonly used in our setup. Now, fluorochrome brightness, how bright will it be, depends upon two things. One is the quantum yield and the efficiency. And second is the staining index. Now, quantum yield will depend upon the antigen concentration on the particular cell, and staining index is basically how well it differentiates the negative staining cells from the positive staining cell. That will depend upon the quantity of antibody that you are adding to that particular sample. So if you add more antibodies than the amount of antigen that is present in the cell, overstaining also causes loss in staining index. That means loss in differentiation, and understaining also leads to loss in staining index. So if this is like that, that's why what we do is titration of the antibodies. Whenever we have a new antibody that we are procuring in the lab, we have to titer it and to see that which concentration is appropriate for separating the negative stem cells from the positive stem cells. Okay. Now, if you have too much of an antibody, then also there is a suboptimal differentiation. And if you have too little antibody, then also the differentiation is reduced. So that is what we have to take care of. Now, other than the fluorochromes, if we use only the fluorochromes, then our options of antibodies in the particular tube is reduced. So for increasing it, what we use tandem dyes. What are tandem dyes is exactly? Tandem dyes is a conjugate of two different fluorochromes. For example, PRCP Psi 5.5. So there is a PRCP part and there is a Psi 5.5 part in that. So what happens in those, what is the basic principle is FRET, or fluorescence resonance energy transmission, where the laser causes excitation of the first fluorochrome. And this fluorochrome, when it comes back to the ground stage, that energy that it releases will cause the excitation of the second fluorochrome, which is attached to it. And the final end product, that means the final wavelength that our detectors will detect, will be the one which is released by the second carrier fluorochrome. Okay, so this is how the number of colors in the tubes are increased. So you must have heard in routine practice, it's a multicolor flow cytometer, 6 color, 10 color, 12 color, 18 color. So what are these colors exactly? This is like in single tube, how many antibodies you can add. Now this antibodies, each antibody obviously has to be attached with a dye, that is fluorophore. So the base fluorophores are limited. So we use tandem dyes. Okay. Now, how is the histogram getting created? Once the fluorophores are excited and the wavelength are released, they are detected by the detectors, and you have your cells which are positive for it and which are negative for it. And just like your forward scatter and side scatter, each individual cell will give its own data. So either one cell will come here. That means this is one cell which is bright positive, and this is one cell which is negative. Okay. And computer system basically converts your optical data to electrical data. And how you can store this data is also specified by our, there are guidelines for it. So either it is stored in list mode method or fax files. Okay. Now, how are the plots demonstrated? You can either go for a density plot, dot plot, contoured plot, or grayscale. That depends upon the user's preference in which way you want to see the plots for analysis. Now, when do you say a particular antigen is positive? So usually we always compare a positive expression cells with a negative expression of cells. But this is just for a demonstration that I have told you. We never use this boxing system in our routine practice, but this is just to simplify for you. Now, if something which is there in this upper right quadrant, that means these cells are positive for antibodies which is present in both the X and the Y axis. The one in the lower quadrant will be, lower right quadrant will be the one that this green arrow, that means it is positive for only CD8 over here and not for CD4. These cells are positive for CD4 but negative for CD8. And the one that is present in the lower left quadrant, that is this orange arrow, they are negative for both the markers. Apart from saying positivity and negativity, we have to also assess the strength of expression. Now, how do you assess it? You compare it with those of the normal expression. So if you have to say the CD19 expression in malignant cells, you have to compare with normal B lymphocytes. If it is falling more away from the what is expressed in the normal cells, that means it is bright expression. Okay, because normal cells are supposed to be like moderate expression. If it is falling behind them, that means it is a dim expression. So that is how you compare and assess the strength of expression. Now, while analyzing, you have processed the sample, you can see the data plot in front of you. Now, and you have a multicolor flow. You have run your control and everything, but before analysis, you have to see whether your samples are properly displayed or not. Your data is properly displayed or not. For that, you have to understand the concept of compensation. Now, when we are dealing with so many dyes and so many fluorochromes or fluorophores, the wavelength of the light that is being emitted, there will be some overlap between them. And because of that, some antigen which may be negative might be considered as positive because it is being overlapping with another antigen which was positive, and it was in somewhere near in the same range of that wavelength. So for that, we have to do compensation and we have to check. So this is in this plot. If we start analyzing without compensation, we will think that this particular population is positive for both X and Y axis. But if we compensate it properly, we will see that it is definitely positive only for the antibody that is there in the X axis, but negative for the one which is there in the Y axis. Under compensation and overcompensation, if you do overcompensation, you will lose the data plot in front of in your display and the cells will be lost. And if you undercompensate, then obviously the differentiation between the positive and the negative expression of the antibodies cannot be ascertained. Okay, now there are certain guidelines about how you should be reporting your flow cytometry samples. So you have to summarize all the major populations as a percentage of the total cells that you have aspirated or you have taken for analysis. Then you have to give a detailed description of the abnormal population. That means, say our abnormal populations cells are having moderate CD19 expression or dim CD20 expression with CD200 and aberrant expression of CD5 and 23. So, and it is also having a kappa restriction. So what am I talking about over here? It's a case of CLL, chronic lymphocytic leukemia. So that is how you describe your abnormal population. And you have to tell them, like I have told, aberrant expression. So if there is any antigen or which is not normally expressed in lymphocytes or say in your target cell, you have to say that this is an aberrant or abnormal expression is there. And if there is a change or weakening or loss of expression or in a normal antigen, that also you have to record. Only listing the antibodies or antigens expression as a percentage is not helpful or not relevant. Okay. And while analyzing rare events, we have to state the total number of events that we have acquired and give the exact percentage of the rare events that we are commenting on. Okay, now how do we know what is abnormal? It's simple. You have to know what is normal first. Without knowing the normal, we cannot know what is abnormal, right? Now, there is a beautiful article by Professor Brentwood, and this is like a classical article which everyone refers to before starting out their career in flow cytometer, where the normal developmental patterns of each individual cells are described. Okay, I'll just describe to you the B and the myeloid series, and I won't venture into every details. Say, for example, while we are doing this, we all know that B cell starts from pro B cells, then goes to pre-immature, mature, and then finally plasma cells. So if you have this backbone markers of CD19, 19 is like your lineage marker over here. Cytoplasmic CD22 is also your lineage marker. So what are the, other than that, what are the precursor markers? CD34 and TDT, they are like the precursor markers. They will be present only in the precursor cells. CD10 is lost in the mature forms and is only there in the middle region. Okay, CD20 appears in between in the pre-B cells and it is expressed in mature B cells. But if you are dealing with a case of myeloma, CD20 is lost or it's not expressed, or is it's like dim expressed. So this is how the things go. And this is like the, if you plot these antibodies against each other, you will see the various patterns. So the most common cell which is confused with blasts are the hematogones. Now these hematogones are what various stages. There are 3 stages of hematogones. So slowly, if you see, the most classically everyone uses the CD2, CD20. Yeah, anybody is saying something?
I think it was just a mistake. You can continue.
Shall I continue?
Yeah, sure.
Yeah, okay. Say for here, A, B, C are the 3 categories of hematogones. Now, A is the most precursor cell where CD10 is positive but 20 is negative. B is showing the positivity for both CD10 and CD20. And as this hematogone matures and goes to the 3rd stage, it loses CD10 and you see only CD20. So this is the classical waterfall cascade like pattern which you see in hematogones or B cell maturity. And these are the other various patterns which are described in this article. Okay, now if you come to neutrophils, so here the backbone markers will be the lineage markers. So what are the lineage markers? CD13 and 33 are the lineage markers for myeloids. Now 13 and 33 both starts out with a high expression. 13 remains as a high expression even in a neutrophil, but 33 somewhat dims out once the cell matures. 11B and 15 are acquired in the later stage, and 16 is also acquired towards the later mature form. And what are the markers for precursor cells? CD34, HLA-DR, and CD117. So these are the precursor markers in case of neutrophils. And this is how these are the developmental pattern, where the pink one is the most mature cell and the red one are the blasts. And this is like it's a boomerang kind of a pattern where we can see that CD13 and 16, CD13 is brightly expressed. It somewhat dims in between, but then again regains back its higher expression as the cell matures. Okay, so these are like the normal patterns. So if we know the normal pattern, then only we can compare it with a case and define whether there is any abnormality present or not. Now, how exactly is flow helping us in leukemia? It helps us in diagnosis. It helps us in classifying the particular disease. It helps us in prognostication, for monitoring the response post-chemotherapy, and also helps us in diagnosing early relapse. Okay, now for blast, how are blasts seen in a flow cytometry report? So these blast cells, if you see morphologically, blasts resemble more or less the lymphocytes. So they have a low site scatter. Okay, and unlike lymphocytes, the CD45 expression is weak in blasts. So they will fall somewhere behind the lymphocytes or more towards the 0. Okay. They will have immaturity markers, that is CD34 and TTT. And for determining the lineage, we use lineage-specific markers like cytoplasmic MPO for myeloids, 79A for B cells, and CD3 for T cells. Okay, now let's flow and discuss some cases. Now, I hope the basics is clear and we can go into some case discussion. Shall I proceed? If anything, please ask the questions now.
Postgraduates, you want to clarify anything, you can do now. I think we can proceed with the cases.
Okay, ma'am, sure. So, flowing with the cases. Case 1. A 36-year-old male, he presented with pancytopenia. Bone marrow was done. It was hypercellular, and there were 32% blast, 46% maturing granulocytes, 6% monocytes, 2% lymphocytes, and 12% erythroids. Okay, this is how the blast look like. And this is, what is the structure?
Please answer.
Yeah, these are oil rods. Yeah. Okay. And this was Sudan black stain, and the Sudan black stain was positive for this patient. Okay. Now let's see what we found in flow. So as I have told you, in for phenotyping, we usually do a medium rate for sample aspiration. So whenever we are doing a medium rate, we have to find out singles. We do not analyze doublets or triplets. We prefer out singlets. And for finding singlets, we do forward scatter height against the area, and then we specifically see which are the singlets, and then we gate out the singlets. After the singlets, we can see with the side scatter and CD45, this red one are the blast window. Okay, so this green is the lymphocytes, which has a lower side scatter, but a 45 bright expression, and the blasts have a 45 weaker expression and a low side scatter. So if you concentrate on this red population, these cells are positive for CD34. Right? Yeah, and it's also positive for HLA-DR and somewhat positive for CD13. CD56 is positive. So we are dealing with a case of, most probably a case of AML, right? Here we see CD34 is positive, but cytoplasmic CD3 was negative, CD79A was negative, but MPO was positive. Okay, and this is like the developmental patterns for the lymphocytes. So there are no hematogones as such. So this was a sense morphologically also there was left shift, and we can see the maturing granulocytes in a good enough percentage in our flow also. So we suggested a translocation 821, which came as positive. So this was a case of AML with translocation 821. Okay. Now case 2, 9-year-old male, the count was high. I'd like postgraduates to try this case. So this is how you go about for analysis. The count was high, platelet was low, and peripheral smear itself showed 92% blasts. This was the morphology. And there was SBB was negative, but non-specific esterase was positive in this case. Okay. Maximum cells are in the blast window, as you can see, 85%. These cells were CD34 not positive. They were negative for CD34, but they were positive for HLA-DR, positive for 11B, negative for 15. They were positive for 117, positive for CD33, positive for 64, positive for 56. Cytoplasmic MPO was not significantly positive. CD79A was negative, and CD3 was negative. So what do you think is the diagnosis in this patient? What are we dealing with? Any takers?
PGs, anybody want to answer?
Somebody has put myelomonocytic, somebody has put M5.
Yeah, M5, exactly. So we are dealing with a case of monoblastic leukemia. So you see it's 14 positive, 64 positive, 14 negative, but it is 64 positive, HLA-DR and 117 positive, 56 positive. So it is a case of monoblastic leukemia. Okay. Next case, 9-month-old child presented with a high count. Okay. And this was the bone marrow. When we did the analysis, we have a good enough population in the blast window. They are CD34 positive. They were both 19 positive, 38 was positive, 10 was however negative, 58 was somewhat positive. Myeloid markers were negative, 15 was positive, HLA-DR was positive. And for cytoplasmic markers, CD79A was positive, but MPO and CD3 were negative, as we can see in here. So this is a case of Sorry, I gave out the answer. So this is a case of B cell leukemia. Okay. Now case 4. This is a tricky case. We had recently diagnosed this case 2 months back. So 23-year-old male patient came to pulmonary medicine department. He had a 1-month history of fever, cough, and shortness of breath. There was a mediastinal mass which was found with lung involvement, and the differential considered were tuberculosis or a lymphoma. However, peripheral blood was showing some blast cells, and this was the marrow, which was packed with blasts. So we went ahead and did a flow, taking out the singlets as I have told you, and this were the cells in the blast window. Okay, so this blasts were CD33 positive, CD117 positive, HLA-DR and 64 were negative, 13 was negative. Okay, here you can see majority of the cells were CD3 positive, cytoplasmic CD3 positive, but they were also positive for CD19 and 79A. And cytoplasmic MPO was, however, negative. Okay, remember the markers that we have seen. 33 positive, 117 positive, 34 positive, CD3 positive, 79A positive, 19 positive, but MPO negative. There were 7 positive, 5 was dim, but it was positive. Blue is the normal expression. So if this is a moderate, this one is the dim expression. 4 and 8 were both negative. CD38 was bright, 20 was negative, 7 was positive. Here in B tube, we had a split of expression. There was a population which was positive for CD19, but 10 was negative. Cytoplasmic CD22 was, however, negative. TDT was negative, and CD1A was negative. So what do you think is this case? Want me to recall back all the antigens which were positive?
One participant has replied as ALL.
What type of ALL? Which cytoplasmic marker are we going to consider in this case? So this is a case of early precursor T cell ALL, ETP ALL with aberrant B marker present. Okay. How do you define ETP? You have this T markers should be present. Cytoplasmic CD3 is positive. There should be aberrant stem cell markers, CD and myeloid expression. Myeloid marker is CD33, which was present. CD117 was the stem cell marker, which is apparent in this patient. Other than that, it should be 4 and 8 negative for ETP. Here, both are negative. CD7 is positive. CD5 is dim, which is going on with ETP. And the main clue was CD1A. 1A is negative. So definitely we are dealing with an ETP ALL. Now, why did I not consider 79A and 19 and call it as a mixed phenotypic acute leukemia, and why I just went for an ETP with aberrant B expression? Because as per the latest WHO criteria, whenever the cells are having, see here we had this CD22 was negative, cytoplasmic CD22 was negative in our case. So whenever we have to say a mixed phenotypic, we have to show expressions. So what is the criteria for WHO? If CD19 is strong, along with that, you have to either have a CD10, 22 or 79A expression. If 19 is weak, you need 2 antigens, 10, 22 and 79A. You can see 10 is negative, 22 is negative in our case. And 79A, even though is positive, you see the subclause that is written over here. You can only consider CD79A positivity if CD3 is negative. If CD3 cytoplasmic is positive, like in our case, it was an ETP case and cytoplasmic CD3 is brightly positive. Here, we cannot consider the 79A positivity as a lineage marker. So we have to consider this as an aberrant expression of B antigen in a case of ATP-ALL. Now, this is a rare phenomena when such things happen. And we have already, means this case, we are trying to put it in publications for still under review. We had an article present for ATP-ALL. There are certain scoring systems. If you go online and if you try to read about it, we have different scoring systems for defining ATP-ALL and its variants. So you see, we had this paper where we compared the different scoring systems and we came up with some other scoring systems of our own, which will help us diagnose ATP-ALL easily. Now, apart from leukemias, we also use flow for MRD, that is measurable residual disease. Now, measurable residual disease, you can detect either by flow cytometry or molecular methods like for using PCR. So what is exactly MRD? Say this is your patient which came to you with a malignant clone, that is the red one, and the blue one are his normal cells. Okay. Then you gave the treatment. The malignant cells, normal cells, everything died out, but a few malignant cells are hiding there. So if you want to detect these cells within a pool of normal cells which regenerates back, that is called measurable residual disease. Now, for all practical purposes, as the number of colors in the flow cytometer single tubes have increased to 10 to 12 colors nowadays, which is used in many centers, the sensitivity of flow has increased and it is at par with that of PCR, where it can read up to the depth of 10 to the power minus 4 to 10 to the power minus 5. That means one cell in one lab also can be detected easily by using this method. Okay, this was an article where they compared the sensitivity and they said that MRD is comparable if we are using multicolor flow with that of molecular. Now, if you see, this is just a case for analysis. So here in our patient, it was a pre-B-cell ALL patient. Okay. So in this pre-B-ALL patient, the CD19 was positive. Okay. And CD45 is deemed. CD34 was also positive in this patient. Okay. And here we can see the CD10 is positive. Okay. This is the second tube for this patient. CD10 was positive to begin with. CD19 was positive. CD58 is positive. And those malignant cells were CD123 positive. But when they did when MRD was done at day 33, we can see the malignant cells present over here. There are some malignant cells where the CD10 expression has, if you compare with this, the expression has become dim or it is quite a bit lost. But 19 is still expressed. CD58 is still there. And 123 seems to be lost. So how do you do MRD exactly? You have to see whether the LAIPs are retained. Like for in this case, CD38, CD20, and CD58 was retained. So like CD58 here in this cell, in this slide, and CD20 was there positive in this. See, the CD20 was still retained in this malignant cells. And LAIPs that were lost were CD10, CD123. Okay, now what is LAIP? It's leukemia-associated immunophenotype. The expression of normal antigens which is varying, deviation from normal, and cross-lineage antigen marker. Like in our ATP-ALL cases, expression of myeloid antigens in a T blast. These are like these are what we use while doing MRD. So we know that these are the malignant cells and these are not the normal T cells or normal precursors. Okay, so cross-lineage antigen expression, altered antigen expression, and asynchronous antigen expression are all what is used for detecting or analyzing measurable residual disease after chemotherapy has been given to a patient or after transplant to see whether the patient is relapsing or not. Okay. Now, for all this, you have to have a robust panel where the panel should not only help you diagnose the case, it should also help you prognosticate, and it should be flexible enough if you want to add further markers. Like every day you see research is happening and more antibodies are being told to be helpful in analysis of measurable residual disease. And also if you can incorporate in your diagnostic panel, only then you can see whether it is still expressed or is it lost while doing MRD. Okay, but the good thing is you don't have to do all the paneling on your own. Euroflow panels, they provide pre-formed panels for people to follow, and this has been cross-checked in multiple platforms. And if you just follow them blindly, it's also a good enough way to start flow cytometer in a flow cytometry service in our center. Okay. So next we go to MDS or myelodysplastic neoplasms. Where we can, how do we do this? Basically here there is no increase in blast per se, but obviously there is an asynchronous maturation or there is a shift in the maturation, and we detect that is compared with the normal growth pattern, and we can see whether these patients are having myelodysplasia or not. Okay, and there are certain scoring systems for MDN also, which you can go through if you want. Other than leukemias and MDNs, flow is also helpful in diagnosing CLPDs. It helps in BET, NK cells, and also prognosticates if you have particular antigens which is present or not. The variations or the subclassifications of how you approach a flow, it's the same thing. We, like you do in IHC, we see whether the cells of our target, we just first get out CD19 positive B cells, and then we see whether they are CD5 positive or CD5 negative. If along with CD5, there is CD23 positive, there is dim expression of CD20, there is a restriction in kappa or lambda, FMC7 is negative, and cyclin D1 is negative, then we consider as CLL. If CD5 is positive, but 23 is either negative or positive, but 20 is bright, there is a kappa lambda restriction, FMC7 is positive and cyclin D1 is positive, then definitely we are dealing with a case of mantle cell lymphoma. CD5 negatives are further classified as per CD10 or 10 negative or positivity. If it is 10 positive, it can be either follicular, Burkitt's or DLBL. If it is 10 negative, then we have to do another tube for hairy cell leukemias and hairy cell leukemia variants like CD123, 103, 25 and CD11C, which you have to do to rule out hairy cell leukemia. Okay, now again, a couple of cases. So this is the peripheral blood of a patient where we can see there is increased in lymphocytes and there are some smudge cells present. And this was the marrow. So when we did the flow, so we have a bunch of, we gated out the CD19 positive cells. Now the CD19 cells were CD38 positive, they were CD20 bright, and they were having a kappa restriction. So these were clonal cells, clonal B cells that we were dealing with. CD5 and 23 both were positive and FMC7 was positive. So what do you think is the diagnosis in this patient?
And one participant has responded as CLL.
No, actually, if you remember what I said, CLL should be negative for FMC7. So this is FMC7 positive. CLL cases will be like positive for, yeah, exactly. This is mantle cell. Okay, so we are dealing with mantle cell lymphoma over here. And as you could see, some of the cells were having a bit of a blastic morphology. So if a mantle cell with a blastic morphology cells, they usually have this aberrant CD23 expression. Okay. And they also have associated splenomegaly, if you go back and check the history, which was there in this particular patient of ours too. Okay, so this was a case of mantle cell. Case 2, there is a 42-year-old male. He presented with pancytopenia and he had splenomegaly. Peripheral smear showed this kind of cells where there were some projections in the lymphocytes. Okay, these are the cells up front, up close. So we went ahead and did a flow. Gated out the CD19 positive cells. These cells were CD10 and 11C positive, CD25 and 103 positive, CD23 negative and CD20 positive. CD5 was negative. There were some subset was positive for CD43, 5 was negative, 22 is obviously definitely positive. There was a kappa restriction. So these are clonal cells that we are dealing with, and it was 11C positive. So what do you think is the diagnosis? Yes, hairy cell leukemia. So we are dealing with hairy cell leukemia in this case. The next case, 58-year-old male. He came to us. This was a very interesting case for us. He came to us with back pain for 4 months, but had an anasarca for 4 months also. He came as a huge bloated body with us. Okay. But even though after seeing the peripheral smear and everything, there was a suspicion of myeloma. So we sent out an SPP. Unfortunately, there was no in-spike, there was no AG reversal, nothing. And the doubt still remained what is happening with our patient. Then we did a bone marrow. Bone marrow, this is the bone marrow picture where you can see there are certain scattered plasma cells, right? And they are having granularity in the cytoplasm also. So we went ahead and did a myeloma flow for this patient, and we gated out our plasma cells. These plasma cells were CD56 positive. They were lambda restricted. Okay. And they were lambda restricted. So we diagnosed this case as a possibly a case of myeloma. After that, we did an IFE. IFE showed a lambda restriction. And then I haven't included the picture, but this patient underwent a renal biopsy, and there was amyloidosis with a beautiful apple green refrigerance and all that. So it was a case of light chain restricted myeloma, light chain myeloma basically. It was not a heavy chain myeloma with renal involvement. So it's quite a difficult case when we started out with. So how do you differentiate phenotypically normal plasma cells and neoplastic plasma cells? So normal plasma cells should have lineage markers, that is 38, which is strong, and 138 should be present. Normal plasma cells usually have a weak expression of CD19, but a strong CD27 expression. They have moderate CD45. Neoplastic plasma cells, on the other hand, have an aberrantly bright expression of CD20, CD56, CD28, CD117, CD200. They have a loss of expression of CD19, CD27, CD45, CD81, and definitely you will see a light chain restriction. Now, one thing of note over here is the kappa and lambda staining, which we do in CLPD, is usually the surface marker, and the one which we prefer for plasma cells is cytoplasmic for determining the clonality. Okay. Now, my journey with flow started just like as a PG. It was just a long question for me, just something to learn so that I can write my answers and get some marks. But then what interested me in flow was when I got to do work on CD34 assay in the peripheral blood. This was an article which we published from CMC Vellore when I was there. So we did CD34 assay. I was doing the processing and I was doing everything, and it helped me correlate. What we were doing was basically correlating HPC, that is hematopoietic progenitor cell count, which is a count which you get in Sysmex analyzers, with that of the CD34 count in the peripheral blood as well as the back, to see whether the harvest is optimal enough or whether we can predict when to take the patients for harvesting so that we can get good enough yield in the bags. So that was how I ventured into the world of flow from just being a long question. And then recently we have had publications with a international collaboration where we did a rare matrix sampling and all that. So how to do the analysis in rare matrices, how to work with that, how to standardize them, how to implement it in your routine practices, whether if you are doing it as a clinical practice for giving out diagnosis, or if you are doing it for research purposes, how should you be standardizing it, how should we go about it. So from there, I'll say I'm still learning flow. I'm not an expert or anything, but it has been a journey that I really liked it. And for helping others, we are planning a workshop in our center So I'd like to welcome all of you to our holy city of Kashi. So with that, if you are interested, you can contact me. So till then, let's keep calm and love hematology. Thank you.
Dr. Shruti, that was a great presentation. Very, very nice. Extremely good. Because we don't practice flow daily. So it was very nice for me. And because I too don't see flow every day. I hardly see flow. And recently we diagnosed one light chain multiple myeloma based only on bone marrow and immunohistochemistry. We didn't
Yes,
have
ma'am.
flow.
So it means it's definitely flow is going to means it's like a nice thing to add into your armamentarium of diagnosis, and it helps a lot in tricky cases like this light chain restricted myeloma cases and all that. So it's like
Yeah,
helps
it,
a lot.
I'm now I realize how easy it would have been for me to diagnose because we had to break our head, and then it was just not light chain I mean, one light chain restricted. It was biphenotype in the sense both kappa and lambda co-expression. So that was kind of a thing. It was very, very good. Many a times leukemias, we have to send it out for flow, and so we lose the opportunity of the follow-up of the case as well.
Yes,
So
ma'am. Yes.
yeah, we are getting flow. So definitely I'll be calling you in person here to visit Chennai and then also have a workshop with us to enlighten more on the use of.
Ma'am, it will be a pleasure and honor. Sure, ma'am.
Thank you. Thank you so much, Dr. Shruti.
Thank you, ma'am.
Thank you, ma'am, for the interesting and interactive session. Now, I request Dr. Dharini to introduce our next speaker.
Good morning, everyone. I'm an immense pleasure in introducing Dr. Sulakshana ma'am, who's a renowned pathologist in Sri Shankara Cancer Hospital and Research Center, Bangalore. Ma'am has done her MBBS from Vaidhi Institute of Medical Sciences and Research Center in Whitefields, Bangalore. MD in Pathology from Bangalore Medical College. She has won awards including the gold medal in forensic medicine in PG and also in the PG quizzes. Ma'am was a senior resident in Department of Neuropathology in NIMHAMS, that is National Institute of Mental Health Science and Neurosciences in Bengaluru. Ma'am has been the assistant professor in the Department of Pathology in Padma Shri groups of Institute of Bengaluru and has many publications in national and international journals. Ma'am has been the assessor training program conducted by the NABL in May 2021. And she has taken many talks and national CMEs, and she has conducted many workshops on her. We are honored to have you here, ma'am.
Good morning, everyone. Can you hear me?
Yeah, Dr. Sulakshana, welcome again. Thank you so much for accepting.
Thank you so much, ma'am, for giving me an opportunity to be a part of this CARE-PARE program. So
It's
it
the
is.
third time with us, I think you are.
Yes, ma'am. Yes, ma'am. This is the third time that I'm being with you, and I'm really thankful to you that you actually obliged to give me a different topic this time. So I could also read upon a different topic. So when I read, that is when I can teach the students. So it was an enlightening experience for me too, ma'am.
Jane, allow madam to share.
Yes, ma'am.
Can I share my screen now?
Yes, ma'am.
Yeah.
Ma'am, it's visible, ma'am.
It's visible? Okay. Okay, so the topic given to me was endocrine pathology. So endocrine itself is a very broad topic and it has many organs in it. So to cover everything about it in 1 hour is difficult, but I have taken 10 cases and I think this will be a kind of a broad discussion on all the basic endocrine tumors. And because this is a program for the postgraduates, so I'm sure it will be very much helpful for them, especially for the exams and also for their theory papers. Starting with case number 1. And because I think there are many PGs online, so if it can be an interactive session, it will be very helpful. So can you people hear me, and will you be answering me, or?
PGs will answer and they'll also
Yes.
put it in the chat box.
Oh, okay, ma'am. Chat box. Okay, ma'am. I'll be checking that also.
Letting you know.
Okay, ma'am. So this is case number 1. This was a 54-year-old male who presented with bilateral adrenal masses, and a biopsy done elsewhere showed atypical cells suggestive of adrenocortical carcinoma. And both the adrenal glands were excised and sent to us for histopathological examination. So this is the gross pathology of the same. Can someone explain to me how this looks?
PGs, please make an attempt and start describing. Agatha, Soumya, start describing.
You don't have to be scared. You can tell whatever you see. So it's just an attempt.
Well circumscribed,
Fleshy mass, okay. Can you see the normal adrenal tissue here in the periphery? There's a thin rim of adrenal tissue, and it is almost completely replaced by a fleshy gray-white mass, and it is showing some areas of hemorrhage and necrosis. So this was the histopathology of the same. So here you can see that there is the periadrenal fibroadipose tissue, and this is the tumor, which is highly cellular, and it is composed of cells. How do you think these cells look like? How are they arranged? What is the pattern of arrangement?
Sheets.
They are arranged in sheets. Okay. Is it cohesive or discohesive? Discohesive. Okay. And there is a lot of necrosis. Okay. And the higher power of the same. How do you think the cells look?
Pleomorphic.
Okay, pleomorphic. Large cells with abundant cytoplasm, pleomorphic nuclei. Some are having lobated nuclei with coarse chromatin and lot of mitotic activity. So on histopathology, what will be your diagnosis? What is the differentials that you can give in this case? Outside, they had called it adrenocortical carcinoma. Do you think this is adrenocortical carcinoma? Okay.
PGs, whether it's adrenocortical carcinoma, yes or no, at least you tell. If you say yes, you have to give evidence. I mean, you have to tell why did you think of it. Okay, nobody is ready to answer.
Nobody's. I think they're scared, ma'am. It's okay. You can just answer. You can put it in the chat box also. No problem. So now can you tell what is this? I'm showing the IHC markers. CD20 positive.
CD10 is negative. So at least now we make a attempt. You said it was discohesive, it was CD20 positive.
Okay. And BCL6 and MUM1 also positive.
Now comes the diagnosis. Tell Agatha, Soumya.
The ma'am is so helpful. Nobody used to help us like this during our discussions.
Yeah, somebody said.
Okay. Sorry, I can't hear you. Diffuse large B-cell lymphoma. Yeah, wonderful. So this was a diffuse large B-cell lymphoma, the non-GCP type according to the Hans classifier. So this is a very rare tumor in the adrenal, and this was actually a primary adrenal lymphoma that is involving both the adrenal glands at once. Sorry. So it's a type of lymphoma involving one or both adrenals, lacking antecedent history of lymphoma with or without involvement of lymph nodes or other organs, but always with the adrenal lesions being unequivocally dominant. So in this case, the patient presented with only bilateral adrenal lesions, and there were no lymph nodes elsewhere in the body. 70% of the cases are bilateral, and the patients usually present with abdominal pain and constitutional symptoms, and rarely with features of adrenal insufficiency. So this is a very rare tumor comprising less than 1% of all lymphomas, and less than 300 cases have been reported in the literature. And the most common type is the DLBL, as seen in this case, usually seen in elderly males. So the pathogenesis is exactly not clear. So one adrenal is usually involved by the lymphoid cell, either because of in a background of a chronic inflammation, either because of autoimmune adrenalitis or immune dysfunction or viral infections like HIV and EBV, and rarely mutations of P53 and c-KIT. And through one lymphoid gland, they spread to the other by the lymphatics. And that's how both the glands are involved at that time. And there is no lymphoid tissue as such in the adrenal gland. So only when there is a chronic inflammation in the background of this lymphoma can occur. So rarely it can occur in a background of immunosuppressive therapy. And in DLBLs, the most common mutations are MYD88 and CD79B. And grossly, as we saw, it presents as a solid fleshy tumor mass with areas of hemorrhage and necrosis. The staging is by the Lugano classification, which is a modification of the Ann Arbor staging system. The overall 2 2-year overall survival is about 70%. And if the masses are small, chemotherapy itself will suffice. In this case, the masses were large and were causing symptoms of adrenal insufficiency, and hence they were removed. Post-operative RT can also be given. So whenever you see a bilateral adrenal neoplasm, the most common differentials include metastasis, right? So that is especially from the lungs, and others include met from the breast and melanoma. And the other thing that you can think of in bilateral adrenal tumors are pheochromocytomas. So they present bilaterally. So whenever you see a patient with bilateral adrenal tumors, the first thing that comes to your mind should be a pheochromocytoma. So you check with the clinical findings for any biochemical studies which support the diagnosis, or else you always keep lymphoma at the back of your mind, because adrenocortical adenomas and carcinomas are usually unilateral. So this is the learning point in this case. Okay, coming to case number 2, there are some answers in the chat box by Dr. Agatha and Dr. Soumya, which says DLBL. Okay, great. So case number 2, 41-year-old male presented with headache and progressive loss of vision since 15 days. On MRI, there was an extensive anterior skull-based extra-axial lesion involving the sphenoid, ethmoid, and sella with suprasellar extension. So what do you think this is? What do we do in CNS tumors? A rapid diagnostic procedure.
What procedure we do?
Squash cytology. Yeah, excellent. So this was the squash of the same. So here you can see that the tumor is quite cellular, and the tumor cells are arranged in vague nests, and the background is not fibrillary. So that's why it's not a glial tumor. And if you can appreciate the chromatin, it is a kind of salt and pepper kind of chromatin. So cellular mass with this kind of morphology, what will you think?
E.g. cellular mass. Yeah.
What will you think? Okay, I'll show you the images. Now, what do you think this is?
They have put it as pituitary adenoma.
Pituitary adenoma. Oh, yeah, correct. This is wonderful. It is a case of pituitary adenoma. So here you can see that it's a kind of circumscribed mass with the tumor cells arranged in vague nests surrounded by fibrovascular septae, and has similar morphology that you saw in squash with abundant granular eosinophilic cytoplasm that you can appreciate here, and not much of pleomorphic nuclei. The high power of the same, some amount of endocrine atypia is there, but not much of mitosis. So this was a case of pituitary adenoma. And in the new WHO classification, it is named as a pituitary neuroendocrine tumor. And we called it NOS because we didn't have the immunohistochemical markers to subclassify them. So we called it PIT-NET-NOS. So this is a clonal neoplastic proliferation of anterior pituitary hormone producing cells, most commonly identified in the cellular region and often with suprasellar extensions, and rarely can occur in ectopic locations, including the sphenoid sinus and the clivus and suprasellar region. So the clinical features are because of hormone excess production. So they can present with the growth hormone excess with features like acromegaly, gigantism, and also ACTH with Cushing's, and also with features of hyperprolactinemia or hyperthyroidism, rarely with gonadotrophin excess. And rarely they may present with the visual disturbances and headache because of mass effects. There is a surgical emergency called as pituitary apoplexy when there is hemorrhagic necrosis within the tumor, and which is highly dangerous. So they comprise about 0 to 15% of intracranial tumors, slightly more common in females. And grossly, they look like small pale nodules, which can have pushing borders, and they may extend into the suprasellar space or sphenoid or cavernous sinuses. And the classification is based on the transcription factors, which causes the cell differentiation. And this is the basis of the new WHO classification of the pituitary neuroendocrine tumors. The three transcription factors include the PIT1, the SF1, and the TPIT. So I'll not go into the details. You can look up the new WHO Blue Book where there are details given about this. And these pituitary tumors are associated with inherited, most of them are sporadic, and some are associated with inherited syndromes of the MEN mutations, Carney complex, SDH mutations, Lynch, and McCune-Albright syndromes. As I said, the consensus classified tumors according to the pituitary cell lineage and cell differentiation. So when you get such a tumor, you can do the basic neuroendocrine markers with pan-cytokeratin and neuroendocrine markers, and you do markers for the transcription factors, that is PIT1, TPIT, and SF to subclassify. them. And for further subcategorization, you can do the markers for the hormones like growth hormone, prolactin, ACTH, TSH, FSH, LH. Okay, and always always correlate with the biochemical studies in this in these cases. So this is the WHO classification, where you can see that they are classified into PIT1 lineage tumors, TPIT, SF1, and tumors without distinct cell lineage, which include the unclassified ones and the null cell tumor. So you can go through these in the WHO book. What are the sub types of these depending on the hormone production? Okay, and you can do if you are getting confused with the pituitary hyperplasia, reticulin staining will help, because in case of a hyperplasia, there will not, the acinar architecture will kind of be preserved, whereas in a neoplasm, there will be disrupted staining pattern. And as in other neuroendocrine tumors, you use the Ki-67 proliferation index for the grading, like G1, G2, G3. But this is not applicable in the pituitary neuroendocrine tumor, because such tumors, the prognosis depends on the subtyping, that is the transcription factors, as I mentioned. Specifically, the oncocytic acidophilic stem cell tumor will stain for the anti-mitochondrial antibody. So that is useful in these cases. This is an image of a immature PIT1 lineage tumor, where you can see that the tumor cells are arranged in nests showing a similar morphology as this, as I showed in my case, and it is showing positivity for PIT1, GH, and the alpha subunit, and also for TSH, but it's negative for the prolactin. So this was an immature PIT1 lineage tumor. Treatment of choice is surgery, and if the tumor is large, the clinicians use somatostatin analogs and dopamine agonists to reduce the size and later excise them. If some amount of tissue is left out after excision, if it is subtotal resection, then RT will help, and in some cases, radionuclide therapy may help. So as I said, Ki-67 labeling index is not used in the grading. Even P53 staining is not used in this scenario. The prognosis depends on the tumor type. Especially the immature PIT1 lineage tumors, Crook cell tumors, and if there is ATRX loss, then such tumors behave more aggressively. Okay, and the differentials that you'll think of in this case is metastatic carcinomas or a metastatic neuroendocrine tumor because of the morphology. Then paragangliomas, again because of the morphology. You can do S100 staining for differentiation. Then other tumors that you can think of is olfactory neuroblastomas and pituitary hyperplasia, where reticulin staining will help. Okay. So this is again the WHO classification. You can go through this. There are many subtypes. This is based on the specific IHC for the hormones. Sorry. Let's move on to next case. Case number 3. This was a 32-year-old male who presented with solitary nodule in the right lobe of thyroid. And on radiologically, it was given as a Tirard's 5 nodule, and FNA was done. So can someone describe this smear to me? This is the FNA from the right lobe of thyroid gland.
Usha, can you describe?
Cellular.
Okay, cellular smear. How do the cells look like?
Cellular smear are arranged in micro follicles are having a repetitive pattern, ma'am.
Okay, okay. Can you see some nuclear features in this?
Yes, ma'am. Individual cells show scanty cytoplasm with vacuolated.
Okay.
Nuclear inclusions.
Okay, inclusions are there. Some are also showing kind of grooves, and some amount of endocrine ATP is there. What kind of chromatin can you appreciate in this? The previous one also looked like this only, the chromatin. Coarse stippled, salt and pepper.
Salt and pepper.
Yeah, correct. So what do you think this is?
Follicular.
Okay, what will you call this as? Follicular neoplasm. You can see the cells, some are looking spindled, some are looking plasmacytoid, and they're having the salt and pepper type of chromatin. So, and one more clue I'm giving you. This is your cell block of the same and 2 markers to help in your diagnosis.
Ma'am, somebody has replied as medullary.
Okay, okay. I'll check that. Oh, yeah, correct. Wonderful. So this is Dr. Agatha has said that this is medullary carcinoma. Excellent. So this is your TTF1, which is showing strong nuclear positivity, and calcitonin, which is showing cytoplasmic positivity. So this was a case of a medullary thyroid carcinoma. I put up a cytology slide because I wanted to highlight on the changes in the new Bethesda system of reporting for the thyroid cytopathology. So this we called it out as positive for malignancy, suggestive of medullary thyroid carcinoma, Bethesda category 6. So in July 2023, the third edition of the Bethesda system for reporting thyroid cytopathology came out, and it has some minor updates. So these are the changes. So the category 1 is non-diagnostic or unsatisfactory terminology is removed. Okay. And repeat FNA should be performed in less than 3 months. And category 2 is benign. You can call for the previous terminologies like colloid nodule, hyperplastic nodule, adenomatous nodule, or benign follicular nodule. The term follicular nodular disease can be used. So category 2, you can call follicular nodular disease. Then in category 3, the follicular lesion of undetermined significance is discontinued. Instead, it is called as atypia of undetermined significance, and it has two subgroups, AUS with nuclear atypia and AUS other. Category 4, the suspicious for follicular neoplasm is discontinued. Instead, you call it as follicular neoplasm, or if it is the oncocytic variant, you call it oncocytic follicular neoplasm. Okay. Potential cases of NIFTP or FVPTC should be classified under this category and not under suspicious for malignancy. And if it is the Hertel cell type, now you call it as oncocytic follicular type. Okay. Then category 5 is the suspicious for malignancy. Avoid categorizing NIFTP and FVPTC under this. Under suspicious for malignancy, you have suspicious for papillary, suspicious for medullary, suspicious for lymphoma or carcinoma. And under malignant, you have your papillary thyroid carcinoma, and variants is now changed to subtypes. Previously, the cribriform modular variant came under the papillary type. Now it is a separate tumor entity under the uncertain histogenesis. And now poorly differentiated thyroid carcinoma is now called as high-grade follicular-derived thyroid carcinoma. So that's why I put up this case to tell you about the changes in the 2023 Bethesda recommendations. So this is again the same, the different 5 categories. The range of estimated, that is the risk of malignancy ranges from 5 to 20% in category 1, about 2 to 7% in 2, about 30% in 3, and increases about 80% in suspicious and around almost about 100% in the category 5. So let's move on to case number 4. So this was a 37-year-old male who presented with swelling in the jaw since 2 months. And he also gives an excision of lesion in the left humerus 1 year ago. So this was the lytic lesion in the jaw. It's involving almost the entire jaw. And this is the histopathology of the same. So what do you think this is? So you're thinking I'm talking about endocrine, and why is this ma'am telling about bone tumors? But then I'll give a clue about this. So what is this lesion in the jaw? What do you think this is? What are these cells?
Are these cells prominently seen here? Sonali, yeah, somebody has put giant cell.
Okay, but why am I showing giant cell tumor in endocrine? Any other? Okay, something else related to giant cells only. See, lot of something brown at the background. See, I'm giving you a clue, brown with giant cells.
Which tumor of
sorry.
endocrine? Which tumor of endocrine will have that brown tumor?
I actually put it and I removed it. Brown tumor, yeah. Somebody has mentioned brown tumor. So the clue is this was there in the neck. What is this? Which can cause the brown tumor?
Which organ is this? Which endocrine organ? Yeah, parathyroid.
In the neck, parathyroid. Excellent. So this was a case of a parathyroid adenoma causing this brown tumor. That is the secondary to a parathyroid adenoma. So here you can see that there is a lot of osteoclast-like giant cells with plenty of hemosiderin in the background, and there is a fibrous proliferation, and the bony trabeculae are thinned out. There is osteopenia and lot of hemosiderin is there. And it's not a giant cell tumor. These are osteoclast like giant cells. Okay. And the patient has a parathyroid adenoma. So this was called as brown tumor. Why it is called as brown tumor? Because whenever there is hyperparathyroidism, there's a lot of bone resorption, and there is a replacement of this bone by the vascular a tissue, and a lot of hemorrhage and hemosiderin will occur, and it looks brown in color, and that's why it's called as brown tumor. It's also called as osteitis fibrosa cystica or von Recklinghausen disease. So it's commonly seen in females, and most frequently encountered bones are the ribs, clavicles, long bones, pelvic girdle, and the craniofacial bones. And most common cause is primary hyperparathyroidism, in which parathyroid adenoma is the most common cause, followed by hyperplasia. And rarely it can occur secondary to secondary and tertiary hyperparathyroidism. So there is a lytic lesion in the bone which will provoke little reactive bone. The cortex may be thinned out and expanded, but it's not penetrated. And there's lot of granulation tissue and hemorrhage and vascularity, and that's why it's called as brown tumor. And they regress when the cause of hyperparathyroidism is removed. So coming to the parathyroid adenoma, as we all know, it's a benign parathyroid neoplasm composed of chief, transitional oncocytic or clear cells, or a mixture of the cell types, and typically involves one gland. There are some essential and desirable diagnostic criteria that's the WHO has stated out. The essential criteria include the enlarged cellular gland measuring more than 6 to 8 millimeter in size and weighing more than 40 grams, consisting of a benign parathyroid cell proliferation, and often surrounded by a rim of atrophic parathyroid parenchyma. And there is significant drop of intraoperative PTH, often greater than 50% within 10 to 15 minutes, or there is a post-operative biochemical cure. And the other parathyroid gland should be normal to call it out as a parathyroid adenoma. Okay. Okay. Accounts for about 85% cases of primary hyperparathyroidism. Women are more frequently affected, and it can also occur where ectopic parathyroid tissue may be present, especially in the thyroid, thymus, retroesophageal region, mediastinum, or in the carotid sheath. Associated syndromes include the hyperparathyroidism jaw tumor syndrome. Risk factors include radiation exposure and long-term lithium therapy. And symptoms include secondary to hyperparathyroidism like renal stones, osteopenia, the bone lesions as in this condition, fatigue, and psychiatric disturbances. Serum parathormone and calcium are elevated, but not as much as in a parathyroid carcinoma. They are about less than 1 centimeter to more than 10 centimeter in size. If it is less than 6 millimeter, it is called as microadenoma. They weigh more than 40 milligrams. So whenever you get an endocrine organ during gross, before grossing, always wait whether it's a parathyroid or an adrenal, okay, which is very important. Then grossly, they may look yellowish tan, solid, well circumscribed, and there is no invasion into adjacent structures. So immunohistochemically, they are positive for neuroendocrine markers like synaptochromo and also for PTH, polyclonal Pax8, and in patients with mutations, MEN1 and cyclin D1 may be positive. And how do you differentiate between a parathyroid hyperplasia? In hyperplasia, it typically involves all 4 glands. It is sometimes very difficult on histopathology without having a clinical background. And in parathyroid carcinoma, there is invasion into the adjacent structures, or there is vascular invasion or perineural invasion with atypical mitotic figures. So WHO says that if you are getting only one parathyroid gland, and if the clinician asks whether it's an adenoma or just a normal parathyroid tissue, and it doesn't give any other information about the other parathyroid glands, and sometimes it's not easy to make out that it's very well circumscribed or capsulated. You cannot see, especially on frozen section. So in that case, WHO says that you can sign it out as pathologically enlarged fat depleted parathyroid gland consistent with an adenoma. So they say that you can word it like this. Okay, so they are benign tumors. Recurrent hyperparathyroidism occurs in less than 22% of patients, especially if they are fully excised. And if it's multiglandular disease, the prognosis is dependent on the underlying clinical or the genetic syndrome. So what is this? It's a spotter, similar to the same thing which I described right now, but then the cells are looking kind of different, no? How are they looking? Okay, got something in the chat box. Chief cells. Oh, they're looking very clear, no? Some terminology is used for the same. Clear cells, yeah, excellent. So this is a clear cell or a water cell adenoma. That is a parathyroid adenoma. Plenty of clear cells. Okay. Coming to case number 5. This is a very nice case. A 34-year-old female who presented with a duodenal polypoidal mass. Clinically, they felt it was malignant and hence a Whipple resection was done. So grossly, you can see that around the ampulla, there is a mass and it's infiltrating into the duodenal wall. The pancreas is normal. See, this is the mass. The pancreas is normal. Okay. Sorry. This is the histopathology of the same. Can anyone describe this? What is this mucosa?
PGs, please voice out instead of putting in chat box.
I can read the chat box also, ma'am. That's okay.
Yeah. Okay, at least put it in chat box.
So this is your duodenal mucosa, and in the submucosa there is a relatively circumscribed neoplasm which is arranged in vague nodules. And on higher power, you can see that these cells are, some are spindle shaped, some look like ganglion cells. Okay. Some look epithelioid and some inflammatory cells are seen admixed and not much of, no mitotic activity, no necrosis. What do you think this is? In the ampulla, which is showing such morphology, I'm giving a clue: ganglion cells, spindle cells.
Ganglion cells, spindle cells. What put it in the chat box if you can. PGs. There is no mitosis. It is ganglion cells, spindle cells.
It's in the submucosa and it's arranged in nodules. This is the normal duodenal glands and here is the neoplasm.
At least give differential there.
Okay, they're putting the chat box. Yeah, paraganglioma. Okay. Ganglioneuroma. Okay. Okay. So this was a case of it. It is a combination of both. It was a case of a gangliocytic paraganglioma. Okay, so this slide went off this side. Okay, it's a rare tumor of the periampular region and the second part of duodenum. Almost all arise in the duodenum or around the ampulla of Vater, and they derive from the endodermal neuroectodermal complexes in the embryonic ventral pancreas. Slightly more common in females. The mean age of presentation is 52 years. The patients may present with GI bleeding or abdominal pain, or rarely it may occur as an incidental finding. It's usually benign and non-functional. Rarely metastasis can occur and it may recur if incompletely excised. Okay, and it's also called as composite ganglioneuroma neuroendocrine tumor, COGNET. Okay, composite ganglioneuroma neuroendocrine tumor. That's what the WHO says. It's usually 1 to 3 centimeter in size, sessile polypoidal mass, and it has this classic triphasic histology that I described. That is your epithelial neuroendocrine cells, the spindle-shaped Schwannian cells, and the neuronal ganglion cells. And the immunoprofile again is characteristic of the same. That is, they are positive for synaptophysin, chromogranin, S100, especially the ganglion cells. The spindle cells will be positive for S100 and BCL2. So differentials, as you all pointed out, is paraganglioma, which is rare in the ampulla. And in the paraganglioma, it's usually a Zellballen pattern of arrangement. And the S100 positive such tentacular cells are around the nests of the tumor cells. Whereas in this case, it is admixed. In ganglioneuroma also is a differential diagnosis where the ganglion cells will be predominant. Again, it is rare in the ampulla and duodenum. And another thing that you should consider is neuroendocrine tumor. And the progesterone receptor and pancreatic polypeptide staining will help to differentiate between this. So this was a very rare case. So just wanted to share this with you. Okay. So coming to case number 6, this was a 55-year-old male who presented with a right cervical lymph node, and the excision biopsy was sent to us for frozen section analysis because the clinician wanted to know whether it's a lymphoma or a metastasis. And the patient also gives a history of excision of nodular lesion over the right pinna 10 years ago. So this is the frozen section of the same. So these are all the frozen artifacts, but we have to give some diagnosis on such slides only. So if you can attempt to at least describe this slide. How does this look? Very bad, no? Okay, can anyone say how the nuclei look or how it is arranged?
Anybody? Postgraduates? You can describe the nuclear feature on the right side, which is clearly seen.
This one here, I think this you can describe. How does it look? How are the nuclei sitting? Are they sitting together, sitting far away? And here some pink is there. What is this pink? Necrosis, yeah. So this was a lymph node. Something in the chat box. Yeah, somebody in the chat box has written nuclear molding. Excellent, Dr. Manju. Okay, so this was a lymph node showing effaced architecture and lot of necrosis were there. It is a very cellular blue tumor which is showing nuclear molding. So nuclear molding means, what do you think this is? Where does nuclear molding occur? In which tumor? Okay. Small cell carcinoma. Do you think this is looking small or the cells are large? Actually it was a large cell neuroendocrine neoplasm. So we called it as a neuroendocrine neoplasm, and we asked for markers. Again, did you see that there is a clue in the history of excision of nodular lesion over right pinna 10 years ago? What do you think was there on the pinna? Some neuroendocrine tumor. No. So what is cutaneous neuroendocrine tumor called?
Yes.
See, I'll give you a clue. See, CK20. Cutaneous neuroendocrine tumor, what is it called?
Yeah.
This is the paraffin section of the same, where you can appreciate the salt pepper chromatin, the nuclear molding, lot of mitotic activity. CK20 is showing a characteristic staining pattern. Somebody in the chat box, Merkel cell, excellent. Yeah, it's a characteristic paranuclear dot-like staining of CK20. So this was a case of a Merkel cell carcinoma met to the node. So the history of excision was of the Merkel cell carcinoma of the pinna. Okay. So a strong positivity for synaptophysin and chromogranin, and one nice marker with nuclear staining, which can be used helpful for us to differentiate it from a met neuroendocrine carcinoma from other sites other than the skin. What do you think this is? Nuclear marker? Something you use in the colon? Okay, no idea. This is SAT-B2, which is a helpful. Yeah, one person has told SAT-B2. Yes, Dr. Manju, excellent. This is a SAT-B2 which can be used as an adjunct to the diagnosis of Merkel cell carcinoma. Okay, so this was a metastatic Merkel cell carcinoma to lymph node. So it's an uncommon and highly aggressive primary cutaneous neuroendocrine carcinoma, and the Merkel cell polyoma virus positive type should be distinguished from the virus negative type, because the negative type has a worse prognosis when compared to the positive type. Okay, and should also be distinguished from combined neuroendocrine carcinoma, which is most commonly associated with SCC, commonly seen in elderly Caucasians and in the sun exposed sites like the head and neck, extremities and trunk. And the majority, about 80%, are associated with Merkel cell polyoma virus, and minority are UV mediated. The risk factors include advanced age, chronic sun exposure, immune suppressions, like HIV infections and autoimmunity. And they present as a rapidly growing flesh-colored red violaceous nodule. The treatment of choice is surgical excision. So always distinguish it between a metastatic neuroendocrine cell carcinoma from other sites, for which immunohistochemistry is helpful. That is your CK20, SAT-B2. And if you have the Merkel cell polyoma virus, that is the monoclonal antibody, which can be used as a IHC marker, that will be excellent. So this was the skin nodule, which was a fleshy nodule on the skin, and this is the pinna, where you can see that there is a fleshy nodule which is extending deep into the subcutaneous tissue. Okay, so this is your Merkel cell polyoma virus monoclonal antibody. That is the immunohistochemical marker for the same, which shows nuclear staining. Okay, and the essential and desirable diagnostic criteria include a fast-growing tumor, a blue cell tumor with neuroendocrine morphology, and immunophenotyping. That is your neuroendocrine markers and perinuclear dot-like staining for your cytokeratin. Okay. And as I said, SAT-B2, which is expressed in, these are some of the articles that you can read, SAT-B2 in neuroendocrine neoplasms. And there are many studies that show that the expression is quite good in Merkel cell carcinoma when compared to the metastatic neuroendocrine cell carcinoma or poorly differentiated carcinomas. So the differentials in such case include a metastatic NET, or a poorly differentiated carcinoma, then leukemias or lymphomas because of the round cells, and also melanoma. So treatment of choice is an excision with lymph node dissection followed by adjuvant RT. PD-L1 immunocheckpoint blockade therapy can also be used. Chemotherapy is usually ineffective and reserved only for palliation. So the factors relevant to staging include the tumor size, the depth of invasion, the nodal involvement, and presence or absence of METs. The negative prognostic indicators include the advanced age at diagnosis, elderly males, head and neck site, immunosuppression, and the negative subtype, as I said. About 60% present with local disease, 30% with nodal, and 10% with distant disease. It's a highly aggressive tumor with high mortality rate. So this was an interesting case which we got for frozen section analysis. Now case number 7, we came back to our again favorite organ, adrenal. Okay, so 49-year-old male, right adrenal tumor presenting with Cushing syndrome. Can someone explain how this tumor looks like? You can put it up in the chat box as well. What color is the tumor? Yellow, yeah, yellow, dirty fellow. Yes, it's looking yellow. And this was a large tumor, yellowish, and it is having infiltrative borders and showing some amount of hemorrhage and necrosis. Okay, so microscopically, is something striking to you? What kind of a tumor this can be? What kind of cytoplasm are you seeing? And also the prominent nucleoli. Yeah, a lot of eosinophilic granular cytoplasm with prominent. Okay. I think I am not able to hear you clearly. Yeah, oncocytic. Somebody says oncocytic. Excellent. So this was an oncocytic variant of the adrenal cortical carcinoma. So this is a highly cellular tumor with predominantly oncocytic cells, and you can see necrosis here. Okay, so a similar picture, plenty of oncocytic cells with abundant granular cytoplasm, prominent nuclei, and plenty of atypical mitosis. So this was the oncocytic variant of adrenocortical carcinoma. Okay, so this is a tumor which is composed of more than 90% of oncocytic cells, and it's a subtype of adrenocortical carcinoma, and it is the most common histological variant. It accounts for 11 to 22% of adrenocortical carcinoma cases. The mean age of presentation is around 48 years, and the left adrenal is slightly more commonly affected when compared to the right, and rare cases can occur in ectopic adrenal rests. The usually associated with mutations in mitochondrial DNA, IGF2, and also with mutations of TERT, RB, CDK4, and CDKN2A. The patients may present with features of Cushing syndrome because of hormone production, and rarely they may produce sex hormones or multiple hormones. And when compared to a conventional adrenocortical carcinoma, oncocytic variant is typically larger at presentation, and the patients will present with features of abdominal discomfort, pain, vomiting, weight loss, and weakness. Metastasis is documented in around 15% of cases. Okay. And whenever we, for diagnosis of a adrenocortical carcinoma, we use the modified V system. But this is not applicable in the oncocytic variant. Why? Because at least 3 parameters that you use in the V system, that is your eosinophilic cytoplasm, the high nuclear grade and diffuse architecture, these are intrinsically present in this tumor type. And therefore, another system has been proposed for the scoring of this type of tumors, which is called as the modified score in Lin-Weiss Bisceglia system, that is LWB system. Okay, where there are some criteria. which include the major criteria and minor criteria. The major include high mitotic rate, more than 5 mitosis per 50 hyperfields, presence of atypical mitotic figures, and venous invasion. And the minor criteria include the large size, more than 10 centimeter, or weighing more than 200 gram, presence of necrosis, sinusoidal invasion, and capsular invasion. So one major criterion indicates malignancy. The minor criteria indicates uncertain malignant potential of borderline tumors, and absence of all major and minor is a benign tumor. Okay, so this is your V's scoring system, where the mitotic count, then clear cells, atypical mitosis, necrosis, and capsular invasion are taken into account. And score of more than 3 indicates malignancy. Okay, so the median tumor size is around 20 centimeter, weight of around 500 grams, and it's a yellowish tumor rimmed by adjacent normal adrenal gland. So immunohistochemically, they're positive for the adrenocortical markers like inhibin, melanin, calretin, and also some amount of neuroendocrine markers and cytokeratin with disrupted reticulin network. So the treatment of choice is a radical resection with lymphadenectomy, and pure oncocytic ACC has a better prognosis when compared to the conventional type. The overall 5-year survival rate is around 50%. And one more important thing, which is used for the prognostic scoring for oncocytic ACC is the Helsinki score. Okay, this incorporates the Ki-67 proliferation index, and it's the most specific and sensitive prognostic score for these type of tumors. So in this scoring system, there is you take into account mitosis, necrosis, and the Ki proliferation index. Okay, so mitosis more than 5 per 10 millimeters square, you give a score of 3. If there is necrosis, give a score of 5, and take the Ki proliferation index, whatever the numeric value, and add them all up. Okay, if the total score comes to up to 8.5, it is benign. If it is more than 8.5, it is a malignant tumor, and if the score is more than 17, it has a adverse prognosis. So this is the Helsinki scoring system for oncocytic ACC. And don't use the V's scoring system. You use the modified LWB system for the oncocytic ACC. Okay, so that's why I put up this case to tell you about these two important factors for a histopathological diagnosis and prognosis. Okay, so the differentials again include the conventional variant of the adrenal cortical carcinoma, then oncocytoma. Oncocytoma, to differentiate between this, you can use the reticulin staining, and you can use the criteria, what I mentioned. Then other differentials include pheochromocytoma, renal cell carcinoma with eosinophilic features, and rarely metastatic carcinomas. Okay. So coming to case number 8, now we have come back to thyroid gland. Okay, a 47-year-old female presented with solitary nodule in the left lobe of thyroid and given as steroids 5 on radiology. Total thyroidectomy was done. So can someone describe the gross to me? How does it look? What kind of a tumor is this?
Sonali.
They're putting in the chat box. Fleshy gray white. Okay. Okay, great. Fleshy gray white tumor occupying almost the entire thyroid parenchyma. Yes. Sorry, capsule. You think it's invading the capsule? Okay. So this is the microscopy of the same. Here you can see that it's a very cellular tumor. Kind of vague fibrous capsule is present, but not exactly encapsulated. Okay, it's the cellular tumor which has a predominantly, what kind of architecture is this? What kind of architecture is this? So I'm giving a clue also. BRAF positivity.
The architecture is so typical. Please tell all of you.
Architecture is typical, and also see the nuclear features. Okay, somebody is telling nests. Okay, what do you call nests as? Cell balance in thyroid. Solid or trabecular architecture. Okay, so and can you appreciate the nuclear features? So it is showing the nuclear features of papillary thyroid carcinoma like clearing, and some are showing grooves and occasionally inclusions also. So solid pattern with the papillary nuclear features and BRAF mutation. What do you think this tumor is?
PG is papillary tumor. I mean, follicular. Papillary nuclear features are there. So,
NIFTP,
Some variant
non-invasive
of
follicular,
PTC.
non-invasive follicular variant.
No, the nesting pattern is there. No, so what do you call it?
Follicular variant of papillary thyroid carcinoma.
Okay, no, it's the solid or the trabecular variant of papillary thyroid carcinoma. Okay. So it's an uncommon type of papillary thyroid, subtype of papillary thyroid carcinoma, which has a predominantly solid trabecular and insular growth pattern. Okay, and it lacks the diagnostic features of high-grade tumors, high-grade PTC or poorly differentiated thyroid carcinoma. It's a rare subtype of PTC, accounts to 1 to 3% of cases. It was more common in patients and with a history of exposure to ionizing radiation, and it was reported in about 34% of children with PTC after the Chernobyl disaster. Okay. So the size ranges from about 0.1 to 11 centimeter. Multifocal involvement can occur about in 40% of cases. They may be infiltrative nodules and nests, and they are usually gray white, tan, and generally no necrosis or hemorrhage. Okay, and molecular alterations include mutations in the red PTC, RAS, and BRAF. In this case, our case, we had a BRAF mutation. Immunohistochemically similar to the papillary thyroid carcinoma, TTF1 and thyroglobulin will be positive with positivity for CK19, HBMV1, galactin-3. Ki is usually less than 10%. BRAF mutations are seen in about 11% of cases. So why I put this subtype is when compared to the conventional variant of PTC, this solid or trabecular variant is an aggressive subtype, and it may present with metastasis in about 18% of cases. Okay, the differentials include a poorly differentiated thyroid carcinoma because of the architecture. But in this case, the mitotic rate was low and it showed the nuclear features of papillary thyroid carcinoma. Again, another differential is your differentiated high-grade thyroid carcinoma. I'll be talking about this in the coming slides. In this case, there will be necrosis and high mitotic activity. Then because of the solid pattern, you can confuse it with a medullary thyroid carcinoma on gross. On histopathology, IHC will help in the same. Then some of you mentioned NIFTP and follicular thyroid carcinoma with solid growth pattern. Yes, they can also come under the differentials. But again, clearly look at the nuclear features and the pattern of growth. Other differentials include highlighting trabecular tumor and paraganglioma. Sorry. So what is this? This is again a spotter. Excellent. So this is a tall cell variant of papillary thyroid carcinoma, where the tumor cells
Thyroid carcinoma.
correct. Excellent. So where the tumor cells are arranged in the follicles and they are lined by these tall cells, giving a tram track-like appearance. So here you can appreciate the cells are tall. That is, the length is more than 3 times the width, and you can appreciate the nuclear features. That is your grooves. Okay, so it's a subtype where the height is at least 3 times their width, and they should represent at least 30% or more of the PTC cells to make this diagnosis. And it characteristically gives the tram track-like appearance. The differentials in this is the Warthin-like and the oncocytic PTC. So in this case, you look at the tall cells. Look at the morphology and immunohistochemically usually will be the same, but sometimes high Ki labeling index is reported in this type of variant, and it's a slightly aggressive variant of PTC. And BRAF mutation is present in most cases. Okay. So what do you think this is? What is this blue color thing?
Cartilage.
Cartilage. So what do you think this? From where does cartilage come? Where? And see this lining epithelium. Sorry. You can put it in the chat box. Respiratory epithelium. Okay, good. So what is this? So this is actually a case of a papillary thyroid carcinoma infiltrating into the trachea. And that's why this cartilage. And I just wanted to show you the epithelium and the cartilage. So this is a papillary thyroid carcinoma showing the nuclear features and infiltrating deep into the trachea. Okay, coming to case number 9, 54-year-old female presented with multiple nodules in both lobes of thyroid, and she gives a history of surgery. We don't know the site. About 10 years ago, total thyroidectomy was done. So here you can see that the thyroid gland is replaced by showing multiple gray white nodules, and both the lobes are affected. Some are looking fleshy, some have areas of hemorrhage and necrosis. So this is the microscopy. Can anyone say what it looks like? She gives history of some surgery. Female patient surgery. What do you think this is? Sorry.
Metastasis.
Metastasis. Yes. From where do you think this can be?
Breast.
Breast. Excellent. So this was a case of a met breast carcinoma to the thyroid. So very rare phenomenon of finding met to the breast, met to the thyroid. Okay. So this is a this is a metastatic breast carcinoma to involving the thyroid gland. So tumors that involve the thyroid gland secondarily by hematogenous spread from primary sites in other organs. So it can present as a single nodule or multiple nodules. The patients present with a palpable neck mass, dysphonia, dysphagia, and most common primary is the kidney, followed by the breast, colon, and the GIT, and rarely melanoma. And the thyroid is highly vascularized, but secondary met to the gland is very uncommon. Why? There are two major hypotheses which have been put forth. One is the relatively rapid arterial flow through the thyroid, which discourages the adhesion and seeding of met. And second is the high oxygen saturation and iodine content of the thyroid gland, which itself may inhibit the growth of malignant cells. Okay. So it's very rare. It occurs in about 0.5 to 2% of resected thyroid malignancies. And as I said, most commonly it's from renal cell carcinoma, and they can grow into the interstitium, or it may grow infiltrate the follicles as well. And in such cases, always rule out direct extension from other organs like the larynx, esophagus, hypopharynx, and trachea. The 5-year survival rate after thyroidectomy is about 40%. Okay, so now again I have put up 3 more slides of MET. What do you think this is? Infiltrating into thyroid? Clear cells? Just now I told most common thing which can kidney. Yeah, renal tumor met to thyroid, and this was a lung which is metastasizing to thyroid, and this is what? Cribriform glands.
Breast.
Kidney, somebody. Okay. Cribriform gland. This is colon, which is met to the thyroid. So this was a case of a RCC met to thyroid. This is lung adenocarcinoma, and this was colonic adenocarcinoma. Okay. Okay. The last case. Okay, so 67-year-old female, known case of CA stomach, presented with long-standing diffuse nodular thyroid swelling. And clinically, they thought it was a multinodular goiter, and it also showed retrosternal extensions. And total thyroidectomy was done. So grossly, you can see that it's a large mass. The thyroid is very much enlarged, and there's a thin rim of thyroid parenchyma, and it has a neoplasm, which is showing gray white nodular areas with some amount of foci of hemorrhage, and necrosis is not very evident. At least you can see the hemorrhage, and it is fleshy and gray white. So here microscopically, this has a similar pattern of arrangement that I showed in previous slide. That is your solid or trabecular pattern. But here you can see that the nuclear features of papillary thyroid carcinoma are not there. In the previous one which I showed, you could appreciate the nuclear features. Here it is not there. And here you can see that there are some mitosis here and there, atypical mitosis. So what do you think this is? With a solid growth pattern and mitosis, this I told in one of the differentials of your solid or trabecular variant. Something in the chat box. Poorly differentiated. Excellent. So this was a poorly differentiated thyroid carcinoma. Okay. And here you can see some amount of necrosis that you can appreciate, and the peritheliomatous growth pattern. Okay. So poorly differentiated thyroid carcinoma. So now this poorly differentiated comes under it's a subtype of a high grade follicular cell derived non-anaplastic thyroid carcinoma. Okay. It's a carcinoma of thyroid follicular cells having high-grade features as defined by mitotic count and tumor necrosis without anaplastic histology. Okay, they can either be poorly differentiated or they can be differentiated high-grade. Differentiated high-grade include either the papillary or the follicular variant, which is showing high mitosis or necrosis. Okay, so in poorly differentiated, there is loss of architectural and cytological differentiation, but in differentiated ones, the architectural features are preserved. Architectural and cytological features are preserved. Okay, for example, in a papillary carcinoma with differentiated high-grade areas, there will be nuclear features of papillary carcinoma, but in addition, you will see high mitotic activity and in necrosis. Okay, so this poorly differentiated occurs in older patients, more common in Europe and South America than US. Iodine deficiency may be a risk factor. Some may arise de novo and some may arise from dedifferentiation of follicular or papillary carcinoma. They present with a solitary mass or they can be multinodular as well, and has nodal and hematogenous met in about 50% of cases. Okay, and rarely can also develop in the sites of ectopic thyroid like mediastinum, thyroglossal duct cysts, and in the ovary in the context of stroma ovari. May be associated with RAS and BRAF mutations and also mutations of P53, TERT, CTNNB1, and AKT1. Their large tumors may present with pushing margins and can have satellite nodules. So there are some diagnostic criteria for your high-grade follicular cell-derived thyroid carcinomas, which include the poorly differentiated and the differentiated. So in the poorly differentiated, you have the Turin criteria, okay, where you take into account the architectural pattern and there is absence of nuclear features. There is a solid trabecular growth pattern with absence of nuclear features of PTC and at least one of the following, like mitosis more than 3 per 2 millimeter square, tumor necrosis or convoluted nuclei, and no anaplastic features. Then it is called as a poorly differentiated thyroid carcinoma. In a differentiated high-grade thyroid carcinoma, the architectural pattern will have either the papillary, follicular, or solid with any nuclear features and at least one of the following two features, that is mitosis more than 5 per 2 millimeter square with tumor necrosis and no anaplastic features. So these two you should remember, the Turin criteria and the differentiated high-grade thyroid carcinoma criteria. Okay. And the staining for thyroglobulin is usually reduced and it's usually in a kind of a paranuclear dot-like pattern as seen in this picture. The treatment of choice is total thyroidectomy with neck dissection with radioactive iodine and suppressive thyroxine. The overall survival rate is about 60 to 70% and it is poor prognosis associated with high stage and older age, more than 45 years. And differentials as in this case is your differentiated high-grade carcinoma, anaplastic thyroid carcinoma, medullary thyroid, and the previous one, as I told, the solid or trabecular variant. But in this case, there were no nuclear features of PTC. Okay, this is the 2022 WHO classification of thyroid neoplasms, where they have divided the thyroid neoplasms into benign tumors, low risk, and malignant, and then we have the C cell derived carcinoma, mixed medullary follicular cell, salivary gland type, and uncertain histogenesis. So the previously the cribriform morula variant, which was under the PTC, has been put under this. So this you can go through the WHO book for the classification. Okay, this is another a kind of flow chart, which you can read this article, that is high-grade non-anaplastic thyroid carcinomas of follicular cell origin. So based on the presence of anaplasia, the growth pattern, the nuclear features, and mitosis, how would you either call it either as a high-grade differentiated or a poorly differentiated type? Okay, so you can see, look at this diagram. This article is very good. You can read this. The same thing which I described, the mitosis and the necrosis. Okay, so this was a case of a differentiated high-grade papillary thyroid carcinoma. Here you can see that the tumor cells are arranged in papillae and they are showing the nuclear features of PTC, but it is having necrosis and high mitotic activity. So this was a case of high-grade differentiated PTC, and this is a case of a high-grade differentiated follicular carcinoma. It is showing the follicular pattern of arrangement with high mitotic activity. Okay. So I have finished my cases. I'm just putting some spotters. So there are just 4 spotters. It's just for fun. Not just fun, it's also a good learning experience. So this was a 45-year-old female, solitary nodule in the right lobe of thyroid, and hemithyroidectomy was sent for frozen section. So I've given 2 arrows for the clues. So what do you think this is? Spotter. Frozen section spotter. 2 arrows.
Vascular invasion.
Excellent. And other arrow? This arrow?
Capsular invasion.
Excellent. So this was the follicular neoplasm with capsular and vascular invasion. So we call it out as a follicular carcinoma. This they sent to us for frozen section. It's quite difficult to actually see on frozen, but we were lucky that we could see these 2 features. So the diagnosis of FTC requires capsular and or vascular invasion, and it is divided into 3 subtypes. The minimally invasive, which shows only capsular invasion, the encapsulated angioinvasive, where venous invasion is present with or without capsular penetration, and those with less than 4 vessel invasion have a better prognosis. Then you have a widely invasive, where there's extensive invasion into the thyroid and extrathyroidal soft tissues. Okay, so this is a case of a follicular thyroid carcinoma with some amount of capsular invasion. See on gross, you can see this, and same thing on microscopy, where it is infiltrating through the capsule. This is a case of a widely invasive. See multiple tumor foci infiltrating through and through the capsule, going into the surrounding tissue. Okay, and this was a case of a minimally invasive follicular thyroid carcinoma. You can see the mushrooming of the tumor cells through the capsule. This is a follicular thyroid carcinoma with angio invasion. So CD34 is again highlighting the endothelial cells. Okay, next spotter. So 25-year-old male who presented with multiple nodules in the neck and thyroid, and it is a known case of Men syndrome. That's what they said. And this was sent to us for frozen section analysis. Okay, this is a quite a difficult case, but at least you can attempt. So what is this thing on under green that I have marked? Chat. Parathyroid. No, something with the para only. Something starting with para only. In the neck that you can get. Excellent. So this was a case of a paraganglioma. So the thyroid was normal, but adjacent to the isthmus in the adjacent fibroadipose tissue, there were multiple tiny paragangliomas. Okay, so whenever we think of men, we always think of medullary. Even we were thinking whether this is a medullary carcinoma, but it was actually a paraganglioma in the adjacent fibroadipose tissue. So it was a carotid body tumor. Most common extraadrenal location is the head and neck. Okay, and it has the characteristic Zell-Ballant pattern. Okay, I'll not go into the details, maybe associated with RET mutation, VHL mutations, and a pheochromocytoma is reserved for paragangliomas of the adrenal medulla. Okay, one more spotter. Sorry, I think this is covering this. This was a female who presented with retroperitoneal mass and lymph nodes. So, adrenal mass and lymph nodes. So, 3 things that I have put up. What do you think this is? Okay, paraganglioma. Sorry. Same thing. This was again a paraganglioma, but it was a metastatic or a malignant paraganglioma. Okay, it's a high-grade tumor showing areas of necrosis, vascular invasion, and lymph node met. So you call it as a metastatic paraganglioma. Okay, so whenever you see a pheochromocytoma of the adrenal gland, there is something called as the PAS score. Okay, that is that you have to include in your histopathology report. That is the score to determine the malignancy. Okay, these include the these features, that is periadrenal adipose tissue invasion, mitotic activity, presence of atypical mitosis, necrosis, cellular spindling, nuclear pleomorphism or monotony, diffuse growth pattern, high cellularity, capsular or vascular invasion, and hyperchromasia. So these are the scores that you give. And if it is more than score, it is concerning for malignancy. And then if you also have your clinical biochemical assays, you can include these and you can give out the gap score, where it is again classified into a well-differentiated, moderately differentiated, or a poorly differentiated tumor. So remember the gap score and the PAS score for pheochromocytomas. So the last case, 28-year-old female presented with loss of weight and skin lesions, and then you have a abdominal lesion. So what do you think this is? Very easy. Site of diagnosis, site of biopsy and diagnosis. Granuloma, excellent. So this was an adrenal gland and showing lot of granuloma. And this was a case of an Addison's disease. So it was secondary to tuberculosis. And in this case, the AFB came positive. Okay, so Addison's disease, causes include autoimmune disorders, infections, and space-occupying lesions within the adrenal. And laboratory findings include increased ACTH levels and low cortisol levels. Okay, so thank you so much, ma'am. I hope I could cover many of the cases, but again, somebody was, there were other wonderful speakers who were talking about pancreas and also the breast. So I didn't include those in my talk. I hope I did a decent job of covering the important cases that will be helpful for the exams. And it was a great working with all of you, ma'am. Thank you so much for making me part of this CARE-PARE program.
It was so good, so good. You've covered almost most of the lesions in a very short time. That is, I mean, it's amazing. Without making it look like it's too crowded. It wasn't too crowded. At the same time, you covered everything, and your frozen sections are amazing, especially the one with capsular and vascular.
Yes, ma'am. Yes, ma'am. That
All
was,
of
we
us-
were lucky to get it, ma'am. Yes, ma'am.
all of us will wish for having such kind of frozen sections to report, to give a, very categorical report. Otherwise, we always have to tell the clinician,
Yes,
no,
ma'am.
not looking at it. So you may have to wait for the definitive report, all those
Yes,
things.
ma'am. Yes, ma'am. Yes, ma'am.
Wonderful. I mean, it's you got a beautiful case collection. Very
Yes,
good.
ma'am. I would like
So
to thank
much.
all my colleagues, ma'am, my HOD, Rekha madam, and all my colleagues like Dr. Divya Shanti and Dr. Chaitra for helping me out to pull out all the cases, and all my students and the technicians, and also the digital pathology for helping me to scan and take the images. Unfortunately, I could not give the link, ma'am. We could not get the link to be given to the external people, but as soon as I get the link, I will share it with you, ma'am. The link for the slides. Yes, ma'am.
Thanks a lot. Thanks a lot.
Thank
I
you,
think
ma'am.
next year again we'll call you. We may be calling you to come real time in person here.
Thank you so much, ma'am. Thank you so much.
Thanks a lot for the effort and the time, Dr. Selection.
Thank you, ma'am, for giving me the opportunity.
Thank you, ma'am.
Thank you, ma'am, for the wonderful session. There are comments in the chat box also thanking you, ma'am, for that
Yeah.
session.
Yeah, thank you so much. Thank you so much.
Hello? Yes, ma'am. Appreciation, ma'am. We have just displayed the certificate for you, ma'am. Thank you, ma'am, once again.
Thank you so much. Thank you.
And now we'll move on to our next speaker for the day. I request Dr. Blessy to introduce the speaker.
Ladies and gentlemen, esteemed colleagues, it is a privilege to introduce our next speaker for the day, Dr. Vinay KS, an esteemed expert in the field of renal and transplant pathology. Dr. Vinay currently serves as an associate professor at the Institute of Nephrourology, Victoria Hospital campus in the Institute of in Bangalore, Karnataka, where he has been making significant contributions for the past 6 years. Dr. Vinay completed his MBBS at JJM Medical College in Davanagere and pursued his MD in pathology at BMC and RI in Bangalore. Further honing to his expertise, he obtained a postdoctoral certificate in renal and transplant pathology from IKDRC and ITS in Ahmedabad. His professional journey includes valuable experiences as a senior resident at JIPMER in Pondicherry and as an assistant professor at BIMS in Belgaum. Dr. Vinay also worked as an associate consultant nephropathologist at Manipal Hospitals in Bangalore, where he further deepened his practical knowledge in the field. With numerous publications in both national and international journals, Dr. Vinay is recognized for his dedication to advancing research in pathology. Notably, he received the Young Investigator Award for his impactful study on the renal allograft biopsies, which evaluated patients under the Ahmedabad Tolerance Induction Protocol. His areas of interest include uropathology, renal and transplant pathology, and immunology, to addressing critical issues in these fields. Please join me in welcoming Dr. Vinay KS, a passionate researcher and educator, as he shares his insights and expertise with us today.
Hello, Dr. Vinay. How are you?
Hello, madam. Hello, madam.
Thank you
Namaste.
for accepting our invitation.
Thanks, madam. Thanks a lot.
As always, we are looking forward for your session.
Yes, madam. And thanks a lot, madam. Shall I share the screens now?
Sure. Yes.
Okay. So, good afternoon, everyone. At the outset, I would like to thank organizing chairman, Dr. Vijayashree madam, and organizing secretary, Dr. Navya, for giving me this opportunity. So it is almost fifth session, pre-lunch session. I would like to, and again, topics are kidney and bladder tumors. I will try to keep it simple. Am I audible?
Audible, sir.
Okay. Thank you. So to begin with, renal cell tumors, we'll first cover the renal tumors, then we'll complete the bladder tumors. So renal tumors have expanded from 4 subtypes to now almost numerous subtypes in 2022 classification. This is because in the past decades, considerable advances has been made in the molecular pathogenesis of the genitourinary tumors. So if we go back in 1997, almost we had only 4 to 5 subtypes of the renal cell tumors. So in 2004, we have almost more than 10 subtypes. In 2016, it's almost 11 subtypes. So this is the most recent one, 2022. So if you see, it is almost like more than 20 subtypes. The list is increasing. So this is the 2022. But we are interested in 2016, and that is 2016 and 2022 classification. If you overall see the some significant and much needed changes has been made in 2022 classification. So for example, all the morphologically defined and IHC or the molecularly defined, everything are put in one in 2016. But in 22, if you see the recent 5th edition, so these are morphologically defined tumors have been made in a separate category. And again, molecularly defined tumors have been made in a other category. So these were the important changes, that is regrouping, some definition changes, some nomenclature changes, and again, some molecularly defined RCC, entire separate group. So before going to the morphology of the renal tumors or the renal tumors proper, we'll just have a word about the grading and staging. So here for renal tumors, we practice WHR, International Society of Urological Pathology, nuclear grading. So this grading is based on the presence and prominence of the nucleoli. So grade 1, if the nucleoli are almost absent or inconspicuous and they are basophilic, even at higher magnification. Grade 2, eosinophilic nuclei are observed at high magnification, but they are not prominent at 100 magnification. So grade 3, nucleoli are prominent and eosinophilic even at the 100 magnification. Whereas the grade 4, it is almost like the other spectrum, highly pleomorphic cells, tumor giant cells, the sarcomatid or rhabdoid differentiations. So in this case, if you were to grade these tumors, this would be grade 1, and this would be grade 2, some occasional nucleoli, and this could be grade 3. And this is highly pleomorphic cells with almost all of them having prominent nucleoli. So this is grade 4. So I want to highlight one point here, that grading should be based on the highest grade, which you see at least in one high power field. This is the one we should follow. As we are discussing the grading system, 2022 grading, again, in that this grading is not applicable in these tumors. This you are supposed to remember. This chromophobe RCC and TFE rearranged RCCs, we are not applicable the grading. Again, there is some misleading of this grading in some of the tumors, because some indolent tumors have high grade morphology like tubulocystic, acquired cystic, eosinophilic solid cystic, and eosinophilic vacuolated. And some of the tumors, they have limited data on the significance of this nuclear grading. So as of now, we'll just remember that nuclear grading is not applicable in chromophobe and TFE rearranged RCCs. And this is a recent article, which is very good one for your further reading in archives. So coming to a few words about staging, here the renal tumors is the tumor where size does matter. We are interested in tumor staging, and I'm not going into it, just will focus on T1, T2, T3. So T1 tumor 7 centimeters or less in greater dimension, and it is limited to kidney. It is 1A and 1B further subdivided. So tumor 4 centimeters or less. So if it is more than 4 but less than 7, it is 1B. T2 is tumor more than 7 centimeters. That is 2A and 2B further subdivided. Tumor more than 7, but it is less than 10. If it is more than 10 centimeters, it is 2B. Then T3, in this mainly we are focusing on the involvement of the tumor with the renal vein or the segmental branches. Again, 3A, involvement of the renal vein and the segmental branches. 3B, involvement of vena cava below the diaphragm. And third one will be the above diaphragm. So while grossing, it is very important. We focus on the centimeters. That is, here the cutoff is 4 centimeters, 7 centimeters, and 10 centimeters. And grossly, you have to look for the involvement of the renal vein. So with this, we'll go with the morphology of the renal tumors. So we'll just discuss the morphological categories first, then molecularly defined categories. Then we'll try to combine both this morphology and immunologically for the differential diagnosis. So just like 2022 5th WHO Blue Book will follow. So renal tumors with clear cytoplasm, in this clear cell RCC is the most common subtype with 60 to 75% of all RCCs. It is mostly sporadic, but again, germline mutations of VHL gene. So whenever we say mutations or syndromic association of renal tumors, always remember the tumors will be numerous. They can be bilateral and occur at an young age. When you say sporadic, usually they are solitary, they are unilateral, and at an later age group. So this tumor, clear cell RCC, so this is very well circumscribed with, there may be pseudocapsule, and classical golden yellow with variegated appearance of hemorrhage and necrosis. So corresponding microscopy, They usually nested a tubular architecture with a striking cells with optically clear cytoplasm. So here IHCs, that is carbonic anhydrase 9, will be membranous pattern, that is characteristically defined as box-like positivity, whereas CD117 will be negative. So coming to differential diagnosis, I will just enlisting the important differential diagnosis and then one important IHC marker for the same. As we are all discussing in the coming slides, I will not go in detail in the differential diagnosis. So clear cell papillary renal cell tumor. So cup-like pattern of CA9 positivity. Then TFE related tumors. Again, IHC TFEB will be positive. And multilocular cystic renal neoplasm of low malignant potential, we are discussing in the next slide. So this is the multilocular cystic renal neoplasm of low malignant potential. So prior to 2016, this was known as multilocular cystic RCC. So the RCC, the term has been replaced by low malignant potential. Why? Because there are no reports of recurrence or metastasis on the long-term follow-up. So as the name suggests, so this is the cystic on gross with multiloculations, you can see. So correspondingly, the microscopy will show the multiple cystic areas with the cyst wall will be lined with optically clear cytoplasm. And if on high magnification, you can see these cysts are separated by the septae. These septae, if you carefully see, you are seeing the clear cells. These are the tumor cells. And characteristically, these tumors are non-expansile. So this word is important, non-expansile of the septae. So it qualifies for the low malignant potential with excellent prognosis. So coming to renal cell tumors with papillary architecture. So in this papillary adenoma, so this is again where the size does matter. It is less than 1.5 centimeters or less than 15 millimeter. Otherwise, the morphology resembles like the papillary RCC. Usually, this is common in ESRD patients, acquired cystic disease, and patients with hereditary papillary RCC associated. So this is the typical light microscopy when you see under microscope. So surrounding all renal parenchyma and usually some focus or some nodular area with this showing this papillary tumor. So coming to papillary RCC, again papillary RCC is the second most common type of RCC subtype, usually common in chronic renal disease and acquired cystic disease. It can be sporadic and again hereditary papillary RCC, germline mutation of MET oncogene. So for clear cell VHL gene, for papillary this is MET oncogene. So grossly again, these are the well circumscribed with or without capsule. Again, yellowish tan with, if you carefully observe, some friable or granular appearance on gross will be seen. So this this corresponds to the papillary structures which we are seeing on any other papillary tumors in the microscopy. So coming to morphology, in the morphology previously papillary RCC we used to describe as type 1 and type 2 RCC. Recent 2022 WHO has removed the type 1 and type 2 morphology. So type 1 and type 2 we are no need to report. So instead of that is only one classical pattern. What is this? So these are papillary and tubular structures which in turn are lined by these cuboidal cells with scant basophilic cytoplasm. So fibrovascular cores, you can see foamy histiocytes. And in these tumors, instead of papillary, you can see some homobodies also. Coming to IHC, there will be diffuse strong positivity for AMACAR and CK7. Again, more favorable prognosis in other subtypes. So in recent 2022 WHO, along with the classical morphology, he also mentioned two other morphological patterns. One is biphasic pattern, another in papillary neoplasms with reverse polarity. So this biphasic, as the name suggests, you will have two population of cells. So this one is the surrounding cells and central arranged like a glandular lumen, and this lumen will be filled with squamate appearing cells. And you can have that brisk inflammation with some emperipolysis also. So overall mimicking like a Warthin's tumor of the salivary gland. So this is the biphasic pattern. Whereas the papillary neoplasms with reverse polarity, as the name suggests, reverse polarity means the nuclei will be coming towards the apical region. So characteristically, this is IHC will be GATA3 positive in this. So papillary RCCs, we have classic pattern, biphasic pattern, and papillary neoplasms with reverse polarity. So the differential diagnosis, the list is more. We'll just go through it. Eosinophilic solid and cystic RCCs, which is positive for CK20. Tubulocystic RCC, we should exclude other tumors. Fumarate hydratase deficient RCC, again IHC we have to do, FH will be deficient. collecting duct RCC, so it will be high molecular weight cytokeratin, TFE rearranged RCCs. So RCC now, that is oncocytic tumors, basically renal cell tumors with eosinophilic cytoplasm. In this, the first will discuss the benign one. So this is the oncocytoma. It is a benign tumor. It can be sporadic or hereditary. So here what we are assuming, it can be associated with Birt-Hogg-Dube syndrome. So grossly, these are unencapsulated, very well circumscribed. The characteristic color, the mahogany brown, which will see, it is characteristic. Along with the center, stellate scar can be seen. So this is the characteristic gross appearance. Coming to microscopy, we can see nests and trabecula of the cells with eosinophilic uniform granular pattern or compact nuclei. So before going on, one more thing, in these tumors, some focal areas you can see highly hyperchromatic nuclei with pleomorphism or pleomorphic cells with pleomorphic nuclei. So this is nothing but degenerative atypia, which is more commonly seen in this renal oncocytoma. So IHC, before going to IHC, one more special stain here, Hales colloidal iron stain can be used, but again, it will be negative. It will be helping differential diagnosis with chromophobe. IHC will be positive for CD117 and CK7 will be negative. So the next, coming to chromophobe RCC, this is the third most common RCC subtype overall. Again, it can be sporadic, and if it is syndromic, it can be two, that is Birt-Hogg-Dube syndrome and Cowden syndrome. So clear cell we VHL, then papillary, we discussed MET oncogene, that chromophobe oncocytic, at least you should remember these two, Birt-Hogg-Dube and Cowden syndrome. So grossly, this resembles like a oncocytoma, that is mahogany brown or tan brown color. However, that central scar will be usually not seen. But again, 10 to 50% of the cases, it is, you can see, you may rarely see. Coming to morphology, morphology has some characteristic cellular appearance. So you can see these cells with very prominent cell membranes, that is plant-like cell wall membranes with compact nuclei, and the cytoplasm will be pale or some reticulated pattern. You can see that reticulated pattern. And nuclear features, additionally, you have resinoid or that wrinkled nuclear appearance, then perinuclear, that is called a cytoid appearance. So these are the ones you are supposed to remember: prominent cell membranes, reticulated cytoplasm, wrinkled nuclear membranes, that is resinoid appearance, and perinuclear clearing. So this is the characteristic morphology. And before going to IHC, special stain, again, it will be useful in most of the times. Hales colloidal iron stain, it will be positive, whereas it will be negative in oncocytoma. Coming to IHC, again, CK7 and CD117 will be positive. So in spite of all these morphological features, sometimes it may be difficult to differentiate chromophobe versus oncocytoma on light microscopy. At that time, IHC will be useful. However, CD117, both are positive, so it is not useful. Whereas your CK7 and S100 will be helpful. So CK7 will be positive in chromophobe RCC and it will be negative in oncocytoma, whereas S100 will be negative and positive in oncocytoma. So CK7 will be helpful. Coming to differential diagnosis, one is oncocytoma, we already discussed. Then SDH deficient RCC, we'll discuss in the coming slides. Then very rarely oncocytic angiomyolipoma. Just remember angiomyolipoma, they will be positive for melanocytic markers, HMB45 and melanin. So this is the very interesting one, which 2022 WHO they have included, that is other oncocytic tumors. So apart from oncocytoma and chromophobe, so other oncocytic, what are these tumors? So these are the tumors which are not classifiable as oncocytoma or chromophobe RCCs or any other subtypes for that matter. So with a common denominator, what they have is eosinophilic or oncocytic cytoplasm, which show overlapping and intermediate features between the oncocytoma and chromophobe RCC. These can be sporadic. Mostly they are sporadic. However, again, tuberous sclerosis and Birt-Hogg-Dube syndrome can be associated. 2022, he mentions two further entities in this other oncocytic tumors, which we are supposed to remember. One is the eosinophilic vacuolated tumor. This is an emerging entity. The other one is the low-grade oncocytic tumor. So eosinophilic vacuolated tumor, we'll just remember the morphology. These are, as the name suggests, eosinophilic tumor cells, and the tumor cells have large cytoplasmic vacuoles. Here you can see the cytoplasmic vacuoles. And again, if you see the nuclei are almost, they have nucleoli very high grade appearing. However, the behavior of the tumor is very indolent. Again, CD117 and CK10, CD10 positive. So apart from eosinophilic, then we have low-grade oncocytic tumors. This is typically low-grade tumors, old patients, non-syndromic. Again, characteristic, that is low-grade morphology of oncocytic tumors. But again, IS is very important here. Characteristic strong CK7 positive, whereas CD117 will be negative. Because this oncocytoma and chromophobe, their CD117 is positive, but it is negative here, and CK7 is positive. Coming to this other very highly aggressive tumor, collecting duct carcinoma. However, this is uncommon subtype. These are all medullary based. The previous, which are all we discussed, they're mostly cortically based tumors, whereas this one is the medullary based tumor, and they can involve even the cortex. And again, perirenal involvement is also common because of their aggressive nature. So coming to microscopy, they can be predominantly tubules, and at places tubulopapillary can be seen. On the high power, you can see these tubules are lined by hobnail cells, hobnailing of cells. Here you can see, then express high molecular weight cytokeratin. Coming to the other category, this is again other morphological category. We have not yet gone to molecular. So here we have clear cell papillary renal cell tumor, mucinous tubular and spindle cell carcinoma, tubulocystic RCC, acquired cystic disease associated RCC, eosinophilic solid and cystic RCC, RCC NOS. Here, most of all these tumors are defined by their names. So it is easy to remember. We'll just rush through. So this is clear cell papillary renal cell tumor. So this is a papillary tumor. So papillae will be seen, and these papillae are lined by clear cells. So clear cell papillary, and again renal cell tumor. Why? Because previously it was called renal cell carcinoma, clear cell papillary renal cell carcinoma. But because of its indolent behavior and very good prognosis, the term has been changed to clear cell papillary renal cell tumor. So these are the papillary structures with clear cytoplasm. Again, IHC, it will be positive for CN9, that is carbonic anhydrase 9. The characteristic IHC pattern is also very specific in this, that is cup-like membranous staining pattern of these tumor cells. So what is this cup-like membranous pattern? So the staining will be seen in the basolateral aspect of the tumor cells. So this is the basolateral aspect, and the apical will not be stained. So this you are supposed to remember, that is cup-like membranous staining pattern in clear cell papillary RCC. This is very important. Then coming to mucinous tubular and spindle cell carcinoma, as the name suggests, you will have that mucinous, that is extracellular basophilic mucin, then tubular structure. So anastomosing tubules will be seen. These will be in blending with the some bland spindle cells. So you are seeing mucinous tubular and spindle cell carcinoma. So IH is again CK7 will be and AMACAR positive. Now coming to tubulocystic. So tubulocystic, as the name suggests, this is again cystic on gross appearance. Characteristic gross appearance is again defined for this in WHO. That is spongy appearance or bubble wrap appearance. So bubble wrap appearance, you can see tiny cysts. These tiny cysts can be filled with that clear fluid. So this you remember, spongy for bubble wrap for gross discussions. Then corresponding microscopy, again you will have tubulary structures admixed with the cystic structures. Cystic structures are lined by these hobnail cells. Again, very indolent tumor with very good prognosis. Now coming to acquired cystic disease associated RCC, again as the name suggests, it is most commonly seen in acquired cystic disease after long-term dialysis. So acquired cystic disease is a risk factor for RCC. So more than 100 times compared to general population. So grossly you can see that multiple cysts can be seen. Coming to microscopy, again that morphologically we can see that large eosinophilic, whatever this cribriform appearance or the sieve-like pattern. This is because intercytoplasmic or intracytoplasmic vacuoles is very evident in this. This acts as a morphological clue for this acquired cystic disease. Again, you will have obviously the other history available. Again, very indolent course. Coming to eosinophilic solid and cystic RCC, this is a new entity in 2022. So it can be sporadic and associated with TSC, that is tuberous sclerosis. Grossly also solid, it can be cystic, and microscopy will have that solid areas as well as cystic areas. These cystic areas, if you see, these are again lined by the hobnail cells, whereas the solid areas, as the name suggests, it is very eosinophilic cytoplasm, eosinophilic granular cytoplasm. But the important clue here is you may have some purplish or eosinophilic granules here. If you carefully see, you can see the granules. These granules almost looks like a reminiscent of leishmaniasis. So this is a morphological fluke for this tumor. So foamy, again, apart from that, you can see foamy histiocytes and some bodies. CK20 is characteristically positive. So ISC is positive in CK20 compared to other tumors. So now coming to RCC NOS. NOS not otherwise specified. It is a class where it was previously known as unclassified RCC. So where any tumor which cannot be classified into any of the known RCC subtypes usually will be put in this category. Usually the sarcoma, pure sarcomatoid morphology of tumors will be put in this, and again not classifying for any gross or microscopic definition. So appearance again, sarcomatoid appearance will be there, very aggressive clinical course. So we completed the morphologically the different renal tumors. Now we are coming to the molecularly defined renal cell carcinomas. In this we have TFE3, TFE3 rearranged and TFEB altered. So it is rearranged and altered. Then aloxia or alongin C mutated RCC, then fumarate hydratase deficient RCC, succinate dehydrogenase deficient RCC, ALK rearranged RCC, SMARC-B1 deficient renal medullary carcinoma. So to begin with the TFE rearranged, as the name suggests, the gene fusions will be involving altered TFE, and the risk factor will be prior exposure to cytotoxic therapy. Most of the pediatric tumors, up to 40%, they are associated with the TFE mutations. Here we have mixed histological pattern. So what is just before we go into morphology of all these molecularly defined tumors will have mixed morphological pattern. So what is this mixed morphological pattern? So you can have clear cell morphology, you can have papillary morphology, you can have oncocytic morphology mixed together. So that's why we cannot morphologically define to a particular category. So here mixed histological pattern, but however, some tumors are morphologically predominantly some patterns will be there. So like this here, TFE rearranged RCC will predominantly have papillary neoplasm. So papillary architecture will be there. So these papillary structures, these if you see, these are lined by the clear cells. So you can have these samoma bodies as it is a papillary architecture. So this IHC, TFE IHC is strong nuclear positivity will be very specific and sensitive for this TFE rearranged and even altered tumors. So these are molecularly defined. So molecularly defined alteration of TFEB rearrangement, you can identify by these two tests, that is RNA sequencing and break apart FISH. Will not go in detail. I will just mentioning it. Most of it they are defined by this technique. Then TFE altered RCC. Again, the same TFEB transcription factors are involved, but different mutations. Here, the characteristic morphology is they give biphasic neoplasm. Biphasic neoplasm, as the name suggests, that is two cell population will be seen. If you see here, the peripheral larger cells or epithelioid cells will be seen, and center some small cells. These small cells almost look like a lymphocytes, or the size of the lymphocytes only. Again, these seem to arrange around the basement membrane-like material. So this is the characteristic morphology, or the very morphological clue which we should pick up for this TFB altered RCC. And again, IHC if you do, TFEB will be nuclear positive. Again, break apart FISH and SNA. Again, these are very aggressive tumors. So previously, these TFEB and TFPB rearranged and altered were together called MIT translocation factors, MIT RCCs. So coming to ALOC or alongin C mutated RCC. So these are mutations, as the name suggests, in the ALOC gene. Approximately very few, that is only 20 cases or few cases reported. So if you see the morphology, here it typically appears like a clear cell RCC. So if you're clear cell RCC, but however, if you carefully see at the low power, you see some nodular appearance. So why this nodular appearance? Nodular appearance due to transecting fibromuscular bundles, some transecting fibromuscular bundles around this tumor cells. So this is the characteristic microscopic appearance. And again, if you do IHC, CK7 will be positive, and again it is molecularly defined by the ALOC mutations. So recent WHO even mentions that if you are seeing the clear cell RCC-like picture with this nodular appearance with fibromuscular bundles separating the tumor cells, and again if they are CK7 positive, you can almost give a differential diagnosis or the diagnosis of ALOC mutated RCC. So coming to fumarate hydratase deficient RCC, again, these are alterations in the FH gene. They're very aggressive. As it is molecular defined, you will have mixed morphological patterns. Again, you can have predominantly papillary pattern here. But one striking morphological clue here will be some focally cells may show very high-grade nuclei with very prominent eosinophilic macronucleoli. So that may be a clue here. Coming to IHC, as the name suggests that fumarate hydrate is deficient. So fumarate hydratase, if you do, it will be negative in the tumor cells. Whereas the other like structures in the renal parenchyma or the blood vessels, all other tissues will express this fumarate hydratase. So this is basically that Krebs cycle enzyme. Whereas tumor cells will be deficient. So this will be an important IHC marker. In addition to this, we have 2-succinylcysteine. Those 2-succinylcysteine is an aberrant expression. So it is aberrant expression, 2SC will be positive. So again, these are very aggressive tumors. Now coming to succinate dehydrogenase deficient RCC. So this is due to inactivation of any one of the SDH genes. You can see oncocyte, again pink tumor. So oncocytes will be predominant, but again morphological clue, if you see cytoplasmic vacuolation or some bubbly appearance will be seen. So this will be a morphological clue for these SDH deficient tumors. Again, as the name suggests, succinate dehydrogenase enzyme, Krebs cycle enzyme in our mitochondria, that is, it will be again deficient in the tumor cells. So FH, SDH, if you interpret the IHC, the tumor cells will be negative, whereas adjacent renal tubules, even blood vessel cells, everything will be positive. And again, it's a favorable prognosis. Coming to the next one, ALK rearranged RCC. Here the translocations involve anaplastic lymphoma kinase gene. Very few cases. Most common point which we have to remember here is young patients with sickle cell trait. These are the one who are associated with ALK rearranged RCC. So coming to these are again eosinophilic cells with characteristic cytoplasmic vacuoles will be seen here. And if you carefully see these RBCs, they have some sickled appearance. So sickle cell, always remember ALK rearranged RCC, sickle cells. Then again IHC, ALK positivity. Why it is important to identify this? We have the targeted therapy for, that is ALK inhibitors can be given for this. Even advanced cases have very good prognosis. So this is, though they're rare, we have to remember this one. Then coming to SMARCB1 deficient renal medullary carcinoma. So this is nothing but our previous renal medullary carcinoma, which is an aggressive tumor, but they identified that SMARCB1 will be deficient in this. So that's why it's renamed as SMARCB1 deficient renal medullary carcinoma. And most of the reported literature or the cases, they have African ancestry. Again, hemoglobinopathies. They are associated with the hemoglobinopathies like sickle cell trait and hemoglobin SC disease. That we have to remember. That is previous ALK and SMARCB1, hemoglobin and sickle cell. These are again medullary centered tumors. The striking morphological appearance here will be cribriform pattern. So cribriform pattern because of this empty appearing. So what are these empty spaces? These empty spaces may be due to individual cell necrosis, giving it an empty appearance. Again, along with that, you will have that dense inflammation can be seen admixed within the tumor cells. And again, desmoplastic stroma. So this one will be the morphological clue. And as the name suggests, IHC will be the same, deficiency, that is loss of SMARCB1. So because of his medullary location and some morphological resemblance, even high-grade urothelial carcinomas can become to a differential diagnosis. Again, the issue can be settled with GATA3. So we completed the morphological and molecularly defined. Now we'll try to correlate with the IHC and morphology. So IHC panel. So in 2022, WHO immunohistochemistry plays an important role in bridging the morphology and genetics. But however, we can't use a single IHC marker. It is always ideal or essential to use the panel of markers. So which are the panel of markers? So these are the panel of markers which are used for renal panel. I am not going in detail as we discussed. So this is like a mini algorithm which I prepared. So basically here morphologically appearance, whether it's clear cell, papillary or oncocytic. I have taken clear cell RCC as a prototype in this clear cell tumors. So clear cell RCC, the IHC I have mentioned CN9, that is circumferential positivity and CD positive. Whereas the differential diagnosis for this clear cell will be clear cell papillary renal cell tumor, which we already discussed, that is CN9 will be cup-like membranous positivity. Then again, alloc mutated RCC positive for CK7. Then TFE tumors. TFE we discussed both in clear cell as well as papillary. This is a mixed pattern. Again, positive for TFEB, nuclear positivity. Again, this multilocular cystic renal neoplasm of low malignant potential. Here, ISC is not much useful. It's a low-grade tumor which we can diagnose with morphology. So, this coming to papillary tumors, this papillary RCC I have taken as a prototype. And again, IHC will be AMACAR and CK7 positive. So, differential diagnosis will be FH deficient and IHC will be FH deficiency. Then tubulocystic by exclusion of other tumors. Collecting duct RCCs, high molecular weight cytokeratin. TFEB arranged, again, we are discussing it here also. Nuclear TFEB will be very specific. Then metanephric adenoma, sometimes it can be a differential diagnosis for completion sake. However, it will be positive for WT1 and CD57. Coming to the oncocytic. So oncocytic, the list is enlarging and lot of data, lot of literature is coming on these pink tumors or the oncocytic neoplasms. However, chromophobe RCC is still the prototype and IHC CD117 positive and CK7 are very useful in this. Renal oncocytoma, we discussed CD117 positive, CK7 is negative. Then eosinophilic vacuolated tumor, cathepsin and CD117 positive. Low-grade oncocytic tumor, that is a new category. So CK7 will be positive, CD117 will be negative. Then clear cell RCC, that is eosinophilic variant, CA9 positive, SDH deficient, as it is SDH will be deficient, and eosinophilic solid cystic, CK20 will be positive. And again, for completion sake, epithelial angiomyolipoma. So this is HMB 45 and melan A. So this, before we conclude, to summarize, so this new WHO 22 5th edition, morphologically similar tumors they have put up in separate group. Molecularly defined tumors also they have put up in separate group. But still morphology plays a very important role for criteria for classification. And IHC helps in the differential diagnosis and it acts as an ancillary tool. So bridging the morphology and the genetics. So molecular tests again break apart fish and RNA sequencing for identifying the molecular mutations. And one more change they have given useful, which is very useful, is for each tumor they have mentioned minimal essential criteria and desirable criteria for a reliable diagnosis. When we have any diagnostic dilemma, we can see that by definition whether this tumor fits there or not. That is one thing. And some nomenclature changes which we are supposed to remember is papillary renal cell carcinoma type 1 and type 2 in 2022. It has been removed. And renal medullary carcinoma previous, it is labeled as mark deficient RCC. Then MIT family translocation RCCs, now they have made in two, that is TFE rearranged and TFEB altered RCC. Then clear cell papillary renal cell carcinoma, that carcinoma has been replaced by clear cell papillary renal cell tumor. Then hereditary leiomyomatosis and renal cell carcinoma associated RCC, the longest name. So now it has become FH deficient. Then other oncocytic tumors, there is the new category, that is eosinophilic vacuolated tumor and low-grade oncocytic tumors. And in this eosinophilic vacuolated tumor is one of the emerging entity. So which are the new entities? The new entities are eosinophilic solid and cystic RCC and alloc mutated RCC and ALK rearranged RCC. So finally, to conclude, this will be my concluding slide for this renal tumors. Look for broad morphological patterns, like whether they belong to clear cell, whether they belong to oncocytes or they're papillary. And look for very obvious or some subtle observations like obviously cribriform or cytoplasmic vacuolations or subtle observation like cytoplasmic granules. So based on that morphology, you can still come to a differential diagnosis. So as we discussed in the previous algorithm, that would be helpful. And we can next use that IHC panel after the differential diagnosis. So here, most of them, you can settle the diagnosis. If not, again, molecular and genetic test will be useful. At this juncture, I would like to mention that for in preparing these algorithmic approach, very valuable inputs were taken from Dr. Viksha. She is the oncopathologist who is working in PGH Chandigarh. Thanks, Viksha, for this. So this come to renal tumors. And I think I will continue, if it's okay, with the bladder tumors. So I will wind up. So coming to bladder tumors, just a second. Again, very interesting tumors, bladder tumors. Here again, histomorphology still remains the gold standard and IHC is not needed. And here three-tiered classification of papillary neoplasms, that is low malignant potential, low grade and high grade tumors is still maintained in the recent WHO. Again, they have proposed a comprehensive molecular classification, which is more useful for prognosis and targeted therapy. But as of now, we can't use it in routine pathology practice. More data is needed for that. So coming to bladder specimens, we receive usually TURBT, transurethral resection of bladder tumors. In this, we get by two containers, superficial tumor, where we will get the tumor, and deep muscle biopsy. So why I put is, this container 2 is very important to us. So deep muscle, because that is staging is dependent on this one. Again, cystectomy specimen, I'm not going in detail. So again, we follow 2022 genitourinary tumors, 5th edition. So if you see the WHO classification, broadly, there are only two categories. That is non-invasive urothelial neoplasms and invasive urothelial neoplasms. So this is non-invasive and invasive. So non-invasive, we have only these. That is, one is papilloma, urothelial papilloma, then inverted papilloma, then punlum. What is punlum? Papillary urothelial neoplasm of low malignant potential. That is punlum. Then again, classical papillary urothelial carcinoma low grade and high grade. Then one entity, that is urothelial carcinoma in situ. So these are all non-invasive. Whereas coming to invasive, we have conventional urothelial carcinoma, then urothelial carcinomas with divergent differentiation. So divergent differentiation means squamous, glandular, and trophoblastic. Then other subtypes. Subtypes mean basically histologically distinct types based on the morphology, that is nested, large nested, small nested, tubular and microcystic, micropapillary, lymphoepithelioma-like, plasmacytoid, giant cell, lipid-rich, glycogen-rich, clear-rich, everything. Then along with the sarcomatoid urothelial carcinoma, and finally poorly differentiated. So we'll stick to a morphological approach. So in this morphology, before going to morphology, bladder histology will discuss. That is, normal urothelium bladder will be lined with the urothelium 5 to 7 layer thick, and the superficial umbrella cells will be seen. So this will be the lamina propria. Lamina propria is, that is, loose stroma with this muscularis mucosa, discontinuous muscularis mucosa. Whereas these thick bundles will be the muscularis propria. Then we'll have perivesical fat. So at this juncture, for the histology, I will just mention that non-keratinizing squamous epithelium can be seen in trigone or bladder neck, especially in pre and post menopausal women. So we should be careful before reporting whether it is metaplasia. So just a word about muscularis mucosa, because sometimes it may be confusing with the muscularis propria. So muscularis mucosa is thin and wavy fascicles of smooth muscles. They are frequently associated with the thin-walled blood vessels. So thin-walled blood vessels, discontinuous thin wispy bundles of smooth muscles. So this is muscularis mucosa. So these are the superficial most cells, and these are the intermediate and basal cells. So we'll just go through these spectrum of neoplasms. So one is the papilloma. So papilloma, it is nothing but exophytic papillary neoplasm. So there will be thickness will be normal, thickness will not be increased. And again, remember, no cytological atypia. So just it is a papillary outgrowth, slender fibrovit having slender fibrovascular course. So ILC, if you do, it will be like normal urothelium. So what will be normal urothelium? Most commonly it is CK20 which is used. Usually CK20 will be positive only in the umbrella cells. So this is inverted papilloma. As the name suggests, the growth will be inverted. There will be endophytic growth pattern invaginating into the lamina propria. So this is the superficial lining epithelium which we will be seeing. We have to always search for this in the microscope. Then the trabecular or the cords of cells invaginating into the lamina propria will be seen. On the high power, you can see peripheral palisading and central streaming of cells. One more point about the carcinoma with inverted growth. This WHO, they says that if it is associated with severe nuclear atypia, atypical mitosis, infiltrating invasive border, but again, typically if it's more than 80%, it is having inverted pattern of growth, it qualifies for that invasive urothelial carcinoma with inverted growth. So now coming to punlump, it is the very thickened. The urothelia will be just thickened when you compare to papilloma. Again, there is no much cytological atypia. Only mild cytological atypia is accepted here. You can see it is punlump. Whereas coming to low grade, So low grade, it is a malignant. Low grade and high grade are malignant urothelial neoplasms. Fibrovascular cores will be lined by urothelial cells of variable thickness. So thickness will vary. And again, architectural, that is architectural disorder. Basically, we are comparing cyto-architectural. So nuclear features we will be seeing and architectural features we will be seeing for low grade and high grade. So urothelial cells of varying thickness, mild architectural disorder, that is branching can be seen, fusion can be seen. So nuclear atypia. So what is this nuclear atypia? So everything is mild increase in nuclear enlargement, mild nuclear hyperchromasia, mild loss of nuclear polarity, mild variation in nuclear size. However, these are all non-invasive. Basement membrane will be intact. So this is the low grade. You can see some thickening and you can also see fusion of the papillae. There is loss of polarity, some loss of polarity, mild loss of polarity. So you can better appreciate in this one. So, here, this uniform has been lost, some loss of polarity and mild hyperchromasia and some variation in nuclear size is also seen. So this is low grade. So recurrence rate will be, in bladder tumors, always remember the recurrence rate will be high. And again, some grade and stage progression. So what you understand by this grade progression and stage progression? So grade progression means the patient has come with a low grade tumor now. After 6 months, he may come with a recurrence. But if you do biopsy and see, it will be high grade tumor. That is grade progression. Whereas stage progression means now you are reported as just lamina propria invasion. Again, after 1 year, he comes with the muscularis propria invasion. That will be stage progression. So bladder is notorious for recurrence and the progression. Then coming to high grade, here all your cytological and architectural features of malignancy will be seen. That is more complex papillae will be seen, more fusion, more branching, and total loss of polarity, irregular and highly pleomorphic nuclei, frequent mitosis, everything. So this is the pictures. You can see the branching pattern, that is papillary branching, and papillae are very complex and arborizing, you can see. Whereas coming to cytology, frank malignancy, that is very hyperchromatic, total loss of polarity, pleomorphic cells will be seen. So high grade is relatively easy to diagnose. All your malignant features will be seen. So coming to IHC, IHC is not regularly needed for reporting bladder tumors. However, if you want to use, you can use GATA3, P63, CK20, CK56. Again, proliferation marker will be helpful sometimes. So GATA3, nuclear positivity, and uroplakin you can use, and P63. So before going to invasive tumors, I just want to highlight intratumoral heterogeneity. So what is this intratumoral heterogeneity? So in the same slide of the same patient, you will be seeing some of the bits will be showing this low-grade morphology, whereas some will be showing frank high-grade. So this we call intratumoral heterogeneity, and this is more characteristic of especially non-invasive papillary tumors. You can see in even 1/3 of the tumor patients. So we can report high grade as long as high grade component represents more than 5% of the tumor. So this is very important. Because in these cases, we used to report low grade and someone used to report high grade. There was no cutoff criteria. That recent 2022, WH has come with a cutoff criteria. If you are seeing more than 5% of the tumor showing with high grade morphology, label it as high grade urothelial carcinoma. So remember this 5% cutoff is very important. More than 5% if you are seeing high grade, report it as high grade tumor. But what about if you're seeing less than 5%? Then also WHO says that you should report it as low grade tumor with less than 5% of the high grade component. So this point I want to highlight and remember. So this is just, I'm not going into. Basically, you should understand this the pun lump, low grade, high grade. These are all spectrum of lesions with changes in cytological and architectural features. So coming to a last some word about the urothelial carcinoma in situ. So it is almost all atypical nuclear features, just like malignancy will be seen in the urothelium. However, there is no papillary outgrowth. So I highlight that it is just a flat lesion. No papillary formation, no invasion, but all your features, carcinoma in situ, again intact basement membrane. So what about then urothelial dysplasia? So dysplasia, we are not supposed to use frequently as per the 2022 WHO. He says that whenever you are very not definitive for the diagnosis of CAS, so you can use dysplasia, but CAS is the preferred term. So if you do IHC, CK20 will be full thickness positivity. Normally, it is only positive in superficial most cells. So these are just another pictures to highlight that urothelial carcinoma. It can involve even pagetoid spread, and you can IHC will be useful in the cases. Now coming to invasive. So invasive urothelial carcinoma, when we discuss, it is important to discuss the depth of invasion. So depth of invasion with relation to what? Lamina propria invasion, muscularis propria invasion, perivesical fat invasion, and adjacent organs. So this one is the muscle invasion. So early invasive tumors, the clue will be the nests or the pockets of cells with a retraction pocket will be seen. Whereas the frank invasion, it is easy to identify, where all smooth mandals will be infiltrated with these tumor cells. So divergent differentiation. So urothelial carcinoma with divergent differentiation are 3. So we have to remember urothelial tumors with squamous differentiation, glandular differentiation, and trophoblastic. So squamous is the most common divergent differentiation. So when to label them as squamous differentiation, you must see, so this intercellular bridges and keratin material. So when you're seeing this, you can label it as squamous differentiation. Then glandular differentiation, again, less common than this format, but again, you can see it, glandular spaces and the lined by these cells. So whenever this glandular differentiation comes, always have it in mind, metastatic adenocarcinoma is a differentials. Then coming to trophoblastic differentiation. So which are the trophoblastic cells? Cytotrophoblast and syncytial. Practically, syncytiotrophoblasts are the ones which are easy to identify. So we should search for that. These are the syncytiotrophoblasts, you can see. So if you label beta HCG will be positive, and even if hormones can be elevated in these cases. Now coming to subtypes. So subtypes, we'll just rush through them. So micropapillary, just remember all these subtypes, apart from the conventional urothelial carcinomas, are highly aggressive tumors. So micropapillary urothelial carcinoma, just like your any other micropapillary structures without any true fibrovascular core will be seen. Again, there are high risk of vascular invasion, aggressive tumors. So this will be nested variants. So you can have small nests and large nested variant of urothelial carcinoma. So this one is important. Why? Because if you see, there is deceivingly bland histology, but they are very aggressive tumors. So how to identify them? You always look for the infiltrative base. So the depth, the biopsy should be, at least deep biopsy should be needed for this, for interpretation. Then tubular and microcystic, as the name suggests, you can have tubules and microcyst will be seen. So here again, benign conditions will be a differential diagnosis, that is cystitis cystica. Again, you have to look for the infiltration. So plasmacytoid urothelial, as the name suggests, the tumor cells almost resemble like these plasma cells. So that's why it's called plasmacytoid. Again, CD138 will be negative, but it will be positive for urothelial markers like GATA3. So sarcomatoid will have that sarcomatoid appearance. And one more thing, you can have heterologous components, sometimes osteoid, then chondroid, rhabdomoid. So you can have other heterologous elements in this. Again, ISC will be useful in this. Then lipid rich, you can see the tumors will show empty spaces, lipoblast-like cytoplasmic vacuoles may be seen. Again, aggressive tumor. Coming to lymphoepithelioma, like it will resembles like your nasopharyngeal carcinoma. You can see here, there is epithelial component and lymphoid component. Lymphoid will be positive for CD45 and epithelial, that is CK27 will be useful. Clear cell again, you will have just like your RCC. But again, when you are thinking of clear cell, always metastasis from the RCC, you should keep it in mind. Again, it can be admixed with conventional urothelial carcinoma. That time it will be very easy. So however, DD, always keep it in mind. Then giant cell rich, very aggressive tumor of the bladder. So bizarre pleomorphic giant cells like trophoblastic, osteoclast-like giant cells are foreign body type of giant cells. Highly aggressive subtype. So before we wind up, we'll just discuss something about the staging. Why it is important? We'll just focus on the T1, T2, T3. So what is T1? Tumor invades subepithelial connective tissue. T2, tumor invades muscularis propria. So when there is muscularis propria, muscle invasive bladder cancer, 2A and 2B. What is this 2A? Tumor invades superficial muscularis propria, and 2B will be deep muscularis propria. So up to TU or BT specimens, whatever the chips we get, we can report up to only 2A. Whereas 2B onwards, we need cystectomy specimen. So just remember that. Then T3, tumor invades perivesical tissue. Again, if you are seeing on the microscope, so then it is 3A if you are seeing macroscopically. So at the grossing only, if you are seeing that the tumor is coming out, then you can directly stage it as T3. So this one I want to remember. I want you to remember. So this is just pictorial representation. T1 subepithelial, then upper superficial muscular and deep muscular and perivesical. So this is urine cytology. So why we are discussing urine cytology? That is the Paris system in this histology class. Because this Paris system of reporting urine cytology has been incorporated in the 5th WHO. There is a recent one. So we ought to know something about it. So at least important points we'll see. Cytology, as it is highly sensitive for detecting high-grade urothelial carcinoma, and it's very difficult to detect low-grade urothelial carcinoma. So this Paris system, it acknowledges that fact. So that is inability of the cytology to detect low-grade urothelial neoplasms. So that's why this has been incorporated, and more importance is given to high-grade diagnosis of high-grade neoplasms. So here some objective criteria are used: increased NC ratio, hyperchromasia, irregularity of nuclear membranes, irregular clumped chromatin, like this. But broadly, you have only two diagnostic category here. So one is low-grade category and one is high-grade category. So in low-grade category, all your whatever we discussed, papilloma, pun lump, low-grade urothelial carcinoma, everything is been included in this. High-grade, we have only high-grade tumor and urothelial carcinoma in situ. So carcinoma in situ on cytology is not possible to diagnose. So it comes under this high-grade category. So you remember that. So various other, so impression, whatever impression you can give. So this is the different criteria. I'm not going in detail. Again, you have a very beautiful algorithm in the WHO Blue Book. So based on the objective criteria, so they are trying to remove the subjectivity, and more focus is to high-grade tumors we are not supposed to miss. So even cytology, it is easy to identify high-grade compared to low-grade. So just you have to remember this for if you are reporting urine cytology, especially high-grade urothelial carcinoma. This is the definition of WHO. Minimum you have to see 5 to 10 well-preserved urothelial cells with an NC ratio of more than 0.7 and severe hyperchromasia, coarse chromatin, and irregular nuclear membrane. So that's it. Coming to molecular pathology, we are not going in detail. Just I will highlight that molecular pathology, there is no clinical significant role at present, especially in non-invasive papillary tumors. In this, it will be helpful only in predicting the recurrence and progression. Like some of the mutations can be associated with the low risk of recurrence, whereas some mutations, they can be associated with high risk of recurrence. But whereas they have proposed a consensus molecular classification for bladder. MIBC is muscle invasive bladder cancers. Here, what they have done is 6 molecular clusters with the different prognostic outcomes. They have made it tentative 6 classes. That is luminal papillary, luminal non-specific, luminal unstable, stroma-rich, basal squamous, and neuroendocrine. So they are trying to correlate the morphology with each of these. So some have papillary, some have micropapillary, some have mixed pattern. So morphology, they are correlating with this molecularly defined classification, molecularly defined classes. And also they are trying to identify each IHC panel for each of these category. So it is still the work under process, but it will be in future just like your RCC. So morphology with IHC along with the molecularly defined categories. So why is this important molecular classification? Not for this bladder, also for any other classification for that matter, we can have targeted therapy. Because now very recent, most of the targeted therapy drugs are available like FGFR inhibitor therapy, anti-PD-1, that is immune checkpoint inhibitor therapy, anti-VEGF therapy. So this can be useful, especially in muscle invasive, highly advanced and metastatic bladder cancers. That's why it will be important in oncology in future. So this will be my concluding slide for the bladder tumors. Take-home points which we are supposed to remember is grading is purely based on morphology, that is cytological and architectural features, and IHC is not needed. And we have to remember concept of tumor heterogeneity and 5% cutoff rule for high-grade carcinomas. Then Paris system of urine cytology, that is high grade and low grade, we can only 2 categories. Then PT3B staging, because on gross examination only you can stage it. Then carcinoma in situ is the term used rather than dysplasia. So dysplasia were not supposed to use loosely. We have to mention carcinoma in situ is the one. Then urothelial carcinoma of uncertain malignant potential, which was previously used, it been totally removed. Now we have only papilloma, LMP, high grade and low grade. Then molecular consensus classification of bladder tumors. In future, we may be practicing this. Again, as we discussed, is based on the morphology, IHC and mutations. As of now, it is not much useful. So these are my references. Most of the images I have taken from web pathology and pathology outlines just to get the classical appearance. Then again, WHO Blue Book. So my acknowledgements to my mentors, Dr. Aruna Manikar from Ahmedabad, Devdatta Basu sir from Pondicherry, Dr. Dayanand sir and Siddiq sir from the Bangalore Medical College. So this is our laboratory team of technicians and few doctors, some of my colleagues. This is my histopathology team, my colleague Dr. Somnath, and this is the histotechnician Dr. Ms. Dayasagar, and this is the new technician who has joined. So we are a small setup, we have a small setup. This is our institute. Basically, we are catering to exclusive nephro and urology. So thank you. Hope the audience are with me.
Dr. Vinay, it was quite extensive. I mean,
Yeah.
to cover entire set of kidney and bladder is very difficult, but you
Yes,
managed.
madam, that's right. It's a
WHO
very big topic in 1 hour. I tried to cover the salient topics, salient points at least.
Yeah, I mean, it's kind of a revision for the students. They can go
Yes,
through.
madam. I kept the PG students in the focus only. That's it.
Yeah. So it was really good. And the slides were very, very good. And you explained it very clearly, though it was, it looked like you're telling too many things, but it was all of them were so such salient points. And so it was really good. Thanks a lot for the effort.
Thanks a lot, madam. Thanks a lot for giving this opportunity.
Thank you. Thank you so much.
Thank you, sir.
Thank you, madam.
Thank you, sir. Thank you very much.
Thanks a lot. Thanks a lot.
We will now break for lunch. I request the delegates to join back a little earlier, at least at 1:15, for the afternoon sessions. Thank you.
Hi, Vijayashree, can you hear me?
Yes, Dr. Satya, I can hear you.
Oh, okay. Thanks.
You want to share now?
Can I connect and see?
Sure, Good afternoon, everyone. I request all the delegates to join back in. Welcome to the post-lunch session of CARE-PARE 2024. I now request Dr. Kamal to introduce our next speaker.
Good afternoon, everyone. I am honored to introduce Dr. Satyamurthy Selvarajan, a highly esteemed anatomical pathologist with extensive experience across clinical and academic settings. Dr. Selvarajan began his medical education with an MBBS from Stanley Medical College, India, and went on to complete a postgraduate diploma in clinical pathology at Madras Medical College. He furthered his expertise with a master's in clinical science from the National University of Singapore and is a fellow of the Royal College of Pathologists in the UK. Currently, Dr. Selvarajan serves as a senior consultant in the Department of Anatomical Pathology at Singapore General Hospital and as a clinical assistant professor at Duke's NUS School of Medicine. Over his career at Singapore General Hospital, he has held various consultant and registrar roles, marking a progressive journey in patient care and education. Dr. Selvarajan's expertise lies in bone and soft tissue pathology and head and neck pathology. He has contributed significantly to breast cancer research and molecular genetic techniques with numerous publications and presentations to his name. An avid educator, he regularly teaches postgraduate trainees and has been a key faculty member in the pathology module at NTU Schools of Traditional Chinese Medicine. He has also served as president of the Singapore Society of Pathology and remains an active fellow, the Academy of Medicine Singapore, embodying a deep commitment to the advancement of pathology. Please join me in welcoming Dr. Satyamurthy Selvarajan.
Thank you, Dr. Kamal. You are so kind to give a detailed description about me. I'm a fellow Chennai guy and a very good friend of Vijayashree. We did post-graduation together from MMC under quite a few eminent teachers. Still, our roots are strong. We keep in touch and communicate with each other. And a special thank you to Vijayashree. She given me an opportunity to share what I know a bit of it to my country people especially. I always talk about this whenever I go back and say hello to my friends and teachers. So our pathology has evolved a lot, and I can see the difference, how much importance clinicians started giving to a pathology. Last time all, they never bothered to consider pathology as a specialty, and now they know, because especially oncology has become more personalized. No two patients with the same tumor can be treated in the same way. So we play a major role as a morphologist, as well as uh, doing other additional ancillary techniques, which is totally important. So how dominant we can be in the tumor board. If you see the tumor board and my multidisciplinary meetings, we have a big voices. I learned this from my mentor, Prof. Rosenberg. He is very authoritative, and clinicians, the orthopedic surgeons, everybody used to be keep quiet, whatever he says. So it is happy to see pathology evolving in that way. Without wasting my time, I think I have a lot of things to discuss. I tried to be concise within the time frame what I have. If not able to finish it, just let me know where I need to stop, and I can share the screen later to Vijay. She can share with all other postgraduates and colleagues. I share my
30
screen.
seconds, Satya. It is so nice to see you back with us. We had wonderful PG days, and yesterday I mentioned in the morning that, I mean, surely you and myself together, how we were students of our ex-vice chancellor here, Dr. Shanta Madam.
Yeah, exactly. True,
Yes.
true. I missed Shirley's talk yesterday, was not
Yeah.
able to join. Anyway, good to hear from her too. So I off my video to be more comfortable for me, and share my screen. You all can see my screen?
Yes.
Okay. Though it's recent updates in WHO, bone and soft tissue tumors, I may not be touching in bone tumors. Bone tumors also had some changes, but time limit is the factor which is affecting me. So I'm going to talk mostly about the soft tissue tumors. What are the recent updates? What are the emerging entities? And what some of the entities has taken out from the comparatively from the last WHO to the recent one. That is 2013 one was the last. So this is the cover page. You all have seen this thing. And at the end of the session, I hope that you, the pathologist as well as the fellow students, will come to know what are the newer entities has been evolved, as well as what are the updates happened in the current entities and changes. And also some entities I will be talking the trivial points. I can't able to go in detail, and some entities where I come across personally over a period of last 3 to 4 years. I'm going to discuss in detail about those 2 or 3 cases. So the new WHO, the 5th edition, happened in 2020. Usually it happens like a time frame they keep is maximum of 12 years. So much happened, changes in the bone and soft tissue. They can't able to wait until 12 years. They did the following update within 7 years. And usually it happens with the consensus among the eminent BST pathologists all around the world, and including the primary clinical team, which includes med and surgical oncologists, both general surgeon as well as orthopedic surgeons, geneticists. They played a big role this time around. Radiologists also will be there. So some new entities has been emerged, and some of the existing entities prognostic updates has been given, and quite a number of novel genetic alterations has been discovered, especially in the bone and soft tissue tumors, and a few new chapters has been created along with the other existing chapters. The genetic alterations, I remember around 12 years back when I went for my fellowship, I can able to remember what are all the molecular events happening in the bone and soft tissue. But if you ask me now, I can't, because every few months to a year, there is one new alterations and new molecular event happening, especially in the bone and soft tissue tumors, saying that it is expanding beyond the soft tissue tumors. Now we all know how hematolymphoid is, depends largely on the molecular event, and that also getting into the lung, GI, breast, everywhere. So the molecular pathology last time used to be just a simple tool. Not all the pathologists need to know, but it is not like that. You postgraduates, when you start going to practice as a histopathologist, definitely you should need a big or a vast idea what's happening at the molecular level in each tumor, because though morphological diagnosis is not going to be replaced, but you should know what is the molecular event, because it affects at every level of the tumor management for a particular patient. So the changes happened in almost every sub-specialty within the soft tissue, including the list I have given. And quite characteristically, changes happened in adipocytic and undifferentiated small round cell tumors. And there are few entities has changed from the one subspecialty to other one. For example, extra-adrenal angiomyolipoma, last time thought to be adipocytic, now moved to a tumor of uncertain differentiation. So there has been quite a bit of changes happen, but it is not affecting much of the WHO book. And so these are the entities which either emerged new or updated within the subspecialty among the soft tissue tumors. So in this, I'm going to discuss in detail few of the entities which I highlighted in green, and some of the entities which I highlighted in red. I'm going to talk about a few points about it. Rest of the entities, not much changes happened, except malignant melanotic nerve sheath tumor, which is a newer malignant tumor under peripheral nerve sheath category. It is very, very rare. I haven't seen one in this 10 years. And so it's one of the rarest tumor, not needed at your level. Definitely may come across in future. So saying that these are some of the tumors, they have been reclassified from one specialty to the another specialty, that is subspecialty in current WHO. The adrenal extra-adrenal angiomyolipoma moved to a tumor of uncertain differentiation. Last time they thought it's adipocytic. Now they know it is not adipocytic. It is more of like a pericytic or a picoma kind of a cell type. So they mention it as undifferentiated. Similarly happened to the other different tumor. Ewing sarcoma, they made it a separate chapter and also combined both bone and soft tissue tumors under this, because they can appear in both soft tissue and bone frequently. And these are some of the tumors they have taken off from the current WHO. Either the significance is not that great, and it is not very well defined over this period. So they have removed it from the current WHO classification. So moving that, saying that we are moving to some of the trivial points in some newer entities. One is this angiofibroma of soft tissue. It is a recently described entity, and it's a benign tumor, most likely affects the middle-aged population. A bit of a female predominance is there, and characteristically seen in the lower extremities adjacent to a larger joints. And morphologically, if you see, it is a bland spindle cells with the loose edematous or a myxoidy stroma, variable numbers or a degree of the vasculature, which has a very classic this branching pattern of vasculature. There are some of the other pictures I'm showing here. You can appreciate the characteristic vasculature, and the cells are all surrounding these blood vessels are either bland, very rarely mitosis seen, and as of now, no malignant transformation has been noted. And some of these tumors are the morphological diagnosis rather than the immunohistochemical help may help. The reason is in this one also, very variably, the spindle cells are positive for CD34 and EMA. And also, again, as I said, it's variable. Some tumors may not show any staining pattern at all, but it's the morphology. When you see these kind of branching vasculature, that is one helpful factor. And again, as I mentioned, the molecular thing is expanding beyond a certain malignant tumors into the benign tumors also. And this one have a characteristic molecular translocation, AHRR, NCOA2 fusion. And complete, as of now, excision is curative. Very, very rarely recurrence has been reported. And this is CD34 staining, which shows a very weak or patchy staining of the spindle cells. However, you can appreciate how nicely the blood vessels are lighting up. So it's variably positive for, as I mentioned, SMA, desmin, EMA, and CD34. And the second case is anastomosing hemangioma. I have come across a few of these cases over a period of this 10 years or so. Initially, the lesion has been reported around the hilum of the ovary and genitourinary tract. Patient undergoing some kind of a renal procedure, and they are giving some kind of history. So it's more seen around the retroperitoneum and the genitourinary region, and can be seen in, though it's common in adult population, can be seen in pediatric age group. And morphologically, again, here also the morphological diagnosis, you can see all these vascular spaces, which looks like connected to each other, like a branching or a lakes or a river which flows across between the muds and pools. So it's a branching type of vascular pattern, and lined by the endothelial cells, not much ATP or increased mitosis. Mitosis can be seen, but it is not alarming. And curative, surgical excision is the curative. No malignant transformation has been reported as of now. Again, they are all, these endothelial cells which are lining are positive for endothelial markers, the usual ones. And recently it's been reported they also started showing mutations in GNA14 and GNAQ genes. So nowadays, most of the tumors, if you keep working on it, definitely some kind of a molecular event is happening. Some could be a novel, still not as well established, how to manage or how it's going to help, whether it's a prognostic value or a predictive value. Only few are getting established, and the molecular field is expanding in details. And another one is the inflammatory leiomyosarcoma. Last time, this entity was initially it was under the MFH, the older terminology for a UPS, undifferentiated pleomorphic sarcoma, inflammatory variant MFH, and then later it's been moved under a variant under a conventional leiomyosarcoma, like an inflammatory variant. Now in this newer WHO book, it's been given as a separate entity, mostly seen in, again, adult population and a male predominance with the lower limb and trunk are the common sites. You can appreciate all these spindle smooth muscle cells or in fascicles admixed intricately or diffusely with the inflammatory cells, which includes lymphoplasmacytic cells as well. And you appreciate increased mitotic activity, necrosis can be seen. Most of these tumors are of low grade only, so they never reach a grade 3 FNCLCC grading 3. Mostly it is grade 1 and grade 2. only. And this is another case which shows some even a clear or evacuated cells like a histiocytic like cells also admixed along with the inflammatory cells, very strongly positive for desmin. And moving on is another interesting case is the NTRK rearranged spindle cell neoplasm. I have come across at least 3 or 4 cases as of now in this period of 5 to 6 years. And another emerging entity which has a very characteristic as well as morphology and overlapping with peripheral nerve sheath tumor. There have been quite a few retrospective studies done where they pull the cases which have been called as a peripheral nerve sheath, and when they did the molecular analysis, they found this NTRK rearrangement, and they can have areas like this spindle cells of bland to minimal nuclear ATPI admixed in a background of myxoid matrix, and there are areas with increased cellularity as well. There are areas where the tumor cells are accentuated or concentrated around the blood vessels, and characteristically some tumor can have these hyaline stroma. Again, this is more commonly seen in children. I have seen a couple of cases in a young adolescents, one presenting as a mass over the maxilla, another one is presenting as a soft tissue mass in the upper arm. Yes, both are adolescent patients, and it can be superficial as well as deep also. As I mentioned, varying pattern of morphology seen, and mostly low grade in nature. Again, when it comes to the immunoprofile, we have to be careful because they can be variably positive for S100, CD34. Both are expressed in a peripheral nerve sheath tumor. SOX10 is negative in case of NTRK rearranged tumor, but in MPNSTs, SOX10 will be variably positive as well. So now a lot of these molecular alterations and their products can be prepared in the form of immunohistochemistry. So one such for very helpful is in this tumor, pan-TRK IHC, which is very useful. The tumor can be either cytoplasmic or nuclear positivity, depends on which NTRK gene is involved. The studies as mentioned, NTRK3 involvement shows a lot more strong nuclear positivity. NTRK1 and NTRK2 can have both mixed cytoplasmic and nuclear positivity. So this is one of my in-house case immunohistochemistry slide, which shows cytoplasmic positivity with very few sprinkled nuclear positivity. This is another case, very strong expression, including both cytoplasmic and nuclear. Though the immunohistochemistry is helpful, now it is expanding, and beyond that, people say NTRK can be spuriously expressed because of the validation, and the antibody is not properly treated or anything. So it can be variably expressed in other tumors also. So molecular testing is definite. A fish study for a break apart fish or a fusion study is needed to ascertain the molecular event happening, because this is one of the targetable genes, and there are management for a NTRK rearrangement spindle cell tumor. They treat with the TRK inhibitors. So moving on to my next case is the EWSR1 SMAD3 positive fibroblastic tumor. This is another emerging tumor. In my institution, we come across one of this case. It is like a spindle cells which is proliferating in a long fascicles with the entrapment of subcutaneous or adjacent adipose tissue within or at the interface of the tumor. If you notice, the ATPI is very minimal and not much increased mitotic activity is seen. And the age range is, again, it's broad, not yet fully categorized. And a female predominance has been noted as of now. And most of the time they are present at the extremities, either in the hands or foot. In our case is a soft tissue tumor, subcutaneous location present at the forearm. And they are very strongly ERG positive. ERG is a very sensitive and a specific vascular marker, in saying that it can be expressed in quite a few other tumors, like variants of Ewing sarcoma can have a ERG positivity. And one another tumor is this one, where ERG is strongly positive, but other vascular markers, including CD10 and smooth muscle markers, are negative. So it has a very, very characteristic feature of when a tumor, you get a spindle cell lesion, looks bland, ERG is positive, but other vascular markers negative. Keep in mind, this could be the tumor. And you can do EWSR1 break-apart FISH to support the diagnosis. If you have a fusion probe, then you can locate the partner gene SMAD3 as well. Saying that EWSR1 is such a ubiquitous gene, one of the gene which has been involved not only sarcoma, even in some rare carcinomas as well. Within sarcomas, malignant like Ewing sarcoma, angiomatous fibrous histiocytomas, then in fact even seen in myxoid liposarcoma, many other tumors it's been involved. It's so ubiquitous. So when you're doing break-apart FISH, if it comes back positive, it's not always Ewing's. So there comes the morphologist who can support. You can say the clinician, though it is EWSR1 positive, but morphologically it doesn't look like Ewing's. It could be some other tumor. So you have to put every point and everything together to come to a diagnosis nowadays. And cheek rearrangement tumors have been there more than a decade now, but not much has been proven early days. Earlier, it was thought as one of the Ewing family of tumors, where it was thought as a variant of Ewing's. But as it progresses in this 10 years period, they realized they don't behave like a Ewing's, and also the Ewing's management is not helpful. And in fact, they are very refractory to the Ewing's treatment. Even clinicians don't know how to treat these kind of patients. They're trying all the ways, and expanded studies are happening. And when this tumor was identified more than 10 years ago, it was thought to be found only in young adults, but now they found it can be seen in a pediatric age group also very rarely, as well as adult population as well, and mostly deep soft tissue in location, and rarely visceral primaries are also noted. And morphology wise, it can have a very classic round cell sarcoma, as what we seen in the Ewing's like these, with either a minimal cytoplasm or some pale eosinophilic cytoplasm, and also areas with the clear cytoplasm and very much fibrotic with the hyalinized areas with a lot of necrosis as well. So the morphology is still overlap with the Ewing sarcoma, but can show varying other features like spindle morphology, hyalinization, and bland looking areas also sometimes. And immunoprofile wise, they are very strongly positive for WT1. Still, people don't understand why this tumor is expressing ETV4, and it saying that very useful immunohistochemical marker to diagnose this when there are no molecular facilities are available to do the test. So ETV6 positive, ETV4 positivity and WT1 is strongly positive, but very patchily positive for CD19. And CD99 is a very nice membranous positive for Ewing's tumor. In this case, it's patchy cytoplasmic. So that itself will give a clue. So this is a round cell sarcoma. The staining pattern of CD99 is not that classic, will make you to think of, am I dealing with the non-EWSR1 fusion type of round cell sarcomas? Because it's very, very useful and it's definitely needed for the management of the patient. So NKX 2.2, another very good marker for Ewing's, which has found recently, not expressed in CHRI rearranged tumor. They found the partnering is DUX4. So it used to be called as a CHRI DUX4 rearranged round cell sarcoma. Now, as it progresses, as I mentioned, the molecular event is expanding within a tumor and beyond other tumors as well. Now, there are quite a few other partners have been noted. One is FOXO4, another one is a NUTM also involved in the CHRI DUX rearranged tumor. Very, very guarded prognosis. And in fact, they behave worse than Ewing's sarcoma. And the next one along the same thing is sarcoma with the BCAR genetic alterations. BCAR also was there in the era of more than 10 years now, was considered initially as a part of the Ewing's family of tumor spectrum, saying as a non-EWSR1 fusion kind of Ewing sarcoma. But again, similar to CHRI DUX4, they also behave badly in a different manner and not responding to the usual Ewing's management. They have a certain other characteristics also, more common in the children and young adults and adolescent population. Male dominance has been noted, and primarily epicentered in bone. Bone primaries are more than the soft tissue primaries with the BCAR genetic alteration tumors. Again, it's a round cell morphology, and also you can appreciate clear cytoplasm in some and spindle morphology. So there is a mixture of morphology, but the baseline is the round cell morphology with all the other high-grade parameters. And another genetic alteration which has been coded as immunohistochemistry is BCAR. Very, very useful. Very strong nuclear positivity has been noted for BCAR. In addition, they can be positive for SADB2, cyclin D1, CD99. Again, CD99 is variable and patchy, so be careful. SADB2 is a marker for a soft tissue person is osteosarcomas. In fact, any osteoblastic proliferation tumor, whether benign or malignant, they are a SADB2 positive. In addition, colonic adenocarcinomas can be SADB2 positive, but morphology totally different, we all know. So SADB2 positivity in this tumor is will make you to confuse. Am I dealing with when it is a primary bone, children? Am I dealing with a round cell variant of osteosarcoma? But here you don't see that osteoid formation elsewhere. So extensive sampling needed if it is a resection specimen, or molecular event where osteosarcoma don't have any specific molecular event. And this one has the BCAR tandem duplicates as well as other genetic alterations. So those are some of the trivial thing. And two other cases of which one I come across recently is the atypical spindle cell / pleomorphic lipomatosome. This one is confusing a bit more for a young pathologist, and a myxoid pleomorphic liposarcoma is a newer entity as well. So what is this atypical spindle cell pleomorphic lipomatous tumor? Another low-grade Even WHSC, it's benign, but I disagree a little bit because when it is benign, why you have separated this entity from already existing spindle cell / pleomorphic lipoma? So because this one have a bit of a higher recurrences rate, that is a loco-regional recurrences, no metastasis seen. So that's why they have separated it probably and given this name. And morphology spectrum, you can see one end like a very bland spindle cell lipoma like areas, as well as in other end either a atypical lipomatous tumor or a well-differentiated liposarcoma kind of morphological changes can be seen within the same tumor. Earlier, Fletcher, when he diagnosed this case, he has given a name called spindle cell sarcoma in 1994. That is almost 20, 30 years back itself. But over the period, they found these tumors rarely recur in that location, never metastasized. So that's why they have removed the term spindle cell liposarcoma, which is a bit more alarming, and calling it as a atypical spindle cell lipomatous tumor. So male more common than females. Limb and limb girdles are the locations. So again, a spindle cells with a variable degree of ATPR lipoblasts can be seen or may not be there. And to the other end, you can appreciate pleomorphic cells as well. So myxoid to collagenous matrix can be seen, what we see in a spindle cell lipoma as well. Similar to spindle cell lipoma, they are very strongly positive for CD34. S100 being a lipogenic in nature can or cannot be positive. And again, RB1 gene deletion has been shared between spindle cell lipoma and this tumor. Around up to 70% of the cases can have RB1 deletion, which is a similar in the percentage wise of the spindle cell lipoma, pleomorphic lipoma spectrum. So they almost have a molecular profiling and a morphology close to that, but still considered as a atypical. In areas, it may be really worrisome, increased cellular. So people will think of well-diff liposarc. So MDM to amplification is very useful in those type of cases because they are always MDM2 negative. So this is the bland end of the atypical spindle cell tumor where very minimal ATP, I will say, it is not a striking at all. There are scattered fat cells, some 1 or 2 lipoblasts can be seen as well. This is more cellular variant of the atypical spindle cell tumor in this case, and with the scattered adipocytes. So this is a closer view of the another case showing multinucleation and also lipoblasts-like cells, and there is an increased degree of ATPR comparatively. In a spindle cell pleomorphic lipoma, the ATPR, what you see is mainly in the pleomorphic lipoma end of the spectrum. Those cells are called floret cells, where the cells have a nucleus arranged around the region. So here, even the spindle cells can express or show ATPR. That is the reason why it's been given the terminology. And this is another case where it looks so ugly, and even a lot of multi-vacuolated lipoblasts are in. And this one was RB1 deletion present and not MDM2 amplification. And moving on to the next case, this is a new entity in the WHO. Again, this is an aggressive adipocytic neoplasm. Again, there is a morphologic overlap between the myxoid round cell liposarcoma and the very ugly looking pleomorphic liposarcoma, more common in the children and young adults. Pleomorphic liposarcomas are more common in the adult population. Predilection for the mediastinum as of now. It is a newer entity. It's been there only few years, not beyond that. And very rarely they say can be associated with some syndromes. Leaf-Rimani syndrome is one shown this tumor as a part of the spectrum. As I mentioned, it has a myxoid liposarcoma-like areas, to the other end as a pleomorphic liposarcoma. Consistently, they lack DT, IT3, break apart fish negative. That is no FUS DTIT3 or EWSR1 DTIT3 fusion has been reported in this tumor. Again, saying that no MDM2 amplification. So this is not a variant of a dedifferentiated liposarcoma also. So high rate of local, it's a small period now, it's only few years now. Within that, people have experienced the local recurrences and metastasis as well. It has given a guarded or a bad prognosis. Okay, I think the picture has been missed. I don't know how. I'm sorry about it. I can send to Vijayashree later to show to all. Moving on to two cases which I come across recently and a very interesting one. It's a left posterior calf lump, very long duration. MRI showed a well-defined subcutaneous mass. This is the MRI picture. Being a bone and soft tissue pathologist, I always sign out my cases without not seeing any radiology. I always see the radiology. If there is a MRI or CT done, I will see the picture, try to interpret as much as possible. I'm not a radiologist. We have our MBBS knowledge. With that, we try to utilize a bit. But when you are soaked in a bone and soft tissue for a long time, you will try to learn all those radiology terminologies as well. So if you are interested in bone and soft tissue, don't sign out any case without getting details about the radiology, because always correlation is so important. It gives almost half of your diagnosis before seeing the glass slide. So the patient underwent straightaway wide excision since it's amenable for surgery. So what we received is this tumor with a very glistening and whitish. Even in this, you can see that wall kind of appearance, circumscribed tumor. And this is a scanning picture of the tumor showing a somewhat paler to darker areas, but it looks more like a fascicles and bundles. And it is in the dermal location and the deep soft tissue. So as I keep showing the slide, it shows a fascicles and bundles, even story forming is there. And there are some scattered inflammatory cells as well. So this is further higher magnification where you can appreciate sprinkled inflammatory cells, spindle cells, very bland appearance, and no increased mitotic activity or any necrosis. And there are areas like this with the scattered pigmented macrophages all over, admixed with inflammatory cells as well. And some variation in the nuclear sizes started seeing year one, and some of these cells have a much vacuolated cytoplasm. So it looks like some degree of ATPI is there, but no increased mitotic activity. This is another area showing cells with vacuolated cytoplasm with a little bit of enlargement of the nuclei. So summarizing this, without any necrosis, no activity, but there is some degree of nuclear ATPia, multinucleated stromal cells and the lipidized cells, hemosiderotic pigments all over. Is this a benign or a malignant? What am I dealing with? So as usual, we started doing some stains. In this one, it is very diffusely and strongly positive for CD34. WT1 nuclear positivity was also there, and quite a few other markers. MNF116 is keratin. EMA shows some patchy positivity. SMA also very, very patchy. Then MUC4 showed some kind of patchy positivity. MUC4 is a marker for a low-grade fibromyxoid sarcoma. Proliferation index Ki67 is very low. So is this a benign or a malignant tumor? So difficult. Morphology doesn't look like a benign one, but immunohistochemistry is not supportive. So interestingly, this WT1 positivity and CD34, this kind of combination not seen in many soft tissue tumors. So what tumor is this? I was a bit worried. And all sort of differentials brought forward to me by my resident, whether this is UPS, no, it doesn't look high grade. Pleomorphic liposarcoma, no. Is this cellular BFH? Yes, possible, but CD34 positivity, unlikely. Atypical FH can have a much more ATP and increased mitotic activity as well. And PHAT is a very characteristic ionized blood vessels, as in because of the presence of the pigments, this was thought. DFSP, yes, CD34 positive, but the morphology doesn't look like the DFSP will give a bluish hue to the slide. That is like a gross feature. Without seeing the tumor under the microscope, you can think of DFSP. Then is this SFT? No more characteristic morphology. So though CD34 is positive, low-grade fibromyxoid was thought because of the, again, low-grade morphology plus positivity, are very not spurious positivity for the MUC4. And then we have this Archer Fusion next NGS platform in our center. I told the clinician it is some kind of a low-grade spindle cell tumor. I don't know what exactly is this. I want to check, is there any molecular event? I sent to NGS assay and we come across this MET12 chromosome 4 intergenic and PRDM10 gene fusion. So the diagnosis is superficial CD34 positive fibroblastic tumor, another newer entity in the WHO book. A repeat MRI done after post-surgical and follow-up, no recurrences has been seen. So what is this tumor? It's a rare soft tissue neoplasm, recently introduced in the WHO book, and it was first described in 2014, almost 10 years back, by Volpe and his colleagues. And this is that article, and having all these characteristic features which I was just mentioning, and it's a very slow growing. In our case also, it's a 10-year history, very slow growing and mostly lower extremity. They all show MED12 PRDM10 gene fusions. So that time the superficial CD10 positive fibroblastic tumor was given the name as a PRDM10 gene fusion associated tumor. But now seeing that they rename it, and some of these tumors, they are merged together and giving a could be both could be a single entity with a significant overlap of morphology and molecular event. Initially, the PRDM10 rearrangement tumors were called as a UPS with the PRDM10 fusion, but the recurrences and all those malignant features are not there. So it is thought it could be at the benign tumor only. So morphology, I mentioned, they are having an indolent clinical behavior, very low grade. Recurrences are rare, but some of the tumors may look really ugly. So it is very important to aware about this existence, this case. So why I highlighted WT1 is WT1 act as a surrogate marker in PRDM rearrangement tumor, and thus it is very useful nowadays. And also it's been expressed in nearly 75% of all the superficial CD34 positive fibroblastic tumor. And another marker which is not available that easily in the market is CADM3. It is coming up slowly, so it may be available sooner as well. So in our case is a little bit special in the sense it has having a fusion of the three levels, MED12 and chromosome 4 intergenic and PRDM10 gene fusion as well. The significance, I don't know. There is nothing mentioned in any literature as of now. So these are some of the pictures I got from the literature and textbooks. See how ugly it looks. But when you do a Ki67 proliferation index, it will be very low. These cells may not highlight at all. So that ugly, a bit scary for the people who don't know about this entity at all. And this is another case which I come across in my practice. It's a overseas patient. The slides has been brought to my institution for a second read. 18-year-old girl presented with a maxillary tumor, which is around 4.5 cm. They excised there itself. And in Indonesia, it's been called as a ASPS, that is alveolar soft part sarcoma. And patient was brought, patient came here. When the MRI done in our center, it showed post-surgical changes only. So this is the section taken from the paraffin block they brought, which shows a pale pinkish appearance on a scanning microscope. In areas like these, slit-like spaces, some kind of, they are trying to form something, and there are a stromal hemorrhage as well. And on higher magnification, as you enlarge it, you can appreciate the cytomorphology. Very packeted or nested cells, like a solid nest, intervene by these vascular spaces. So it's a very highly vascular tumor, and the cells have a very pale, abundant cytoplasm as well. There are areas which showed like these abortive kind of vascular spaces. Are they truly blood vessels forming, or some kind of spaces formed within the tumor? So these are some of the more sections on higher magnification. And the ATPR wise, not much, not a striking nuclear pleomorphism or increased mitotic activity, but mitosis noted, not high. Even some of the cells you can appreciate like a rhabdoid-like appearance. Okay, all these voluminous, vacuolated, larger cells. So there is a clue in this, the description: larger cell, very voluminous, and rhabdoid-like appearance. So probably that's the reason they called it as a ASPS, I think, in the other institution. So I did these markers, MNF, S100, SMA, that is smooth muscle actin, and desmin are all negative. Then all the vascular markers are very strongly expressed. Factor 8, and not often I use, sometimes I use, because it gives a lot of background blush. So my preferred to go immuno is ERG. ERG is very specific. And if you are suspecting any vascular lesion or to emphasize, you can use a ERG. So it's a vascular tumor. Ki67 proliferation index is not very high. And this immuno showed a very nice nuclear positivity. And it is TFE3. TFE3 was strongly positive. And when I sent for we have a molecular TFE3 break apart fish, which came back as there is a around 90% of the cells showed a disruption in the TFE3 gene. So what tumor is this? This is YAP1 TFE3 translocation associated variant of a EHE, epithelioid hemangioendothelioma. This was not there in the last WHO book, but it's been there over a period of last 7 or 8 years, and it's been given a name by its own. Okay, it was again first identified on the early days by Antonescu group, and it's a variant. It's still a variant of epithelioid hemangioendothelioma, which is an intermediate grade of vascular tumor, equal gender distribution, but the clinical and morphological variations are there between the classical EHE and this variant. Here you can appreciate a well-formed vascular channels. In EHE you don't see the classical one. I show some of the pictures later. There are solid pattern also what we have seen. And I think the involvement of the TFE3 gene is the reason for the morphology of these cell types. We all know that TFE3 is involved in some renal tumors, that is XP11 translocation, TFE and TFB translocation tumors. They all have a thing. ASPS also have a TFE3 involvement. They are all voluminous cells. So this gene plays a role in the morphology of the cell type. And most cases, as I mentioned, in addition, they form a vascular channels, which is not seen in the classical thing. They can harbor or compress to have a WWTR1 CAMTA1 fusion, which has been identified in classical epithelioid hemangioendothelioma also. So this is some of the features. Clinically indolent only, long-term risk of a distant metastasis has been reported. Uniformly strongly expressed TFE3 immunomarker. So it's a cofactor. YAP1 is a downstream effect in this pathway and shares a significant functional and sequential homology with the WWTR1. And this is a comparative a table which shows the morphological difference between the classic EHE, YAP1, TFE3 variant and angiosarcoma, which is frankly a malignant. And there is this article which showed there is a composable expression of both the TFE3 gene as well as CAMTA1 gene in a epithelioid hemangioendothelioma. This is that TFE3 variant. So history-wise, very early days itself, it's been reported by Enzinger, and the word has been coined by Sharon Weiss and Enzinger. And earlier it was called as intravascular bronchoalveolar tumor. The reason is more common presentation of EHE is lung, second common is the liver, and then the soft tissue. So initially they thought it's a primary lung tumor, and then later identified to be as an endothelial lineage. And EHE, I think you all can come across in your textbooks. It's nothing new. I thought just few points to show. I quickly move. I have one more case before 5 minutes. So these are the pictures, which is a very characteristic one of the soft tissue tumors which can mimic like a carcinoma. So be careful when a biopsy of a lung taken and sent to you, and if you don't do enough immunohistochemistry by morphology, don't jump into and call this as this is a poorly differentiated carcinoma, because they easily mimic like a carcinoma because they don't form true vasoformation at all. So now CAMTA1 also available as immunohistochemistry, very useful in our lab we have. So rarely I will send for molecular thing because CAMTA is very much helpful. Most of the time it's not needed. It's in the small biopsies which may be needed. In a resection specimen, morphology is classical with this, with the background of those chondro island matrix where the scattered cells in cords and small clusters. So this is prognostic risk stratification. You can go through this later. Later I send this file to Vijayashree. And in the same group, vascular tumor is another new. I won't say it's a newer entity. It's been there, but it's been given a separate entity by itself recently in the WHO. Pseudomyogenic hemangioendothelioma, very interesting tumor, and initial terminology was called as a fibroma-like variant of ES, epithelioid sarcoma. Then the name has been changed as a epithelioid sarcoma like hemangioendothelioma. Soft tissue people are one of the funny people. They love to keep changing the terminology. Rarely metastasizing tumor and repeated local recurrences. One of the characteristic features is the synchronous development, which I will show later, and commonly seen in young adults, present as a multiple nodules in a different planes across bone, soft tissue, skin, viscera. So straight away clinician will think this as metastatic tumor after radiology, but it's a young adult. How often you get a young adult with a extensive metastatic tumor? So that is the interesting about this tumor. So this is one of the case which shows a multicentricity where there are nodules in the same plane and enhanced in the radius and soft tissue involvement also. There are other areas also. So it is not a metastatic tumor. It's more of a synchronous presentation. So what is the morphology? It's the fascicles of spindle cells with the which infiltrates the adjacent fat and the skeletal muscle. And why the term pseudomyogenic? Because of the appearance of these plump spindle or rhabdoid-like cells and epithelioid appearance as well. And if you see this tumor, or if you come across, you can appreciate another feature is the variable number of neutrophils as seen sprinkled within the tumor. And you can get myxoid change, necrosis is possible, mitosis can be seen. And these are some of the nice pictures I took from the textbook, which shows spindle cells like a myoid-like appearance, and in fascicles, and also more epithelioid in nature. And they are positive for the vascular markers. However, consistently they are CD34 negative. So another vascular tumor having a CD34 negativity. So to confuse the pathologists, they are positive for AE1, AE3, as well as variably to SMA as well. So that is the reason they thought this is a myogenic tumor. But again, Desmin and S100 are negative. INI1 also retained, so it is not a epithelioid sarcoma as well. So always a metastatic carcinoma deposits are the differential. Even in fact, a few years back, I had a case, again overseas case. They thought it's a metastasis to the lung, and then thought to be a pseudomyogenic. Then when they did a whole body scanning, they found that there are few nodules elsewhere in the extremities as well. So this is a cytokeratin, which is very strongly positive, ERG positive, INI1 is intact. And again, another tumor which having translocation, which has been recently found involvement of the FOSB gene. SERPINE1 FOSB fusion has been reported in pseudomyogenic hemangioendothelioma, and there are some variant fusions as well, ACTB FOSB fusion happening in this thing. So I think I'm on time. What are the take-home messages? Being a pathologist, we all should know tumors never read books. So what you read in the books may not be seen always under your microscope. So read your books as well, put and apply yourself. If it looks something fishy, think how to move on. Don't jump into the ancillary techniques straight away. Morphological diagnosis is the best way. You will attain your diagnosis at least 60 to 70% by grossing and morphology itself. Then all these easy tools are nowadays available to help you and support you. In this era of personalized medicine, for a practicing histopathologist, in addition to our own knowledge, we need support from the treating physician. So try to pester your clinician. What are all the clinical details available? Even it may be trivial. Just get the clinical details, and a radiologist, have a good rapport with your radiologist. They are very, very helpful people for us to come to a diagnosis, especially if you're going to do a bone tumors. Radiologist is a must friend in your list. And same tumor in two different patients, the management varies. So be more or less accurate and precise to help our patients to get a best treatment. So with this, I end the session. A very happy Diwali to all my Indian colleagues and pathologists. Thank you. So all my presentations are taken from PubMed literatures and all these textbooks.
Satya?
Yeah.
It was so good, I tell you, because this session, to sit like this without even yawning is something very difficult, but I managed to do it because it is one of that area where every day when we report soft tissue tumor, I have so many dilemmas because we are not supported with so much of molecular or fish. So with little bit of IHC, I try to give. Recently, that EWSR1 SMAD3 positive fibroblastic tumor, which you were telling as a second entity. And there were a tumor similar to that, but I had to call it as low-grade fibromyxoid sarcoma. And when I sent it for MUC4, it said diffuse sparse positivity. So I just called it simply as MUC4 positive low-grade fibromyxoid. But I never even thought of doing EWSR1 SMAD3 in that. So maybe I missed one, definitely for that.
Yeah, the management is totally different, and also behavior. As of now, this SMAD4 one have a very benign course, but a low-grade fibromyxoid sarcoma, we have to be very, very careful. They are deep-seated. First thing is they are deep-seated. Anything superficial, don't ever call as a low-grade fibromyxoid sarcoma. They are very deceiving morphology. Yeah, I agree with you. Yep.
And epithelial hemangioendothelioma, many times we have come across these kind of voluminous cells, but of course we do see that intracytoplasmic vacuolations, but we don't see exact vasoformative channels. We do see vacuolations sometimes, and many times I have just called it only as classic epithelial hemangioendothelioma. And sometimes I have a doubt, and I did only a reticulin stain to rule out other diagnoses where reticulin is individually cell positive, but I never even thought of the variant YAP1 TFE3 because we don't have the facility to do. So prognostically, how different it is? The same or they are different prognostically?
No, prognosis wise, they say this one little bit better than the classical EHE. EHE, the cellular variant behaves like a angiosarcoma. But the usual myxohyalin matrix one behaves better, but local recurrences and rare metastasis happening. This one can metastasize, but the episodes or the percentage is much lesser. The case which I showed was 2016. I had a recent check with my clinician. The patient is doing well. So with the limited period and the study having, they are thinking this YAP1 TFE3 variant have a comparatively better prognosis than a usual EHE. Yeah.
And in my private practice, I had a red nodule from my husband, dermatology practice, and he thought it's some kind of hemangioma or a metastatic deposit. So biopsy, I knew I'm seeing something different, but it looked more like epithelial angiosarcoma. So I had to sign it out as epithelial angiosarcoma. I did send it for second opinion, and the oncologist did get everything to find out where could be anything else. They couldn't find anything. Now I did go back to Enzinger. I was thinking of pseudomyogenic, but I was so scared to even call it something like pseudomyogenic hemangioendothelioma because in case the patient doesn't get a follow-up, what will happen? Now, because the patient is absolutely normal.
Yeah, they have a better prognosis than
and it was a skin nodule, so
yeah.
I didn't even think of pseudomyogenic hemangioendothelioma. Those are some occasions where you really, soft tissue is very, very difficult. And one more thing I had to ask you was, whenever you get soft tissue tumor and whenever you see these kind of spindle cell lesions, what are your basic, apart from IHC, what are your basic molecular? Because we don't do any kind of molecular here. If I have any doubt, I do only
generally, I also don't straight away jump into it. I'll try to fine tune it morphologically. Is it benign malignant or something like the one I showed, CD34, one kind of one, where very much overlapping and difficult to come to. Then I have a basic immunohistochemistry panel, which includes a couple of vascular markers, smooth muscle, S100, and now we have STAT6 also. So STAT6 I include if the location is like pleural, mediastinal mass, like that. So we do the panel, then I will decide for molecular. And if it is a lipomatous tumor, wherever the location, I first call my clinician, ask for radiology, where is the location, everything. For example, a lipomatous tumor from a spermatic cord, which is only 4 cm, and same lipomatous tumor from the back, which is 15 cm. The 4 cm one can be a well-diff liposarc. The 15 cm one is still could be tumor. So you need to never hesitate, whoever, don't hesitate to call your clinician, ask where is the plane, where is the location, all those things. So it is an interaction is so important. And also they should know, clinician should know that how bigger role we are playing. So that is important. We have to show that as a pathologist, we have to show that. Yeah, that always. And good, my clinical team here, my head and neck also. Head and neck is another one. I can talk whole day about head and neck. And head and neck also have a very big center here, always busy. Even that also, I regularly have a good communication with my clinician. So you people also should do. I think in India, last 10 years or so, it is nice and expanding pathology. So we should make it to point to the clinician that we are very important in patient management, even though we don't touch the patient. Yeah.
Thank you, Dr. Satya, for sparing your time and effort. Looking forward for your head and neck anyway. Definitely,
yeah, sure.
It's here. So thank you so much. Thanks a lot.
Hey, thank you very much, Vijayashree, for giving this opportunity.
Don't think that I'm going to stop with this. I'll be calling you every year. So whenever you come to check,
I will try my level best.
Bring your, whatever digital slides or whatever it is. You don't have to carry the glass slides. You can bring your digital slides and please talk to us.
Is there any questions or in chat? I can do.
No, there aren't.
Nothing. Okay, good.
I only asked morphological DD for EWSR1 positive tumors. Anyway, I spoke to you about it.
Yeah, the round cell one we all know, Ewing's. When it is Ewing's CD99, as I mentioned, if it is diffuse and a nice membranous, the story ends there. But if it is very patchy means, then only I will move on to the NGS platform and look for any other fusion. Non-EWSR1 ETS fusion is there or not. Yeah.
Thank you. Thanks a lot.
Yep. Okay.
Dr. Jain.
Okay. Hey, thanks, Vijayashree.
Thank you. Bye. I think it's your evening time. Please go home and rest.
Thanks. Thank you.
Thank you, sir, for enlightening us with your knowledge. Now I request Dr. Catherine to introduce our next speaker.
Good afternoon all. It's my immense pleasure to introduce our speaker, Dr. Rajavelu Indra ma'am, Head of Department of Pathology at Government ISO and KGH Madras Medical College. Ma'am has completed her MBBS from Sri Ramchandra Medical College and her MD Pathology from Dr. ALM PG Institute of Basic Medical Science with an impressive teaching experience of 26 years in both undergraduate and postgraduate education. Ma'am has made a significant impact in her field. In addition to teaching role, ma'am serves as an editorial member of e-journal of Dr. NGR Medical University and has guided numerous theses and co-guided several PhD graduates. Ma'am has been recognized for her contributions with Best Doctor Award at Government ISO and KGH in 2019 and 2021, as well as the COVID Warrior Award in 2021 at Government ISO and KGH Hospital. Ma'am has actively participated in conferences and has presented numerous papers and posters in various national and international journals and also various publications in index journals. We welcome you, ma'am, to share your insights with us. Over to you, ma'am.
Good afternoon all. Can you hear me?
Yes.
Yes, at the outset, I would like to thank Professor Vijayashree and her team. I feel very proud to call myself as the teacher of...
Yes, I am so happy to sit here listening again to you.
So, is my screen visible?
Yes, ma'am, it's visible.
Okay. So, in the next 1 hour, I'll rapidly go through 12 different slides of gynecology, and in the first 4 slides, we'll be seeing about the ovarian lesions. So before we go on to the slides per se, I wanted to discuss certain features about the general features about the tumors of the ovary. They arise from one of the 3 ovarian components, either from the surface epithelium or from the germ cells or from the stroma of the ovary. Few general aspects of the ovarian tumor, how to diagnose. You need to know about the history. What is the age of the patient? Because it does matter because certain tumors are common in certain age groups. The most common ovarian tumor, the mature cystic teratoma, can be seen at any ages, but other primary germ cell neoplasms are rarely seen after the age of 50. And tumors which are occurring in patients who are less than 45 years, only 1/8 of them are malignant, whereas ovarian tumors occurring in older age groups, about 1/3 of them are malignant. Unilateral tumors. So which tumors are commonly unilateral means the granular cell tumors and the Sertoli cell tumors. And bilateral tumors, usually metastatic tumors are bilateral. Next comes the serous tumors and undifferentiated carcinomas. Coming to the metastatic tumors, they have specific features. That is usually bilateral, multiple, and involvement of the surface of the ovary is common, and involvement of the adjacent structures and involvement of the hilum is very common with the metastatic tumors. What are the risk factors for ovarian carcinomas? Increasing in age. So initially I told you, if the patient is less than 45, only 1/8 of the tumors are malignant. So increasing age is an important risk factor for ovarian carcinomas. Early menarche and late menopause, high socioeconomic status, and incessant ovulation hypothesis. Because ovulation repeatedly traumatizes the ovarian surface epithelium, thus stimulates the proliferation, and it plays an important role in ovarian carcinogenesis. And retrograde menstruation-induced salpingitis, or the introduction of a foreign body through the vagina, and certain viral infections in childhood or history of prior exposure to prior ionizing radiation all plays an important risk factor for ovarian carcinomas, and certain lesions like endometriotic cysts, from which clear cell carcinomas of the ovaries and endometrioid carcinomas and certain borderline mucinous tumors can arise. There are also protective factors like increased parity and the usage of oral contraceptive pills, apart from surgical protective factors like bilateral salpingo-oophorectomy, hysterectomy with tubal ligation. What is the genetic predisposition to ovarian cancer? There are three main types: site-specific ovarian cancer, hereditary breast ovarian cancer, and hereditary non-polyposis colorectal cancer, that is the Lynch syndrome. You need to know about the ovarian carcinoma staging. So to put it very simply, in stage 1, the tumor is limited to one or both the ovaries, and in stage 2, there is pelvic extension, and in stage 3, it goes beyond the pelvis, and in stage 4, it is distant metastasis. What is STIC and P53 signature? Is serous tubular intraepithelial carcinomas, and P53 signatures or precursor lesion of tubal intraepithelial carcinomas. They appear morphologically normal, but harbors a P53 mutation. Sampling of these tumors is very important, because large solid tumors, you must make cut sections at 1 centimeter every 1 centimeter and examine the cut surfaces thoroughly. And you should take bits wherever there is an unusually soft or hard areas which contain papillary processes, areas of necrosis, and any cyst more than 1 centimeter in diameter has to be opened up. With this background, we go on to the slides. Slide 1 is a 55-year-old female who presented with postmenopausal bleeding, and patient had a left ovarian mass. Cut surface of the mass shows a gray-white tumor replacing the ovary. Microscopically, under scanner, you can see it's a highly cellular neoplasm. And low power view shows the arrangement of the cells in the form of cards, nests, and trabeculae, and here and there you can see some structures. So high power view shows small cavities which are lined by these neoplastic cells, the cells which are small, round to oval, with scanty cytoplasm, oval or angulated pale nuclei surrounding central cavities which contain eosinophilic fluid, degenerated nuclei, and hyalinized basement membrane-like material. This is well seen in this. So forming the microfollicles or the Kollexner bodies. Now, what's your diagnosis?
Granulosa cell tumor.
Very good, very good. So it's an adult granulosa cell tumor, which accounts to 1% of all ovarian tumors and 95% of the granulosa cell tumors and 5% by the juvenile granulosa tumors. More commonly seen in postmenopausal women because it's an estrogen secreting tumor. It causes hyperplasia of the endometrium, and the risk of endometrial carcinoma is less than 5%. And there is an increased level of estrogen in the blood and urine. So patients present with postmenopausal bleeding, if occurring in reproductive age group, they present with abnormal uterine bleeding. Sometimes there may be hemoperitoneum, then the patient may present with acute abdomen. Grossly, it's approximately 12 centimeters in diameter. The specimen which I showed you was predominantly solid. It's only solid, but it's usually solid and cystic. Unilateral, as I've already mentioned, in more than 95% of the cases. So please pay attention to the history which is given. Okay, during exams time. External surface will be smooth, cut surface, gray, white, or yellow, soft to firm, solid and cystic with areas of hemorrhage. So microscopically, predominantly you see granulosa cells, or they may be mixed with thicker cells, fibroblasts, or both. These cells are dispersed in a wide variety of patterns, which are commonly admixed. The most common pattern is the cards. You can see diffused pattern, microfollicular pattern forming the Kollexner bodies, the macrofollicular pattern, insular, trabecular, tubular, watered silk or the Moyer silk, gyriform pattern where the cells are arranged in an undulating fashion, pseudopapillary due to degenerative changes. The Kollexner body, I have already described, they are composed of central cavity containing eosinophilic fluid-like material with degenerated nuclei and hyalinized basement membrane-like material, rarely basophilic fluid, which are surrounded by the neoplastic granulosa cells. There are certain mimics for these Kollexner bodies. They include the acini of carcinoid, which are slightly larger than these Kollexner bodies, and the nuclei of carcinoid are very classic. You have the salt and pepper chromat. And the hyaline bodies of the gonadoblastoma and certainly sex cord stromal tumors with annular tubules. So these are the mimics for Kollexner bodies. When the tubular pattern is more than 10%, then it is called as gynandroblastoma. So I have already described the neoplastic granulosa cells, and one important characteristic feature of this is nuclear grooves. Which other tumor do you get? Other ovarian tumor do you get nuclear grooves? Nuclear grooves are seen in Brenner tumors also. Okay. The macrofollicular pattern is not so commonly seen. Here you get cysts lined by well-differentiated granulosa cells with thicker cells underneath. Mitotic rate is generally not brisk, and sometimes the cells may have abundant vacuolated cytoplasm. Then you call it as a luteinized GCT. Sometimes they may have a signet ring cell morphology. Stroma is generally absent, sometimes conspicuous, but not so much as in the case of other sex cord stromal tumors. And the thicker cells which are present, they occur as a response of the ovarian stroma to the growth of granulosa cells, because these cells are not seen in the extra ovarian spread of these GCT. Reticulin stain will surround groups of cells or perivascular, as opposed to wrapping of individual cells which you see in thecomas. IHC, they are positive for inhibin, calretinin, SF1, FOXL2, and CD56. molecular genetics shows mutation of FOXL2. So differential diagnosis include undifferentiated carcinomas, small cell carcinomas, primary or metastatic endometrial stromal sarcomas, tecomas, fibromas, fibrosarcomas, follicular cysts, that is the gross diagnosis, differential diagnosis for the macrofollicular pattern, and endometrioid carcinoma with a predominantly solid component, steroid cell tumor, metastatic malignant melanoma, and metastatic breast carcinomas, which can be differentiated because usually they are bilateral. So now, what are the general differences between an adult granular cell tumor and juvenile granular cell tumor? Less than 1% is prepubertal in adult GCT and usually seen in older age group, but can be seen after the age of 30. Callexner bodies and crude nuclei, which are pale and angular, are seen in adult GCT, whereas Callexner bodies are rare and nuclei are darker, rarely grooved in juvenile GCT. But luteinization is frequent with that. We move on to the next slide. 32-year-old female presented with a patient of Peutz-Jeghers syndrome, presented with a right ovarian mass. You can see a cystic structure with a solid component in the scanner view. LOPA view shows some tube-like structures which are surrounded by small neoplastic cells. So these tubular structures, what do they contain? Yes, we'll see under the hyper. So hyper, you can see these ring or tube-like structures containing eosinophilic basement membrane-like material which are surrounded by the neoplastic cells which are arranged perpendicular to each other, and so many of them are seen. Yes. So it's very well seen in this picture and here also. So now you're seeing so many tubules. So what's your diagnosis? It is sex-cord stromal tumor with annular tubules. It's a rare tumor accounting to less than 1% of all sex-cord stromal tumors. The peak incidence between third and fourth decade. There are two types basically, sporadic and syndromic. That is associated with the Peutz-Jeghers syndrome with the germline mutations in chromosome 19. And why should we differentiate? Because they differ both clinically and pathologically, whether the patient is having PJ syndrome or not. The patients who are having PJ syndrome have small ovarian tumors, but they will be bilateral and multiple and with calcification. But they follow a benign course. As opposed to the sporadic cases, which are larger, grossly visible, and 20% of them have an extra ovarian spread. Not only these sex-cord stromal tumors with annular tubules are associated with PJ syndrome, there are other tumors also, like Sertoli cell tumors, Sertoli Leydig cell tumors, and steroid cell tumors may also be associated with the PJ syndrome. So they are characterized by the presence of simple and complex annular tubules. So it is a sharply circumscribed nest composed of ring-like tubules which surround the basement membrane-like material. What is the origin? Whether they are representing the Sertoli cells tumors or the modified version of the granular cell tumors, because they have features intermediate between these two. These cells contain Charcot-Butcher filament bundles in the cytoplasm, which is a characteristic feature seen in the cytoplasm of the Sertoli cells. The differential diagnosis include the adult granular cell tumor, Sertoli cell tumor, and gonadoblastomas. ISC is positive for inhibin, calretinin, WT1, SF1, CD56, FOXL2, and negative for EMA and CD10. So already I have listed the differences between the sporadic cases and those patients with the PJ syndrome. That we move on to the third case, 52-year-old female presented with a pelvic mass. And sorry, I could not get the gross pictures for some of them. because, okay. Now here you can see there is this neoplasm, the cystic neoplasm with a solid component made up of papillary processes which are branching at the scanner view. Low power view shows the hyalinized fibrovascular cores, the hyalinized fibrovascular core and the branching papillary processes lining these hyalinized cores. It's the same thing. And hyper view shows these papillae are lined by cells which have clear cytoplasm, vesicular nucleus, and prominent nucleoli. So the cells have a clear cytoplasm. So this is the stroma, and you have the papillary processes which are lined by cells having clear vacuolated cytoplasm. So your diagnosis?
High-grade serous carcinoma.
I was stressing on clear cell. And the nuclei don't look so pleomorphic. No? See, what else can you think of? Any other surface epithelial tumor?
Clear cell.
Yes, correct. Yes.
Clear cell tumor. Clear cell
Yes,
tumor.
it's a clear cell carcinoma. It's a clear cell carcinoma of the ovary. Very good. So it accounts to 8.2% of all ovarian carcinomas. And this tumor is associated with the Lynch syndrome, and most of them arise in the ovaries with endometriosis. So endometriotic cyst. You can see the solid malignant transformation occurring in the endometriotic cyst. And clinically, patients age ranges from 50 to 53 years. Patients present with a pelvic or abdominal mass, and these tumors secretes the calcium. So hypercalcemia is common. Paraneoplastic, patient present with vascular thrombotic events. Grossly, the ranges in diameter up to 30 centimeters, and it may be solid and fibrous with a honeycomb cut surface. And more commonly, cut surface will show multiple yellow beige fleshy nodules projecting into the lumen of these cysts. Microscopically, there are various patterns, papillary, tubulocystic, and solid, with the combinations occurring. And they can be divided into two types. Clear cell carcinomas arising in a cyst, that is endometriotic cyst. More commonly, they are papillary, and clear cell carcinomas with an adenofibromatous background. More commonly, they are tubulocystic. And the third pattern is a solid pattern, which is composed of sheets of polyhedral cells with abundant clear cytoplasm separated by delicate and dense fibrotic stroma. In the papillary pattern, the hyalinized papillary cores are the characteristic feature. That's why I was stressing on the hyalinized papillary cores and the clear cell nature of the cytoplasm. This clear cytoplasm contains either glycogen or intracytoplasmic mucinous inclusions, which are PS positive. Nuclei are small and rounded, and sometimes they may be large and pleomorphic with prominent nucleoli, but the nuclear grade is always high. In the tubulocystic and papillary patterns, you can have a hobnail appearance of the nuclei projecting into the lumen. Mitotic activity is less than 10 per 10 hyper feet, and necrosis, hemorrhage, and stromal lymphocytic infiltrates are variable. Sometimes you may get luteinized stromal cells and summamatous calcification. If there is no invasion, but only cytological atypia is present, then you call it as atypical proliferative clear cell tumor with intraepithelial carcinoma. And in oxyphilic clear cell carcinoma, the cytoplasm contains abundant granular eosinophilic cytoplasm rather than clear. They are positive for CK7, CAM 5.2, EMA, LUM1, B72.3, and 34 beta, E12, where it is strongly and diffusely positive. HNF1 beta shows nuclear positivity in more than 90% of the cases. The differential diagnosis include the festooning papillary process, which you've seen in YST, dysgerminomas, APST, high-grade serous carcinoma. So somebody said this. So differential diagnosis, high-grade serous carcinoma with clear cells. The endometrial carcinoma is secretory changes, steroid cell tumor, tumor ovary, and metastatic RCC. The fourth slide is 21-year-old female who presented with abdominal pain and distension of the abdomen. Microscopically, LOPA view shows spared superficial cortex and rest of the ovaries being involved. So here you can see thin eosinophilic edema fluid separating the spindle-shaped stromal cells. So the spindle-shaped stromal cells are separated by thin eosinophilic fluid, which is diffuse, and important clue, it spares the superficial cortex. So what's your diagnosis? Grossly, that ovary will be soft and fluctuant.
Soumya, tell. Massive stromal edema.
Okay. Anyway, good. I give good. So it's not a tumor. So we saw in the first three cases, we saw more the tumors. No, this is not a tumor, but it's a tumor-like enlargement of one or both ovaries, which is secondary to an accumulation of edema fluid within the ovarian stroma. It is closely related to ovarian fibromatosis. Clinically, typically the patient is young with mean age of 21 years. Patient presents with abdominal or pelvic pain, menstrual irregularities, and abdominal distension. 90% of them are unilateral, and androgenic manifestations can be seen in about 20% of the cases when it is associated with luteinized stromal cells. This occurs either due to partial or complete torsion of the involved ovaries. Rarely, it may be associated with mix. So grossly, the ovaries enlarged, soft and fluctuant. So you got the clue from that. Good. External surface will be shiny, smooth and white. Cut surface is edematous, is gelatinous and exudes watery fluid. The fallopian tube also is edematous. And microscopically, there is marked diffuse stromal edema, which typically spares the superficial cortex. It separates and sometimes involves the follicular structures. The cortex is usually thickened and fibrotic, and the stromal cells are separated by the pale staining edema fluid. Now, whether fibromatosis is the precursor of massive edema is controversial, or whether it represents a spectrum with burned out stage of reactive fibroblastic proliferation on one end and a variety of highly cellular fibroblastic tumor-like lesion on the other end. So how will you differentiate it from a tumor? Because generally fibromas, tumors, any neoplasm, it can be surrounded by a rim of normal ovarian tissue in contrast to massive edema. And it diffusely involves the ovary. It does not spare the superficial cortex, as in the case of massive ovarian edema. Why is the need to recognize this by fluorescein section? Because you can spare the ovary. It's seen in younger age group. And fibromas usually occur in older age group and they are hormonally inactive. Yes. So we have seen a few cases of the ovary. Next, I want to move on to the lesions of the uterus. So I have 6 cases in that. So we shall see them one by one. Before that, I want to highlight certain features about the endometrial pipal biopsies. Now, what are the general indications for endometrial biopsies? To determine the cause of abnormal uterine bleeding, to assess the response of the endometrium to hormonal treatment, to know the status of the endometrium in infertility, to dating of the endometrium. So which day of the cycle you should do the biopsy? If you want to date for the infertility, which day? Post-ovulatory or pre-ovulatory? So it's done on the 7th or 8th post-ovulatory day. And to evacuate the products of conception, And then whenever ultrasound shows a thickened endometrium, so up to 12 mm is normal in a reproductive age group. Anything more than 12, so you have to be cautious. And in the case of postmenopausal women with atrophic uterus, the endometrial would normally it will be only 3 to 4 mm in thickness. So any increase in thickness of the endometrium has to be taken into mind, and it's one of the indications for the endometrial biopsy. And abnormal glandular cells or presence of endometrial cells in the pap smear is also an indication. So how do you obtain the material? Either previously they used to do curating. Now people is practiced as an OP procedure because it is fast and it does not require any anesthesia. But of course it doesn't. Disadvantages like focal lesions can be missed, and in atrophic endometrium you obtain only scant tissue. Hysteroscopy and direct biopsies can be taken, or transcervical resection of the endometrium can be done. In the case of polyps, the entire polyp is removed, and normal endometrium adjacent to the polyp should also be sampled. In transcervical resection of the endometrium, the entire sample has to be weighed similar to your prostatic chips, and it should be submitted for histopathological examination. If it's a smaller polyp, then you can submit it entirely. If it's a larger polyp, then you have to take bits and submit it. What is important is the clinical history. So you should know the age of the patient, the menopausal status, last menstrual periods, how regular are the cycles, and whether the patient is on any hormonal replacement therapy or whether the patient is on oral contraceptive pills. So the clinical details are very important. And there's no definitive guidelines to say how adequate, whether the endometrial biopsy is adequate or not. If you can make a diagnosis, then it is adequate. But please do not sign it out as inadequate. You can put it as it's unaccessible. It's not accessible. Okay. And when you see fat in the endometrial curating, that means it's perforation. So it's for critical value. So the endometrial biopsy, whether it is obtained by a pipil or curettage, if there is inadequate sample, whether should we do a rebiopsy or not, that depends on whether the patient is having a normal ultrasound findings or not. The patient has a normal ultrasound findings and there is no clinical suspicion, then rebiopsy is not needed. But when clinical suspicion is there or abnormal ultrasound is there, then rebiopsy is a must. Certain artifacts can occur in these endometrial biopsies, like telescoping. So, yes, telescoping, where you see the gland within the gland appearance. That is due to mechanical disruption and snapback of glands during taking the biopsy. This form of intussusception. Then you may get a pseudo-papillary architecture. That's because of there is no stroma, and here you have to look for proliferative activity and atypia. And sometimes you get to see crushed endometrial glands in atrophic endometrium. Artifactual crowding and compression of glands can be seen, which mimics hyperplasia. Here the glands are molded together and there is a tearing of tissue around the glands, which is a clue to the artifactual nature. Vacuolated stromal cells can be seen due to cautery, which gives a signet ring-like appearance. With this background, we move on to the next case. It was a 55-year-old female. Hysterectomy specimen was received and cut surface shows a proliferative growth occupying almost the entire endometrial cavity, soft and fleshy, but there is no areas of necrosis or hemorrhage. Microscopically, you can see the endomyometrial junction, and there is an infiltrating neoplasm with a superficial invasion of the myometrium. And how are these tumor cells arranged? Long, slender, tall papillary processes with central fibrovascular cores. And hyperview shows they are lined by a single layer or sometimes occasionally stratified, tall columnar cells with vesicular nucleus, grade 1 nuclei, most of them contain. There are no solid areas. There are no solid areas. In other fields also did not show solid areas. So the diagnosis is type 1 endometrial carcinoma, glandular type. Sorry, I did not give you a chance. I should have put a blank slide in between. It was an easy case, so you could have easily diagnosed it. I wanted to discuss this with the next slide also. So I'm proceeding with the next slide. Endometrial pipal sample was obtained from a 65-year-old female. I wanted to try whether this video is working in this. That's why only for one slide I have put this. Anyway. Okay. I have pictures for the same. So we'll go into that. So this is a cellular neoplasm. At this part, you can see it's a cellular neoplasm in the scanner view and a few papillary processes, solid areas predominantly. And the lower view shows the short, broad papillary processes. Yes, you can see the short, broad papillary processes with hyperchromatic nuclei. Yes, hyper view shows the hyperchromasia of the nuclei, which are very pleomorphic. And here also again you can see, and some hobnailing is seen. Hobnailing is seen. You can make out the high degree of pleomorphism and abnormal mitosis. The nuclei are predominantly hyperchromatic and some of them are vesicular with prominent nucleoli. So now what's your diagnosis? It's a pipal specific. Yes?
Type 2 endometrial
High-grade
carcinoma.
endometrioid.
Type 2 endometrioid. So type 2 has many under it. It has subtypes. So which yes, serous. Very good. So you can compare the thin papillary strands like papillary processes which you see, which you saw in the case of glandular carcinomas, as opposed to the short, broad papillary processes with hyperchromatic pleomorphic nuclei in the case of a serous carcinoma. So type 2. So you again, marked pleomorphism is seen. Some of them showing the typical hobnailing appearance. So it's a serous carcinoma. So we'll see about the general features about the endometrial carcinoma, and then yes, it is endometrial carcinoma accounts to 7% of all invasive cancers in women with a peak incidence between 55 and 65 years. That is, I'm talking about the type 1 endometrial carcinoma, which is usually associated with obesity, diabetes, and hypertension, infertility, and unopposed estrogen stimulation, which is due to the estrogen secreting ovarian tumor and following estrogen replacement therapy, which is given. Actually, we had a case of endometrial carcinoma occurring in a 38-year-old woman who was treated with tamoxifen and for breast carcinoma a few years back. She had malignancy of the breast when she was in her late 20s. And she developed, unfortunately, she developed malignancy of the endometrium when she was only 38. They may be associated with hereditary syndromes like Lynch and Cowden. Endometrial carcinomas classified into the endometrioid carcinoma, which is classical with the variants, and serous carcinoma, clear cell carcinoma, and carcinosarcoma and so. Molecularly, you can subdivide it into endometrial carcinomas with pole mutant type and pole wild type, which is further subdivided into MMR deficient and proficient, and P53 wild type and P53 mutant subtypes. Sometimes the molecular testing is not done or inconclusive, then you can write it as not otherwise specific. Okay. The endometrioid adenocarcinoma is the most common type of endometrial carcinomas, which resembles the proliferative phase endometrium. When it shows more than 10% differentiation into either serous, mucinous, or clear cell, then you call it as a mixed carcinomas. Patient presents with postmenopausal bleeding. Grossly, the endometrial surface is shaggy, glistening, and tan, and maybe focally hemorrhagic. It can be exophytic, and even when it is deeply invading into the myometrium. Lesions can be either focal or diffuse, with necrosis occurring in poorly differentiated tumors. Involvement of the myometrium causes enlargement of the uterus. It can extend down into the lower uterine segment and the cervix. Grading and staging of endometrial carcinoma is very important to know about the prognosis. Grading is based on the architectural pattern, the nuclear features of both. So architectural grading, so in the first case, I told you there is no solid areas. So because architectural grading is based on the extent of solid masses of cells as compared to the well-defined gland. These solid masses of gland, you should not mistake the areas of squamous cell metaplasia. Sometimes you will get in endometrial carcinoma with solid masses. And next you have the nuclear grading, which that depends on the nuclear size and shape, the chromatin distribution, and size of the nucleoli. Mitotic activity is increased with increasing nuclear grade as of the abnormal mitotic figure. So architectural grading, grade 1, less than 5% of the tumor is composed of solid masses. Grade 2 is 6 to 50% is solid masses, and in grade 3, more than 50% of the tumor is composed of solid masses. The tumors are graded primarily based on the architecture, and usually they go hand in hand with the nuclear grade, especially in type 1 carcinomas. And whenever there is a discordance between architectural grading and nuclear grading, you must always follow the nuclear grading. And there will be tumor heterogeneity. That is, one area may be showing a different grade from another area. So you have to take the overall grading, should be taken into account. And among this, usually there is concordance, but whenever there is a disparity, the nuclear grading is taken into account in type 1 carcinomas. Type 2 carcinomas are usually high grade. Myoinvasion can occur in the form of a broad pushing front or diffuse infiltration. What is the specific feature about adenocarcinoma when it involves adenomyosis? Usually, it's a low-grade tumor, occurs following estrogen therapy, and has a better prognosis. In adenoma malignant pattern of invasion, the stromal inflammatory response is not there. And sometimes you may get unusual form of myoinvasion, the form of MELF, microcystic, elongated, and fragmented, where some of the glands gets detached, gets dilated and lined by flattened epithelium. That is microcystic, elongated, and fragmented. So staging of the endometrium, in stage 1, it's limited to the uterine carpus. When it involves less than 50% of the myometrium is stage 1A, more than 50% is 1B. And stage 2 involves the cervical stroma, and stage 3A, when the tumor invades into the serosa and adnexa, and stage 3B involves the vagina or the parametrium, and stage 3 involves the pelvic nodes or does metastasize the para-aortic group of lymph nodes. In stage 4A, that is invasion of either the bladder mucosa or the bowel mucosa, and stage 4B is distant metastasis. The differential diagnosis include atypical hyperplasia, atypical polypoid adenomyoma, hyperplasias with metaplasias, and ariostellar reaction. So, villonodular carcinoma is a variant of endometrial carcinoma that displays a papillary architecture composed of thin, delicate fronds. The fibrovascular core is covered by columnar cells with oval bland nuclei. Mitotic activity is variable and abnormal mitotic figures are rare. Even if myometrium is involved, it is only superficial. The differential diagnosis is the serous carcinoma with the short, broad papillary processes. This occurs, serous carcinomas typically occurs in postmenopausal women with atrophic uterus, and it's less likely, these patients are less likely to have received the estrogen replacement therapy, and they do not have the other risk factors which you've seen in the case of the type 1 carcinomas, that is the metabolic syndrome, obesity, hypertension, diabetes. So it's commonly seen in Black women. These grossly, the uterus with serous carcinoma often are small and atrophic, sometimes unassuming. The clinician would not have even have suspected. We have seen cases like that. So it will only when you're taking the bits from the hysterectomy specimen, you have diagnosed cases. Or the tumors may be having exophytic and papillary appearance, or it can develop from a polyp. So it is always high grade, which is characterized by uniformly marked cytological ATPR. The papillae here are short, thick, and broad. And sometimes papillary clusters can get detached from these papillary processes, and they are called as papillary tufts. Scalloped luminal border or seen. The nuclei are highly pleomorphic and atypical with cherry red macronucleoli. You will get hobnail appearance of cells with smudged hyperchromatic nuclei. So there is always discordance. I told you it is a high grade because the architecture looks well differentiated, but the nuclear morphology is on the higher grade. So always follow the nuclear morphology. You may get multinucleated cells with giant nuclei and bizarre forms in 50% of the tumors. Mitotic rate is generally high with abnormal mitotic figure, and adjacent endometrium is atrophic. Hyperplasia without ATPR is seen in less than 10% of the cases. And sometimes you will get a minimal uterine serous carcinoma or SEIC. That is when the tumor is less than 1 centimeter in size. Then you call it as a minimal uterine serous carcinoma, and SEIC stands for serous endometrial intraepithelial carcinoma. The differential diagnosis includes the villow-glandular carcinoma, endometrioid carcinoma, papillary syncytial eosinophilic change, which will show spaces with neutrophils, and metastatic serous carcinoma from ovary or fallopian tube are typically bilateral, so it can be differentiated. IHC shows strong diffuse positive for P53 because of the TP53 mutation, and there's a diffuse P16 expression, whereas it will be patchy in endometrioid carcinoma type 1, and there's lack of expression of ER and PR. It will be positive in type 1 carcinomas, and extremely high proliferation indices CARE-67, mutations in TP53, tumor suppressor genes are seen. Next slide is a 68-year-old female. Fractional curettage material was received. See a highly cellular neoplasm. Most of them showing spindle-shaped cells and low part. And you can see some glandular patterns, solid areas with highly pleomorphic cells and hyperchromatic nuclei, which are pleomorphic. And you can see the glands. So glands are seen, solid areas are seen, and you're seeing some spindle-shaped cells. So these are the solid areas, and these are the spindle-shaped cells. Yes, so you're seeing both spindle-shaped cells and the glandular elements, both of them appearing malignant. What's your diagnosis?
Carcinosarcoma.
Very good. And then what's the difference between carcinosarcoma and adenosarcoma?
Yes, Soumya, tell. Adenosarcoma. It is not carcinosarcoma.
This I accepted. But then what's the difference between that and adenosarcoma? How will be the glands in adenosarcoma? Glands will be benign. Here, both the glands and the stromal component are malignant. Okay. So it's a carcinosarcoma or the malignant mixed Mullerian tumor. Very good. It accounts to less than 5% of malignant neoplasm of the uterine carpus. It is having a biphasic appearance. And how do you get both? Because of either divergent differentiation or tumor progression or progression from an adenosarcoma, or a bidirectional differentiation from a single multipotent stem cell. Here, risk factors include obesity, estrogen use, nulliparity, tamoxifen therapy, all similar to that of the type 1 carcinomas. And in addition, patients treated with pelvic irradiation for rectal or cervical carcinomas. And it occurs in an older age group with vaginal bleeding, and it may present as a polypoidal mass protruding to the cervical arch. Grossly, it is polypoidal, filling the entire endometrial cavity, may invade the myometrium, and it can present through the cervical arch with a necrotic tip. It is soft to firm with areas of hemorrhage and necrosis. So microscopically, you will see a admixture of both malignant epithelial and mesenchymal component. The epithelial component is usually serous and high-grade carcinomas, and the homologous stromal component is either high-grade spindle cell like fibrosarcoma or pleomorphic like MFH, and or heterologous component like rhabdomyosarcoma and chondrosarcomas. And differential diagnoses include the dedifferentiated endometrial carcinoma, endometrioid adenocarcinoma of the corded and hyalinase variant with spindle cell element. Prognosis depends on the extrauterine extension and the myometrial invasion along with the lymphovascular invasion. Advanced age has a poor outcome, and presence of the heterologous sarcomatous differentiation, especially the rhabdomyoblastic differentiation, is associated with very poor survival. Next case is a 45-year-old female, hysterectomy specimen with a separately sent leiomyoma for evaluation. So this is the gross specimen of the cut surface of the tumor obtained, and microscopically you can see the highly cellular neoplasm with numerous giant cells, tumor giant cells at this power itself. Yes, tumor giant cells. But there were no mitosis, absolutely no mitosis. You're seeing tumor cells, spindle-shaped cells with plenty of tumor giant cells. ATPia is minimum, you can see ATPia, but there is no necrosis. And there are no mitosis, or very rare mitosis are seen. So what do you think it is? Is it leiomyoma or leiomyosarcoma or something else?
PGs, please tell.
PGs, you can say there are no mitotic figures, there are no necrosis. You're seeing tumor giant cells and ATPia.
Agata, you know the diagnosis, tell. Usha, not.
Okay, it is leiomyoma with bizarre nuclei or atypical leiomyoma or symplastic leiomyoma. There is moderate to severe cytological atypias there, and you will see very less mitotic activity, or actually in our slide we had very few, less than 5 pattern hyperfill. There are no areas of necrosis. The nuclei are enlarged hyperchromatic with prominent chromatin clumping and smudging, and numerous multinucleated tumor giant cells. Mitotic count can be done using phosphohistone H3 immunostains, and you need to do an extensive sampling to rule out leiomyosarcoma, because that you should not be missing it. And there are 2 genomic subtypes, one with FS aberration and other one carries the T53 or retinoblastoma abnormalities. Slide 9 is a 61-year-old female hysterectomy specimen. Here again you can see a very cellular neoplasm. Very cellular neoplasm at this power, and you can see the tumor cells are very atypical. And abnormal mitotic figures can be seen. Again, abnormal mitosis can be seen. So mitotic count was more than 10 per 10 high power field. So now tell me, what's your diagnosis?
Leiomyosarcoma.
That's fine. So it is leiomyosarcoma. I kept these 2 slides for you to appreciate. You should not mistake one for the other in the exam. That is why. So the mitotic count plays a very important role here in the differentiating, as a differentiating point. Leiomyosarcoma accounts to 1.3% of uterine malignancies and more than 50% of uterine sarcomas. Age is between 50 to 55 years, and patient presents with either AUB or lower abdominal pain or as an abdominal mass. It is not associated with pelvic radiation. So whereas we saw carcinosarcomas associated with pelvic radiation, this is not so. Most of them are intramural and solitary. And grossly also you can differentiate leiomyoma from leiomyosarcoma because they are larger, fleshy, soft, and hemorrhagic, as opposed to the typical leiomyoma, which has a whorled cut surface and solid. And this has a poorly defined margins. Yes. And you see, microscopy is composed of fascicles of spindle cells with abundant eosinophilic cytoplasm and longitudinal cytoplasmic fibrils, which can be highlighted by the trichrome stains. Nuclei are fusiform with rounded ends, hypochromatic with gross chromatin and prominent nucleoli. Cells show marked degree of pleomorphism, and more than 50% of these cases will show multinucleate cells. What is the clenching point? Nuclear atypia, a high mitotic index. That is more than 10 per 10 hyperfill, but typically more than 15 mitotic figures per 10 hyperfill, and areas of coagulative tumor necrosis. So you need to differentiate between the leiomyosarcoma. So these it has either areas of necrosis or atypia and mitotic figures more than 10 per 10 hyperfill. Whereas in stump, that is smooth muscle tumors of undetermined malignant potential, the mitotic count is less than 10 per 10 hyperfill, and there may be necrosis or atypia. Either one of them will be present. And in leiomyoma, there is no necrosis, and mitosis is less than 5. And in mitotically active leiomyoma, the mitotic count accounts to 5 to 20% per 10 hyperfill. Yes. IHC will be positive for smooth muscle actin, Desmond and Carl-Desmond, and it may invade the surrounding myometrium. So leiomyosarcoma, the differential diagnosis include the leiomyoma variants, stump, endometrial sarcoma, IMT, undifferentiated sarcoma, malignant SFT, the sarcomatous component of adenosarcoma or carcinosarcoma, or extension of this from the rectum. So prognosis depends chiefly on whether it is a uterine confined disease or extrauterine disease. 10th case, you have the 45-year-old female patient presented with a vulval mass. Yes, you can see the skin underneath, which is the lesion. So it is composed of the glandular spaces of varying dimensions, and you can see the papillary processes, the glandular spaces separated by fibrous tissue, and you can see the papillary processes within the glands, and some of them are having an apocrine linings. So some of them are having an apocrine lining. Others are lined by tall columnar cells with the base myoepithelial cells. So some of them are showing apocrine lining. Myoepithelial cells are present. What's your diagnosis?
Hydradenium papilliferum.
Very good. Hydradenium papilliferum is the most common lesion of anogenital mammary-like glands and most common benign glandular lesion of the vulva, occurring in between 49 to 52 years, seen in interlabial sulcus, labia majora or minora. Grossly, it is cystic, solid, or pedunculated, usually asymptomatic, and grossly, the lesions are present as elevated area with a palpable subcutaneous mass, red, blue, or skin colored, solitary lesions with a mean diameter of 6 to 7 mm, and they have a mixture of papillary and tubular structures lined by cuboid to columnar epithelial cells with a myoepithelial lining, but they may be, the myoepithelial layers may be flattened and inconspicuous, but detection of myoepithelial cell layer is critical to the diagnosis. And areas of apocrine metaplasia is very common. Sometimes you may get areas of solid or streaming growth of the epithelium with intraluminal tufting, arching, and micropapillary processes, but it's a benign tumor. 11th slide, 32-year-old female, patient persisted with persistently elevated HCG, hysterectomy specimen. You can see the myometrium and some structures in between. What is this? Within the myometrium, you're seeing some structures. Hyperview. Yeah, very good. They are chorionic villi, which has invaded into the myometrium. Chorionic villi with tropoplastic and hydropic chorionic villi. Hydropic chorionic villi, which has invaded into the myometrium with the tropoplastic proliferation. So the diagnosis is? Yes, very good. Invasive heretiform mole, where hydropic villi invade the myometrium or the blood vessels, or rarely they may be deported to extrauterine sites like lungs. It's not a true neoplasm, but considered clinically malignant because it can invade into the myometrium and can metastasize. And it's usually the possible sequelae of the complete heretiform mole, and it may occur simultaneously or with an intracavitary molar pregnancy also. So pathological diagnosis requires the demonstration of the molar villi invading the myometrium or deported to extrauterine sites like lungs. Grossly, the lesions are erosive, hemorrhagic, and extending from the uterine cavity into the myometrium, and with sometimes perforation or involvement into the adjacent structures, but you can see the molar vesicles grossly. So the presence of molar villi along with tropoplasm in the myometrium or an extrauterine site is a must for detection of the invasive heretiform mole. Because when you don't get to see these molar villi, then you call it as a choriocarcinoma. And in the case of placenta accreta, increta, and percreta, you will see the villi into the myometrium, but they are not molar. So these are the two differential diagnoses. The molar villi are 4 to 5 mm in diameter and behaves as this is the most common form of persistent or metastatic gestational trophoblastic disease after the heretiform mole, mostly confined to the uterus, but it can spread to other sites. Deportation can occur. The risk of, luckily, the risk of progression to choriocarcinoma is not more than that of any other complete heretiform mole without invasion. Vijay, can I continue for 5 more minutes? Or shall I stop?
Sure, ma'am. Sure.
Thank you. 52, this is my last case. 52-year-old female, hysterectomy specimen. So you can see the hysterectomy specimen. So as opposed to the tumors which you saw earlier, this tumor is soft, fleshy, and you can see areas of necrosis and hemorrhage. And is extended deep into the myometrium and even beyond that. Microscopically, it's a blue tumor where most of them are centered around blood vessels. Yes, again, this scanner view shows the same thing. And low power view, you can see this tumor cells or surrounding vessels, and there are areas of necrosis in between. And how are their tumor cells arranged? And what are they composed of? They are small cells and seem to resemble some of the tissue which you see in normal practice. They resemble they are small. Very good. They resemble the endometrial stroma of the proliferative endometrium, small round to oval cells with scant cytoplasm and round to oval nuclei with inconspicuous nucleoli. So these, and there are prominent blood vessels. So the diagnosis is?
Endometrial stromal sarcoma.
Low grade. Very good. Endometrial stromal sarcoma, low grade. Actually, nowadays they do not call it as a high grade and low grade because the high grade is now classified as undifferentiated endometrial sarcoma. So this is tumor of endometrial stromal cells that are invaded in the myometrium, and it accounts 20% of uterine sarcomas and occurs at a little younger age group than the other uterine malignancies, and it is not associated with any of the endometrial carcinoma risk factors, but patients with history of prior pelvic radiation. Similar to triple MT, this also can occur. And patient presents with AUB or abdominal pain and cannot be detected by PAP because the cells lack sufficient ATPR. Okay. The uterus is typically enlarged, irregular in contour, and again, this can be presenting as a bulky polypoidal tumor which protrudes through the cervical os. And similar to that triple MT, it can protrude to the cervical os. And soft, tan, smooth cut surface polyps, which are maybe infarcted and hemorrhagic. The myometrial involvement shows 3 patterns. The most common pattern is by pink, tan, or yellow cords or nodules of tumor involving the myometrium. Or second pattern, a diffuse thickened endometrium. Third one is a nodular tumor, which has a typical yellow-orange cut surface. Microscopically, the tumor cells resemble the proliferative phase or hyperplastic endometrial stromal cells, monotonous appearance. The tumor cells are relatively uniform in size and shape with round oval nuclei, having finely granular or dispersed chromatin and small inconspicuous nucleoli. Cytoplasm is amphiphilic and the cell borders are poorly defined. Mitotic count is very low, less than 3 per 10 hyperphae. And one important feature of ESS is the proliferation of small vessels and arterioles, looking like the spiral arterioles, and reticulin stain presence with the shows a basket weave-like pattern because it surrounds individual cells or small groups of cells. Sometimes you may get to a combination of smooth muscles. Even it is more than 30%, then you call it as a combined stromal smooth muscle tumor. And when they take on an epithelioid appearance embedded in collagen, then it is called as a star bust-like appearance. Invasion of vascular channels is a characteristic feature of endometrial stromal sarcoma. IHC is strongly positive for CD10. They are positive for WT1 and beta-catenin, ER and PR. And areas with smooth muscle differentiation shows Caldesmon positive, and recurrent translocations, the features seen in of chromosome 7 and 17 are seen in ESS. Differential diagnosis includes the endometrial stromal nodule. Here, endometrial stromal nodule, you don't get to have a myometrial invasion. And highly cellular leiomyoma is the next common differential diagnosis. And then you have the picomas or the tumors of the perivascular epithelioid cells. And last is the adenomyosis with sparse gland. Grossly, no tumor is seen in this. So I have 3 spotters for you. This is the ovarian lesion where you're seeing spaces filled with eosinophilic fluid. Do not confuse it with the massive edema of the ovary. Here, the ovarian stroma appears normal. Only thing you're seeing these spaces lined by flattened cells and filled with fluid. You can give a differential diagnosis. They are not RBCs. It's only fluid. Supposing if I'm showing the spaces with RBCs, you would have called it as what? Hemangioma. So when there are no RBCs, you're seeing spaces. Yes?
Yeah, lymphangioma.
Very good, Vijay. Very good. Okay. And this is an incidental finding in ovaries, and you're seeing some tubules and you're seeing some nests. So this was seen in the same ovary. Otherwise, grossly, the ovary was very normal. Any guess? This you can make out, no? This is a nest of transitional cells.
What are those?
What is it?
Tell, yes.
Yes. Before that, a pre-runner of it.
What do you call those? Before the
You will usually see it in the fallopian tube. You'll see it in the fallopian tube, but here we saw it in the ovary.
What do you call it in fallopian tube?
What
This kind
is
of
it?
transitional dress. It
What
can
are
be
they called?
cystic, it can be nest. Yeah. Somebody has put Walther cell nest.
Very good, very good. Walther cell nest, and these are remnants of what? Yes, mesonephric duct remnants. And very easy spotter here. See, you can see the normal endometrium, and look at this endometrium. It is showing something. The arrows are pointing to these cells. Usually asked theory question.
Yeah.
Short note. Theory short note.
Think. Why is it different?
Is it normal? Is this and the same? This different, no? This is a normal endometrial lining. Yes, somewhat you are, yes, yeah, tell. What do you want to say? Ariostella? No, not Ariostella.
Somebody has
Yes.
put metaplasia.
Very good, very good. So okay, you can give it to them. So it is a metaplasia. Very good. It's a form of tubal metaplasia. It's a form of tubal metaplasia. Thank you. I think I have exceeded my time. I'm very sorry about that. And
no, madam, no, don't think so.
Vijay, thank you so much for your invite and the response from your students. That was also very nice.
Thank you, ma'am. Thank you so much for the effort and the time. It was really good. They enjoyed it because they need to feel confident going for the exam now. Thank you so much.
Okay, thank you. I have not put very, I have included most of the exam oriented slides.
Exactly.
Okay, thank you, ma'am.
Thank you.
Okay.
Thank
I
you.
should back my PG at this juncture, PG Mogna, because I was a little jittery about the online presentation. My sincere thanks to her. Thank you, Vijay.
Thank you, ma'am. Thank you.
Okay, bye.
Now on to our last session of the day. Please join me in welcoming back Shatura ma'am. She had captivated us yesterday with her knowledge on salivary gland cytology. Ma'am, over to you, ma'am.
Thank you, Ma. And once again, I need to thank Dr. Vijaya and her team and the CARE-PARE 2024 before I start my session today. And
welcome, ma'am, for today's session.
Yes. And I need to thank people who attended yesterday, and I missed the slide. I'm sure we had dilemmas, right? And then we anyway decided to go ahead and enjoy the delights of salivary gland cytology. So I hope I can keep you enthralled today also. And being the last batsman on the second innings, right? So we'll go ahead. And the topic I chose was nerve sheath tumors, right? So when it comes to nerves, we are always trying to hold our nerves and settle our nerves. And nothing better an example is a tree which holds itself by roots, right? And settles down, you know. And when you cut across one of these branches, I really thought this looked like a nerve. Now, both of these are from Ireland, where I'm presently there, and I enjoyed it. So we'll go ahead with the case one. Most of the things I'm doing as case based today, right? So we'll go ahead with the cases. I hope you're able to see my screen. Now, there's no magic method for beginning. Take hold of your nerves and jump, right? So somewhere we have to make a beginning. Everyone has the capacity for change and growth. As Maya Angelou put it, do the best you can until you know better. And once you know better, do better. So I think my talk will help you to do something more better than what you were doing earlier. And I'm hoping that I can keep you people interested as the case proceeds, right? So when you say settle one's nerves, you're trying to keep calm, composed, and relaxed. And this is what happens when you see one of these nerve sheath tumors. You start being very anxious, but I'm sure there are pointers which will help us to settle down and make a diagnosis. Right. So beginning with the first case, it was from a 16-year female, pain abdomen, and the mass abdomen was in the left hypochondriac and lumbar region. Definitely a huge mass, right, for which the clinician was worried. And they went ahead, and she was a young female, so they resected it. And this was the resected specimen we got. And this was fresh in the OT. And after fixation, you all can see how the color has changed. It was looking very well capsulated. The cut section definitely appeared more tawny or yellow colored appearance than what we usually see. But it was a fleshy tumor. And the clinician was also very anxious to know what the diagnosis would be, and because she was a young female patient. Now the slide showed just beneath the capsule, there were a lot of lymphocytic aggregates. There were some nerve fibers also beneath the capsule. Now, when we go to the tumor proper, it was a very cellular tumor with spindle cells, and there were gland-like spaces. And you can see these are virtually lined with pseudostratified columnar lining-like appearance. Another observation you could make in this area was there was a blood vessel which had a, anybody? What was this area? Around this blood vessel. Okay, let's see if you have a better picture. Right, you get another blood vessel which had this pink areas around it. There was a cellular areas below, right? And again, as I told you, cystic spaces which had a lot of pseudostratification in the lining. The rest of the tumor had spindle cells with pointed ends, blunt ends, everything, and short fascicles were running in various directions. So with these and additional areas, your tumor appeared yellow in color. So definitely on section, we did find lot of xanthomatous cells, right? Cells with abundant granular to eosinophilic cytoplasm, right? And small micro vacuoles and places. So these were the xanthomatous cells corresponding to the gross appearance. Right. So any takers, or let me summarize what I saw. There was a circumscription, thick capsule, lymphoid aggregates in the capsule, hypercellular fascicular whorl pattern. But I could not show you any verrucae bodies. They were predominantly Anthony A, and they were very focal Anthony B areas. I did not pick up mitosis. There were xanthomatous histiocytes. And the feature I was asking you to observe was the hyalinization of the vessel walls. I have not done an S100 stain because it's very diagnostic. Seldom we do it usually, right? But if you have a facility, you could go ahead and do a S100 immunostain. So anybody has an idea what this, or want to take a chance in letting me know what this is?
Ancient schwannoma.
Ancient schwannoma. What were the features that made you think for ancient? Just the secondary changes, right? So it was a schwannoma, fine. But you only had xanthomatous histiocytes, right? So a better proposal would probably be a cellular schwannoma. Ancient schwannoma, you need to have nuclear atypia, smudged nuclei, enlarged nuclei, right? But usually schwannomas can show a lot of secondary changes, whereas this was a cellular schwannoma with pseudoglandular elements. You had a lot of cystic spaces lined by stratified cells, which were nothing but the Schwann cells itself. Usually it has a wide age range, common in females, retroperitoneum and posterior mediastinum. Head and neck and extremities are rare. It's a benign variant of schwannoma. NF association or neurofibromatosis association is very rare. So we should remember that you could get to see a pseudoglandular elements. Now, being in that location, there might probably be other differentials, right? So the other differentials would just be a schwannoma. If I was able to show you verrucae bodies, Anthony A, Anthony B areas, right? Even there in a regular schwannoma, you could have pseudoglandular elements. But if there were a lot of mitotic figures, it could be a malignant peripheral nerve sheath tumor, which can also have glandular elements. But synovial sarcoma, biphasic synovial sarcoma in a retroperitoneal location would become important. Biphasic sarcomas can have glandular elements. Now, the clinician was insistent that it was a GIST, right? Just because of the location, and we were able to show a lot of perivascular hyalinization, and the young age of the patient, we favored a diagnosis of cellular schwannoma with pseudoglandular elements. So sometimes the schwannomas can mimic other lesions. Now look at this, was sent from a neck, and it was wholly a cystic wall-like area. And when we gave sections, you can again see the cyst lining, the tumor cells itself start getting compacted here, and it appears like a lining. It had a lot of hemorrhage, and the pearl stain also picked up the hemorrhage. So cystic schwannomas, right, can have a lot of pseudoglandular elements. But luckily, we were able to pick up the verrucae bodies in this case. Now we also get conditions, right? Now, this was again suspected to be a cyst, and all the myxoid material oozed out. And you can see lot of lymphatic-like channels. Just now, madam showed you cystic spaces filled with fluid, but please look in the solid areas. This was another one which was mistaken for a lymphangioma, and we had lot of cystic spaces, right? Thin-walled spaces, but you could see the spindle cells forming palisades and verrucae bodies. So it's rare to come across a schwannoma showing or mistaken for a lymphangioma. If you had just seen these features, you would have missed this. So maybe if you just see a neck swelling with these, and try and give more bits from the solid areas of that. Now, why do we get these cystic spaces? This is because of accumulation of fluid, particulate matter, debris in the lumina, with the expansion and compression of adjacent Anthony Bay areas, or it may be because of degeneration of septa and coalition of cysts. Now, the simple cyst expansion and coalescence may be related to their propensity to palisade formation. So that is why we get a different type of palisade formation, which is lining the cystic spaces. Now, this case you also saw yesterday was in a salivary gland, which was aspirated as a salivary gland tumor. And this gland, that's what I said, it's a pseudo palisade. The palisade area, this inner part, may undergo necrosis and appear like a cyst. So there is literature which tells you pseudoglandular elements in schwannomas, large cystic spaces, and we have to look out in the wall to identify whether it is a schwannoma. So you get to see again, probably this space will disappear or dissolve and give you a cystic space in a schwannoma. Now, this was what I said. A biphasic synovial sarcoma in a retroperitoneal area would be a DD for this, and you do get glandular spaces in them and a lot of mitotic figures, right? And a gist in that location. But problem is, we may not get to see the glandular elements, but you get to see a lot of spindle cells, right? And in short fascicles, whorled patterns, and you have a doubt, you could do a CD117 to confirm if it is a gist and exclude the possibility of a schwannoma. Right, and this was one of the articles we had done, and because all of these were from one of my postgraduates' dissertation on peripheral nerve sheath tumors, which I'm using today to show you what all we did collect over a span of 4 years. Now, other areas where you can see schwannomas, right? All of you have seen them everywhere. And one of the locations is an intradural extramedullary lesion, could be a schwannoma. And even the low par, you can see the palisades. So you get to see schwannomas in multiple locations. So this patient had luckily a CT done to explain his symptoms. And when they excised it, it was an intradural extramedullary schwannoma. We get to see a palatal nodule in this patient. On excision, you could see the palisades even at the low par, right? So the schwannomas can occur any region of the body. Now, this was a lip swelling, which was suspected to be a salivary gland tumor and removed, but it was a schwannoma. So you see the classical Anthony A areas and Anthony B areas in this case. Now, this was a large tumor again, removed from the thigh, and it had lot of areas disappearing in the center, and the wall showed the solid areas had spindle cells separated by stroma, right, forming whorls at places. And you can see it has started palisading. Because of the large size of the tumor, there was a lot of hemorrhage and hemosiderin latent macrophages. You get to see now the perivascular hyalinization, and xanthomatous cells were also there. So look for the secondary changes. If they are overwhelming, try to find areas which are more cellular to come to a diagnosis of a schwannoma. See the xanthomatous cells. So just this, you might call it a xanthoma, but keep in mind the spindle cells around and look for areas which are more convincing to you, right? So frank xanthomatous areas, because there is lot of hemorrhage, and once the hemorrhage resorbs, you get a lot of foam cells. Now, this is what you would more aptly call an ancient schwannoma. This was a neck swelling which was removed as a lymph node. So schwannomas may not be diagnosed clinically, and they may be removed as other swellings in a patient. So you can see the schwannoma, right? You can see the xanthomatous areas, but now you start getting to see large cells with chromatin smudging, but no mitotic figures, no areas of necrosis. So that is how you identify an ancient schwannoma. Like Madam showed you, a symplastic leiomyoma or an ancient leiomyoma would have all these changes. In addition, it would have lot of nuclear atypia. Now, coming to the cellular schwannoma, which you already saw, right? So in an unexpected area, when you get a spindle cell tumor, which is very cellular, keep in mind a cellular schwannoma could be a differential if you do not find mitotic figures. So search for mitotic figures before you want to call it a sarcoma, or get back to the clinician, ask for details, and sometimes they may not be able to remove in toto. So we may get bits and pieces, and we are very worried if it could be a sarcoma. Now, this was another case, right, where you can see the Verrucay bodies, Anthony A and Anthony B areas, and they were occasional semomatous bodies. So the more number of schwannomas you see, the more smaller features you start identifying. It's your luck that by sampling, I was able to get a semoma body. But they usually say when you find a semoma body in a schwannoma, it could be from a patient with Carney complex, but we were not able to document in this patient. Right, so that was a case one, and it's a frank schwannoma, one of the very common nerve sheath tumors, but with a little twist. You get to have cellular schwannomas and glandular or pseudoglandular elements, right, which are other features you observe when you look at more number of cases, or you're made aware now. So next time you will start looking out for them. Now, coming to case two, this was a 13-year male who had a scrotal swelling and it was excised, right? Definitely it was a skin covered scrotal skin, they thought, and removed this. And cut section showed a lot of nodules. Now, section was taken. So this was the skin, and you find a lesion, right, which appears capsulated and cellular with lot of pink areas in between. Right, look at the nodules. I had tried to give in, and we were able to get some 4 nodules. Right, here again 2 nodules at a higher power. Now, this is what you call a palisade, right? Anthony A areas are the palisades, but when you have 2 palisading areas with the pink area in between, this is a Verrucay body. Now, this is virtually a diagnostic clue for one of the commonest tumors, right? Some uncommon tumors could also show palisades, but Verrucay bodies are usually observed in schwannomas. I often think this represents something like a barcode, where they are palisading like this. And this was the person. Jose Juan Verrucay was an Uruguayan pathologist who first described this Verrucay body. And this is what we call nuclear palisades. And this is a common sight I'm finding in Ireland here. Everybody's house has a compound which is made of wooden poles, and they look like palisades. And being a very cold country, you can see a lot of apples already in November in the trees in the garden. So Verrucate body is defined as stacked arrangements of elongated palisade nuclei alternating with anuclear zones containing cellular processes. Now, these bodies are typically found in the more densely packed Anthony A areas rather than in the loose microcystic Anthony B areas. So you don't find verrucate bodies in Anthony B areas. You will find them in the compactly arranged areas, right? So this is a classical verrucate body. Now, as I told you, there are various conditions where you get to see palisades, but the commonest ones are the peripheral nerve sheath tumors like schwannomas, palisaded encapsulated neuroma, rarely in a neurofibroma and MPNST. There are some soft tissue tumors, right, like leiomyoma, angioleiomyoma, spindle cell lipoma, and DFSPs, and other epithelial neoplasms. I have seen them in basal cell carcinomas, but palisades are more plump nuclei and do not have the eosinophilic processes. So palisades and pseudo palisades, neuropathology for the neuroradiologist. So very nice article which I could find these the entities where you get palisades. So now what do you think was our patient having, right? He had multiple nodules. He had verrucate bodies. There were palisades and a young male patient, right? So any idea what this could have been? Any takers?
Graduates at least
Anybody?
attempt postgraduate.
Yes, ma. Anyone? No, it was already there for you. You just had to make a guess. So you saw nodules. That was the giveaway to this. It was a plexiform schwannoma. Right. So it's a type of schwannoma where you find a lot of nodules or multinodular, right? One of the earliest descriptions was in American Journal of Surgical Pathology, where they saw these nodules. Now, these nodules can be grossly visible or they may not be grossly visible, but you can see on microscopy, right? You get to see articles, right, which was especially in the head and neck region. They had emphasized on this plexiform schwannoma. They have all other differential diagnoses with it. It was multinodular plexiform case, right? Encapsulation was there. Now, the feature, why I'm asking you to identify it, the syndromic association may be none, right? But, or they may more commonly seen in none is usually common. The next common condition you see is in neurofibromatosis 2 or schwannomatosis, right? So it's a marker for neurofibroma or neurofibromatosis 2, not your NF1. Apart from plexiform schwannomas, you also have the term plexiform neurofibroma, right? So this was how a normal nerve looks to us, right? You have multiple cut sections of nerves, right? This is the perineurium, this is the endoneurium, this is the epineurium. Now, the endoneurium is here. The perineurium is highlighted by EMA. So they could just look like cut sections. So you might not mistake, it's a small biopsy and then you think it's just a nerve. No, this is a plexiform schwannoma where you have multiple nodules, whereas the endoneurium now is replaced by the schwannomatous elements, right? You can see palisades, you can see the verrucate bodies inside them. So the term plexiform, although it's plexiform, is unassociated with NF1, I told you. It may occur in NF2 as well as in schwannomatosis. Now, clinical implication, it must be distinguished from plexiform neuroma, neurofibroma, and MPNST. Less important differential diagnosis. It could just be a conventional schwannoma with intratumoral nodularity. So you see extensive areas of schwannoma and maybe an occasional nodularity, right? This was a schwannoma with an intratumoral nodularity. So you need to see more nodules to identify it as a plexiform schwannoma. Now this is where you apply the term plexiform, right? There are multiple nodules. Probably this was intertwining, and when we cut across, we get to see them as plexiform. So can you name any other areas where you see plexiform or the prefix plexiform is added? I already told you schwannoma and a neurofibroma. Yes, any others you have heard of? right? Now, more and more cases being published, we are able to document with photographs, right? And that is why we are getting to hear some more areas where this term plexiform is used, right? There's a plexiform xanthoma, plexiform nerve sheath myxoma, fibrohistiocyte. So virtually it is a gross appearance, but sometimes we pick up the plexiform nature on microscopy. Plexiform granular cell tumor, right? So this was a plexiform neurofibroma patient. She had a huge unequal size of a gluteal region, and for which they had excised, and this was a plexiform neurofibroma. So now you can understand, when you cut across, you get to see nodules, right? And then this was another plexiform neurofibroma that I have seen. And as I told you, see, we may not appreciate grossly, but they were still there. But microscopy showed us the numerous nodules, right, which was composed of Anthony B areas in this patient. And there were a lot of mixtures in this area. So this was a plexiform neurofibroma. And this is a patient from a plexiform xanthoma. Multiple nodules were there, right? The patient had more areas, and was a young patient who had hyperlipidemia. And so we had lot of xanthoma and cholesterol clefts, right? So it was prominent xanthomatization associated with hyperlipidemia. Now, this was from an article, plexiform fibrohistiocytic tumor. So that's why I told you more number of literature search would give you this term of plexiform being used now. Nerve sheath myxomas can have multiple nodular appearance, and this was a nerve sheath myxoma. So it is not described under nerve sheath tumors, right? It is a non-neural nerve sheath tumor. We'll go on to the next case, which was a 30-year male and a nasal obstruction, for which an ENT surgeon had done the biopsy. Yes, this is definitely from the nasal passage, was lined by pseudostratified cylindrical columnar epithelium. There was a diffuse lesion here, and this lesion was composed of spindle cells, and characteristically what you are often looking for, a wavy nuclei, right? And other areas, it depends on how these wavy cells are cut across. You may tend to see a lot of round cells, but there is a lot of unsettled appearance, lot of cells going in every direction, right? With a myxoid, a loose stroma in between, but it was difficult to show any palisades, right? So what you think this could probably be a? Yes. And in this scenario of today, I'm sure you would have to think of a neurofibroma. Not that it is rare in sinonasal tracts. They say it's extremely rare. And if in an NF1 related neurofibromas, patients tend to be younger with a male predominance. It's a generally submucosal paucicellular lesion composed of spindle cells with wavy dark staining nuclei, scanty cytoplasm. You get to see sometimes or most often a background of wavy collagen fibers, myxoid stroma, and mast cells. Neurofibromas are very notorious to demonstrate a lot of mast cells. Right now, this is another neurofibroma from a neck region. Virtually, I think this is true to what they call it as a carrot shredded appearance of a neurofibroma, right? The nuclei are also elongated. You see a lot of eosinophilic areas which look like carrot shreds. You know, this is one of the classical descriptions we see in a neurofibroma. And other areas, so peripheral nerve sheath tumors in general, right, being schwannomas and neurofibromas are a cause of nasal obstruction. But on the overall, they are relatively uncommon, but many otolaryngologists will encounter them. They develop from cranial and spinal nerve roots and from peripheral nerves in the nasal cavity. They say if 25 to 44% occur in the head and neck region, right? In general, when you look at peripheral nerve sheath tumors, though they are rare in the nasal and sinonasal tracts, in the head and neck region, they are quite common. But our problem is many tumors are resected piecemeal, and it may be difficult to determine if the lesion is encapsulated. Between schwannoma and neurofibroma, we do have histological appearances that help us, but in a small biopsy or curettage specimen, we would just be wording it out as peripheral nerve sheath tumor. Now, this is because of overlapping histological features. Now, malignant change often develops in neurofibromas, but not in neurilemomas. Now, treatment in the form of gross surgical removal is indicated in most nerve tumors for an histological diagnosis and for relief of symptoms. So they are common in the head and neck region, right? So you may get them from an otolaryngologist. My first case was from a general surgeon. The second was from a neurologist, because the patient had gone, because it was a testicular swelling, they thought, and they had gone to meet a neurologist. The third case was from an otolaryngologist. And we move on to the fourth case, which was a 26-year male and swelling in the upper eyelid. As the location suggests, this came to me from an ophthalmologist or an ophthalmic oncosurgeon. Right, so the patient had noticed the drooping of the eyelid, and they examined and thought there was a swelling in the upper eyelid, and this was the lesion that was excised. This was the conjunctival side. The skin was on the other side, very little skin. For cosmetic reason, they cannot remove a lot more of the skin. Right, this was the post-surgical picture of the patient. Now, microscopically, you had the lining here, right, which was the conjunctival lining, lot of nodules, and being in that location, they were not able to spare the lacrimal gland. So we got a portion or lobule of the lacrimal gland. Now, this was the loose myxoid areas, and as I was trying to tell you, these are the mast cells. If your sections are thin and well-preserved tissue, you get to see a lot of mast cells. You can do a Toledan blue stain and pick up the mast cells. So what do you think this case was now? Right, this came from an ophthalmologist. Yes, anybody has a guess? So you got to see a lot of nodules, right? So this should automatically be a
Plexiform neurofibroma.
Yes, plexiform neurofibroma. No, it takes time convincing the clinician. He was not expecting me to make a diagnosis of a plexiform neurofibroma. This is another case, but now I classically had this skin marker, neurocutaneous marker in this patient, and more of these, right? So what are these? Kephele spots, right? So you have now two features, and because of a cosmetic reason, the patient wanted it to be excised. You won't believe this came to me from an oral surgeon who does a lot of plastic surgery. So this was, they had identified the kephole spots. So they had labeled her as an NF1 patient, but because she was insistent for cosmetic purposes, they had done an excision, and these were the nodules that we could see. This was a plexiform neurofibroma patient. So, right, so when you look at neurofibromas and the variants of it, especially when you see a plexiform neurofibroma, then you have to exclude the patient has neurofibromatosis or no. So I'll show you some of the cases we have seen of neurofibromatosis. This patient had multiple nodules, and because this was in the beard area, he was insistent, and they had excised this, and this was a neurofibroma in the dermis. You can see the entrapped hair shafts also in this patient. Now, this patient had multiple nodules, kephole spots. They had excised one of the nodules, and a lot of mast cells were seen, right? So this was multiple neurofibromas in this patient. Again, a neurofibroma NF1 patient. Sometimes they may just start with solitary neurofibromas, but they would have written in the history to you that patient has multiple nodules. So you can see the various appearances of it, right? But it still looks homogeneous. and you get to see lot of spindle cells with wavy nuclei, lot of myxoid stroma in between, or very cellular areas, right, where there are no myxoid areas in between. Now, this patient had multiple nodules and was referred to a dermatologist, right? They went ahead and did a punch biopsy, suspecting it to be a case of leprosy. We are in an endemic zone in our place, and this was the nodule, right? They had done a biopsy. Now look at this, it's not appearing very well capsulated, and there were a lot of spindle cells which had a very loose foamy cytoplasm, and mast cells were there. So even we were worried if we were looking at a leprosy. So I did a FRCPath stain. Now histologically this favored more a case of a histioid leprosy because there were spindle cells. But strikingly, the FRCPath did not show any bacilli, but FRCPath picks up even the mast cells, right? So in a leprosy case, when you stain for bacilli, make an attempt to search for the mast cells. So this was a case of neurofibromatosis, but this slide was a single one. Then I had to get back to the patient, and the patient came back, and we saw multiple painless nodules were present, and we gave the diagnosis of NF1 or neurofibromatosis, right? So I'm showing you that my lesions are coming from a lot of disciplines, right from surgery to dermatology. Now this was another mother and son who had operated for this plexiform neurofibroma at his elbow, which was giving a lot of hindrance to movements in his elbow joint, right? So you can see the Kephole spots and the neurofibroma here, loose myxoid areas, then the spindle wavy nuclei, and a lot of mast cells. So this was a familial. So you saw both mother and son having one. So more than one family member having it, then you think of neurofibromatosis 1. And these are all the cases I showed you earlier, plexiform neurofibromas, right, with nodules and the plexiform nature. Now, there's another feature that you also can see in neurofibromatosis patients, and that is a diffuse neurofibroma. I can't show you the nodules, right? It looks so fleshy, and whole area beneath the skin was stretched, and we had this diffuse neurofibroma occurring. Sometimes you can also find melanin pigment. So this was the pigmented area which we could find, right? And in diffuse neurofibromas, you often tend to see Wegener-Meissner bodies, which are looking very similar to the touch corpuscles we can find sometimes when we take biopsies, which are quite deep in a dermal lesion, right? So you can see the entrapment of the adipose tissue, the adnexal structures, because they are usually not capsulated. Another diffuse neurofibroma, right? Large lumps are removed in these people, and you can get melanin pigment. I have seen over some 10 cases of diffuse neurofibroma in the last 25 to 26 years in the place where I worked earlier, that is JJM Medical College in Davangere. Now, another feature that characterizes neurofibromatosis is they may have malignant peripheral nerve sheath tumors. So much so, making a diagnosis of MPNST in a non-NF1 setting is often not accepted, right? You might have to prove it with immunohistochemistry or exclude other tumors before you call it MPNST. But in the setup of NF or NF1, then the diagnosis is more straightforward. You get large areas of necrosis, numerous mitosis, right? Sudden increase in size by the history, and then a very cellular tumor, which is spindled. Then you think of a malignant peripheral nerve sheath tumor. Whereas NF2, I already showed you, is a plexiform schwannoma. So in our cases of NF1, we had one of more neurofibromas, either which were solitary, plexiform, diffuse, and we had 3 patients who had malignant peripheral nerve sheath tumor. And they had 6 or more Kephole spots, a first degree relative with multiple neurofibromas. With markers of NF2 was a plexiform schwannoma in a young male patient in our study, right? So neurofibromatosis is an inherited disorder characterized predominantly by multiple neurofibromas. These show features not commonly observed in their sporadic counterparts, right? We might see melanin, we might see diffuse neurofibromas, we see plexiform neurofibromas. The young age at presentation or a clinical diagnosis of sarcoma, whereas the histology of a neurofibroma could serve as a marker for unrecognized cases of neurofibromatosis. The clinician may not be suspecting, but you find a neurofibroma at a young age, or because they think it has suddenly grown, and a clinical diagnosis of sarcoma. Now, correct diagnosis relies mainly on histological findings and IHC profile to confirm neurofibromatosis. But if they are multiple and the morphology is characteristic, we seldom resort to doing an IHC. Now, this is the mnemonic which usually goes with NF1. Chase band clones, C for Kefferlet spots, B for associated bony abnormalities, low for L, Lish nodules, optic glioma, axillary inguinal freckling. More than one neurofibroma or even one plexiform neurofibroma is a pointer for NF1. S is for sister or a first degree relative with NF1 features, right? So this neurofibromas and fibromatosis we did publish in this International Journal of Clinical and Diagnostic Pathology. Right. Now, I showed you cases that has come from far and wide. So it's usually an interdisciplinary approach and diagnosis that needs to be made and a therapeutic challenge. Now, why I'm telling you this, there are chances that the new nerve sheath tumor that we are seeing has been misdiagnosed, right? It might be mistaken for a lymph node depending on the location. They have thought of a sarcoma. And if it's an intramedullary or extramedullary lesion, they would have thought of the cervical spine syndrome, lumbar spine syndrome, and others. So this study documented a misdiagnosis. And if it's misdiagnosed, there are also chances of mistreatment. They're either undertreated or wrong surgical treatment has been given to them. So it's benign peripheral nerve sheath tumors are rare lesions of ectodermal origin associated with peripheral nerve structures, but the symptoms may be heterogeneous, complicating the diagnosis. Now, even the management concepts vary. Some of them do a wide excision, some of them do only a part excision because it's so big, right? In some cases, the initial misdiagnosis leads to mistreatment, resulting in severe functional deficits and chronic pain syndromes. If it's partially excised, I believe they do have a lot of pain persisting in them. Now, the clinical presentation includes asymptomatic palpable lesions or painful palpable lesions, and sometimes even the accompanying neurological deficits. But the most common ones are schwannomas and neurofibromas, as I showed you. And these could present with local swelling, motor deficits, hypoesthesia if it's compressing the nerve, right? So there might be a loss of function, right? Or pain because of compressing the unaffected nerve fascicles. Now, what are the four main causes resulting in misdiagnosis of peripheral nerve sheath tumors? One is because of variation in different symptoms and failure to recognize them as nerve sheath tumors. Secondly, presentation is difficult or they may be similar across various organs or other common diseases. And the third cause for misdiagnosis is they occur in every region of the body. From head to toe, you can get a peripheral nerve sheath tumor. Lastly, in any medical system, I feel it's the general practitioners whom patients go first. Either it's a physician or a surgeon. They are the first ones who are looking at these lesions. Now, they act as gatekeepers. It depends on them to whom they refer the patients for a further treatment plan. So they are virtually doing a gatekeeper function. And that is why you see me showing you plenty of cases which have come across from general surgeons to anyone. Most often, I feel it's the general surgeons who look at solitary cases of nerve sheath tumors. Patient has a nodule, they're very worried, so they go to a surgeon or they go to a physician who recommends them to a surgeon, and that is how we get to see these lesions. And in a primary care, secondary, or a tertiary care, we often forget to remember or remind ourselves that this could be a nerve sheath tumor. And in our enthusiasm, we may jump to make some other diagnosis, but please remember, nerve sheath tumors are one of the common soft tissue tumors. Then all the huge new lines or cases that we are hearing about. And as pathologists, I'm sure you all want to know, what does the WHO think about this? So 2020, the soft tissue and bone tumors have listed the peripheral nerve sheath tumors as schwannomas, neurofibromas, and various other entities under peripheral nerve sheath tumors. Now, there are subclassifications under them. Schwannoma, we saw an ancient, cellular, and a plexiform schwannoma, but the other entities are quite rare to see. Now, in neurofibromas, like yesterday he was telling us, if we have not worked it up, we just write NOS. But if we can identify ancient, cellular, or atypical neurofibromas and plexiform neurofibromas, and as pathologists, we are interested in splitting the cases, and we have got lots more being listed under the peripheral nerve sheath tumors. So perineurioma, granular cell tumor, and a whole lot of entities are listed. And I did show you a nerve sheath myxoma already. Now we'll go on to the next case, right? 28-year female, and the clinical diagnosis was a lipoma, right? I'm sure all of you would agree, a pedunculated soft lesion. Before excision, the clinician thought of a lipoma. And on cut section, it was homogeneous, very soft lesion. So I have no pointers here to even think or of some other tumor, but I'm sure we would not make a diagnosis of lipoma on gross appearance. Now, these were the sections. You had the skin and a soft lesion down here, right? Not very well demarcated, and lot of spindle cells in short fascicles going in all directions. More pictures, right? It was, and as I told you, it was a lot of myxoid or gelatinous areas because it was soft, and we had a lot of muck of the hematoxylin sitting on them. More pictures you can see, right? Non-specific, non-descriptive spindle cells with eosinophilic cytoplasm tapering down, but I'm not able to show you any palisades, right? Verrucae bodies or alternating Anthony A and Anthony B areas. This is another case which was excised in toto, right? They were able to shell it out. Something is different here than what I showed you. There was all this pink areas, and there were these, swirlings around these areas, and entrapment of adnexal structures. Every day we came back, we were thinking of a different diagnosis. Another case, right? Very soft, fleshy, and you find these spindle cells going around. So, I was always wondering, I think of it, the previous day, I thought it's a neurofibroma. I come back the next day and I keep thinking, is it a schwannoma? And then we pass it around in the department. Somebody wanted to call it a fibroma. They said, no, we just think of fibromas. Why are we cracking our heads? I really didn't think this was fibromas. There was some cells which were going around, and we were, this was much late in 2015. Our problem started with this case in 2008, and then I'd been wondering what I need to do to call them. And because I had already seen in 2008, I was a little more confident in thinking this is another 2008 case. Now look at this. Somebody told me, ma'am, it just looks like a ball of wool. Everywhere it's going, everywhere you're showing us cells. But I still didn't feel like calling it a fibroma. These days fibroma is a dumping diagnosis. We have to find out a particular name to this. And that was when I stumbled across this perineurioma. It's a neoplastic spectrum of perineurial cells, which could be an intraneural or an extraneural. Often the extraneural ones are the more commonest ones. You have a soft tissue sclerosing and a reticular variant. Now, this histological appearance coincides with various benign and malignant soft tissue spindle cell tumor. So you're wording it out as spindle cell tumor, probably a nerve sheath tumor. Now, the gold standard to identify perineural cells used to be electron microscopy, but with the advent of IHC, EMA is strongly positive in a perineurioma, right? You can also do a GLUT1 or a Claudin-1. They have become constant markers of differentiation of perineural cells. Coming back to this picture, is incomplete. Any nerve sheath tumor talk, right? This is a normal nerve sheath cut across, and you see the perineural cells are highlighted by EMA stain, right? We did an EMA stain. It was strongly positive, and an inbuilt control IO cells of the epidermis, right? Epithelial membrane antigen is positive there. And this is how a perineurioma. They are S100 negative, epithelial membrane antigen positive, right? So by 2007, it had started gaining importance. It's a distinctive, under-recognized peripheral nerve sheath neoplasm. Depending on the variant, you have lots of differential diagnosis. You can look up this article in Archives of Pathology, Lab Medicine. All of them, even schwannoma neurofibroma is a DD in it. Fibromatosis is a DD. But the EMA positivity clinches the diagnosis. And sclerosing, because lots more sclerosis, a fibroma is of tendon sheath. Reticular ones are more often mistaken for a myxoid tumor, right? Intraneural perineurioma is quite rare. So this was a perineurioma. And they say the embryonic mesenchymal cells either differentiate to a fibroblast, and if it is towards a perineurial cells, they are EMA positive, S100 negative, whereas Schwann cells are S100 positive, EMA negative, and intraneural soft tissue ones, right, which is sclerosing, and the reticular variant of perineurioma. There's a malignant perineurioma also, but they are quite rare to be diagnosed. What was this as a spotter, if I give it to you? Right? This was from the lower leg, they had excised it, right? It doesn't appear to be very well capsulated. And this is the skin. You have large cells here. So how is the cytoplasm of these cells?
Granular cell tumor.
Yes, right. So this was a granular cell tumor, another of the peripheral nerve sheath tumors now listed in WHO. So this is your dream come true and often an exam slide. Now it's a tumor showing neuroectodermal differentiation composed of epithelioid to polygonal cells with copious distinctly granular cytoplasm. You're not supposed to be calling it granular schwannoma, granular cell nerve sheath tumor anymore, or granular cell myoblastoma. The essential feature for it is abundant eosinophilic granular cytoplasm in epithelioid to polygonal cells. They're positive for S100 and SOX10 by IHC. Now, I believe the loss of function of these two or mutation of these two genes are supposed to be pathognomonic. I have very little experience in your molecular testing. So morphology wise, it was a granular cell tumor, right? Another of the peripheral nerve sheath tumors listed in WHO. We move on to case 6. This was a 40-year female, right hand dorsum swelling. They had excised this and we cut it into 3 bits. I'm sure all of us would have jumped, would have been happy to say this is a nerve sheath tumor, myxoid, gelatinous, soft, and I would have thought of a nerve sheath tumor even on gross before I go into my slides. And this was the sections. I'm sure all of you even at this part would tell me, ma'am, this is Anthony areas. There is palisades. I can see Verruca bodies, right? So you would have been happy to call it a schwannoma. There were areas where I'm trying to show you now, carrot shreds. They're just looking like carrot shredded appearance. Multiple other areas now, right? I did show you palisades, right? There are palisades here, and in the other areas there are, if I block this, and I just show you this, or I just show you this, I'm sure you would have thought of a neurofibroma. But some areas, I make a search again, you do get palisades and a verrucate body. Right, I'm on a slippery slope now. Right, if I vote for it, somebody wants a schwannoma, somebody wants a neurofibroma. Now WHO has decided to clear this ambiguity. They are hybrid nerve sheath tumors, right? You have combined features of more than one conventional type. There can be a schwannoma neurofibroma, perineurioma neurofibroma, perineurioma schwannoma, making our life miserable now, right? The combinations can be there, but they usually say hybrid neurofibroma schwannoma is strongly associated with NF1, NF2, and schwannomatosis, whereas neurofibroma and perineurioma is associated with NF1. Schwannoma perineurioma combination occurs sporadically. So don't worry, like you might vote for a neurofibroma, somebody is calling it a schwannoma, right? You also then suggest that this could be a hybrid nerve sheath tumor. And both of them are treated similarly, but just for a clinical or say pathological curiosity and your biopsy reviews or slide seminars, you get to see these hybrid nerve sheath tumors. Right, with that, let's go to last but one case. It's a 56 female. Papilloma was the clinical diagnosis. Right, this was the clinical diagnosis was papilloma. Now, the section showed a nodule here, a lot of spindle cells going in all the directions. It was strongly X100 positive. Without this S100, I think here we would have called it leiomyoma, then fibroma, right? Anything but a nerve sheath tumor. But once you did an S100, it was strongly positive. So a solitary lesion like this sometimes, where you're not able to swear between or even think of a neurofibroma and a schwannoma, would probably be a palisaded, encapsulated, solitary circumscribed neuroma, right? This is listed in WHO. It's a cutaneous nodular proliferation of nerve fibers with Schwann cells predominating over the axons. There's a strong predilection for the face. It's a slow growth over many years and is unrelated to trauma. So somebody might get it excised because it's been there for a long time, and it might be in a cosmetically located location, especially the face, and they would not like to have it and it gets excised, right? So it's a solitary circumscribed neuroma, and we did come across, at least I have seen another 2 more cases after this, and made a diagnosis of solitary circumscribed neuroma. Now, this is how WHO shows you. It's strongly S100 positive, and NFP is variable expression. EMA, when you do, only stains the perineurial cells in the margin. So an S100 and an EMA would be a good bet in peripheral nerve sheath tumors to exclude or confirm most of the common diagnoses. Now, case 8 was from a 16-year male who had a scalp swelling. Again, I'm telling you, this was a scalp. So he had gone to a dermatologist who decided to get it widely excised. And this was the scalp swelling. This was the subcutaneous area, right? And he was a 16-year male. And probably, I think he was wearing a cap and camouflaging it. But when we got sections, I didn't have anything. I was really wondering what was I looking at. But deep down, I found these areas of calcification. It was a scalp swelling, and they virtually looked like samoma bodies. Then I had to get back to sitting and seeing it 3 days, 4 days. It was not. I said, should I just call it a fibroma? But it was not any other adnexal tumors. But carefully, when I started seeing in between those fibrous areas, you have thin cells going. Very thin spindle cells were there. And that was when it suddenly flashed to me, I'm missing something. Why am I seeing this calcifications? And we later got an EMA done, which highlighted this No, those spindle cells in between the fibrous stroma. So any takers for it? It was a midline scalp swelling.
Meningioma.
Yes, WHO lists this out now. In the nerve sheath tumors, ectopic meningioma or meningothelial hamartoma, right, where we have meningothelial cells entirely outside the intracranial and intraspinal cavities. Now, this was non-neoplastic arachnoid cells, which were going in between, and arachnoid cells are highlighted by doing an EMA stain. No, much elder adult, we would have thought of it, but this patient was 16 years and just a scalp nodule. And because of the Samoma bodies, I was able to pick up this meningothelial hamartoma. In both, a CNS connection must be excluded. These are rarities, but once across, you come across one or two. And if you have seen a meningocele, meningomyelocele in a pediatric case, then you will learn to pick up these small arachnoid cells proliferating in the fibrous tissue around. Usually they say it's a midline swelling and give us in a child, and that is when we suspect a meningocele, right? And if you have the spinal matter, it would become a meningomyelocele. So this was a meningothelial hamartoma in the line of closure where the arachnoid cells had got trapped, and you can get calcifications associated with arachnoid cells. Now, last case, I think I made a mistake. There was one more after the 7. It's a 16-year female, swelling forearm since 5 years. Look at the swelling, huge one. And when we cut across, there were large cystic spaces and solid areas. Now, we gave sections, right? You see the skin which was attached to it, a very cellular area, which ranged from spindle cells to round cells, right? The other areas which were less cellular than this showed whirling, a lot of spindle cells. My worry was, what am I looking at it? A spindle cell tumor, right? And the patient said it was there since 5 years because of the forearm swelling. And as she was becoming conscious about it, they came for an excision. We did not have an aspirate done then, right? And these were the features that, and occasional mitotic figures was what was striking to me. And just in the same time, we were doing this nerve sheath tumor study, and everybody was saying, ma'am, you've started smelling them. I said, no, because we are so much invested in it, probably I'm thinking of it. But let's ask the patient or the clinician if the patient had some more nodules. And then we got the history that the patient had 2 more nodules elsewhere, and they were also present from a long time. That's why I said the history becomes very important to us. Now, we went ahead and got an S100 done, right? And to our surprise, it was strongly positive, right? Even in the cellular areas, the less cellular areas also. Now, this was a nightmare. Now, what do you think I should be calling it then? Right? I had started seeing mitotic figures, but they were typical mitotic figures. She had 3 nodules. And so my thought was for a malignant peripheral nerve sheath tumor. But the atypia was so less, there were no much necrosis. There was that cystic change had happened. I think it had outgrown its blood supply. And I started searching literature. Now, then was where we landed with low-grade malignant peripheral nerve sheath tumors, which showed diffuse and intense staining for S100 protein. So when I tell you it was a diffuse and intense staining, but I'm still calling it a malignant peripheral nerve sheath tumor, right? It's a contradiction. Malignant peripheral nerve sheath tumors are supposed to be having very patchy and focal staining. You don't get large areas with stain for it when you turns it into a malignant tumor. But there is a gray zone between just a nerve sheath tumor and a malignant. These low-grade ones can still have a lot of S100 positivity. It is thought that to arise in neurofibromas, as in our case, histological criteria that enables a positive diagnosis is presence of hypercellularity, nuclear enlargement, mitosis, and hyperchromasia, right? But the S100 strong positivity should make you put it into a low-grade MPNST. And this is the article which really helped me to clinch this diagnosis: low-grade malignant peripheral nerve sheath tumor, varied cytology and histological patterns. But when it is a malignant peripheral nerve sheath tumor, as I had showed this to you earlier, there were multiple areas of necrosis. A patient had a neurofibroma elsewhere. There were a lot more mitotic figures. Some of them were atypical. There was melanin present. So malignant peripheral nerve sheath tumor in a neurofibromatosis setup is more easier to make as a diagnosis. And we did have in a plexiform neurofibroma a lot of mitosis. So we had called this a malignancy in plexiform neurofibroma. In another case of neurofibroma patient, we did find large rhabdomyoblast. And so this was a malignant triton tumor. Now, these are really old cases. In recent times, I've hardly come across any of these cases. So differentiating between benign and malignant peripheral nerve sheath neoplasms can be challenging, right? The features favoring malignancy include increased size, rapid growth, infiltrative border, internal necrosis, increased vascularity, frequent mitotic activity with atypical mitosis. They say perivascular hypercellularity, tumor herniation into vascular lumens, necrosis is often more frequently associated with MPNST than a cellular schwannomas. But these days, just that would not be enough. Everybody wants another next line of investigation, and that would be an IHC. But how much is IHC going to help to diagnose peripheral nerve sheath tumor? Often I've heard people who do a lot of IHC that MPNST is a diagnosis of exclusion, right? You have a cellular spindle cell tumor, you exclude or you test for all the other common ones before you make a diagnosis of MPNST, because only less than 50% of tumors are positive for S100, less than 70% are positive for SOX10, and GFAP in only 20 to 30% of tumors. As I told you, the S100 and SOX10 are very patchy and focal. You may not even find in the block that you have sent thinking it's a malignant peripheral nerve sheath tumor, because diffuse staining for X100 or SOX10 is not usually compatible with diagnosis of conventional MPNST. So this is the pitfall in doing IHC for giving a diagnosis of MPNST. So they try to exclude synovial sarcoma, leiomyosarcoma, other spindle cell tumors before rendering a diagnosis of MPNST. Now, these days, they say a complete loss of staining for H3K27ME3 may be helpful in the diagnosis of MPNST, more so in the diagnosis of high-grade tumors. Now, there is exceptions always to any rule. Unlike conventional MPNST, epithelioid MPNST shows strong and diffuse staining for S100 and SOX10 in the absence of melanoma markers, right? If epithelioid tumor, you often also think of melanoma. So if it stains diffusely for S100 and SOX10, then you think of epithelioid MPNST. But the melanoma markers should be present for your epithelioid melanomas. Now, in this setup of epithelioid tumors, let me show you a case. This was a very recent case which I got for a referral from one of my friends. This swelling, I believe, was present on the nasal bridge, and it was full of epithelioid cells. You know, we went around with all differentials for an epithelioid tumor, and he said, no, let me do IHC. S100 was strongly positive, GFAP was positive. So we narrowed down the diagnosis to an epithelioid schwannoma. No, I had not shown you a case earlier. This is an epithelioid schwannoma. So epithelioid tumors, a differential would be an epithelioid schwannoma. And these tumors would be S100 strongly positive, positive for GFAP also. Right, so epithelioid schwannoma display unique histological features, and they look lot of epithelioid cells morphology. And one of the differentials we had was a myoepithelioma here, and he said P53 was negative, and even P63 was negative. And that's how they excluded a myoepithelioma. And smooth muscle actin was negative, right? So the diagnosis of myoepithelioma was excluded. Now, so why are we looking at these neurogenic tumors? The main reason is for its risk association. Especially you find pediatric journals telling you a lot. So when you look at them at a younger age, localized cutaneous neurofibromas has no risk or very minimal risk for malignant transformation. Even diffuse neurofibromas have minimal risk for transformation. Localized intraneural fibromas might have an increased risk. Plexiform neurofibromas have a significant risk of malignant transformation, but they are 98% of the time associated with NF1. Massive soft tissue neurofibromas are pathognomonic for NF1, but they are not associated with risk transformation. Now, the same article also looked at schwannomas, right? So you have cellular schwannomas, plexiform schwannomas. Younger the age, right, then becomes Arwari. And an entity called melanotic schwannomas was described by them, right? There's a lot of epithelioid schwann cells. They contain melanosomes, HMB45, melan, and that's why it was called a melanotic schwannoma. And with semomatous calcifications. That was what I showed you a case earlier, but I had only one semoma body in that, and a melanotic schwannoma. But the new WHO removes this melanocytic schwannoma now. They say all of them are malignant melanotic nerve sheath tumors, or MMNSTS is a new addition to the 2020 classification of nerve sheath tumors, right? So you don't call anymore as melanocytic schwannoma. You're supposed to use the term malignant melanotic nerve sheath tumors. There's no benign counterpart to it. But there's an histological overlap with metastatic melanomas, primary leptomeningeal melanocytic neoplasms, melanocytomas, or say nevi, and conventional schwannomas, right? So this is the new addition in the WHO classification of nerve sheath tumors, where you have the term MMNST, or malignant melanotic nerve sheath tumors, right? So I hope I didn't unsettle your nerves, right? So you can, after this, no, all of you, I think it's raining here and cold. So either go for a walk or listen to some music. Don't be worried. No, there's lots in everyday plate. We can't teach you everything. We can only share our experience with you, right? And especially if you are catering to more general surgeon, and anywhere, I'm showing you all cases. I've also found an orthopedic surgeon who was insistent, and virtually the patient had a pseudo arthrosis of his tibia and fibula, and he was not ready to accept my diagnosis of neurofibromatosis. He said, no, madam, our patient has some orthopedic problem. So you need, as I heard the doctor from Singapore speak, we are clinicians also. So please use all your skills to convince the surgeon who sent the tissue to you, right? And I wish you all the luck. And I'm not scaring you. This has taken me 30 years to put it across. So don't worry. You will also see one or the other case down the lane, or at least it should spark your interest to finding out what am I seeing, And again, I wish to thank Dr. Vijaya and her team. And you can contact me anytime on chaturakr@gmail.com and share your cases. Honestly, I tell you, some of them are from my postgraduates over the last 20 years who have always shared their cases with me because of my interest in nerve sheath tumors. Thank you, Vijaya, once again. I don't know how to say thanks again.
Thank you so
Thank
much,
you.
ma'am. It was such a wonderful session
Yes.
that I haven't left from the institute. I'm still sitting in the institute. It's
No.
5
I
o'clock.
often think we need to show students cases that we are commonly seeing, because the unusual ones are really unusual. And even they may never come across them, but they get worried when they see, and everybody says, ma'am, before a fibroma, we think again now whether it's a nerve sheath tumor. And that is why I
was
insisted
exactly
on this for
thinking the
you.
same. In the exam, when we had a PG, my final PG exam, very coolly we wrote a diagnosis of melanotic schwannoma, which was accepted at that time. But now I
That
think
time.
definitely. Definitely.
No,
So,
it's not accepted, I believe.
yeah,
They don't
anymore.
want us
Exactly.
to stay there, and we have to make a suggestion that this is a malignant melanocytic Schwann cell tumors.
But in the
Yes,
exam,
that
it
is
was
the new
accepted because
concept.
they also thought like that. But
Yes,
now
they also
everything's
would know
changed.
about it.
Yeah,
So no
exactly. So
problem.
it
It's
was
always for discussion. I don't think we should mark the student wrong, when they have
definitely.
also come out with something which is just in the formation. I'm sure another 10 years down the lane, I'm going to find PGs talking and showing me, or colleagues, there'll be colleagues then, showing me all IHCs and all markers for this.
Exactly.
And as he said, 60% of our diagnosis is with morphology. So please do pay attention if you want to jump into the IHC field, right? Otherwise, you'll go haywire and make a diagnosis of anything and everything because you've forgotten what the morphology helped you for. Thank you.
Thank you, ma'am. Thank you so much. Happy Diwali, ma'am, in
Thank you, ma.
Ireland. Enjoy.
Happy Diwali to all of you also. Yes. Thank you, ma.
Jane,
Yes, ma'am.
can we wind up?
Yes, ma'am. Thank you, ma'am. Thank you, dear delegates. I'd just like to show ma'am our token of appreciation, ma'am. Just a small certificate.
Yes, ma.
Thank you so much,
Sure,
ma'am.
thank you. And please send it to our email also, Vijaya, the certificates. Yes, ma. Thank you. Thanks a lot. Have a nice day. Thank you.
Thank you.
Dear delegates, for being with us through this 2-day journey. Have a nice weekend.
Yeah, it's a big thanks from the organizing chairperson to all the delegates and the speakers for having spent their time and the effort. Of course, it was a huge academic session for the past 2 days. So many learning points. I hope PGs will definitely would have enjoyed it and taken all take-home messages and will concentrate on how to report rather than even passing the exam. More than that is the reporting actually. Thank you all. Thank you so much.